Tisnett plot which is normal. And it should come within these two lines. So if you look at this printout, you can see there is a yellow exclamation mark in the infratemporal aspect, which you can appreciate here also there is a thinning of the neuroretinal rim. So that means there is a borderline thinning there. And you also have a stereometric analysis where the actual values of disc area, cup area, rim area, everything is given, and the normal range is also given. If you look at this picture, you can see definitely there is an increase in the cup disc ratio. And if you see here, you can see a lot of sectors are actually marked in red crosses. That means that is definitely glaucomatous. And in the bar diagram chart also, you can see the corresponding to those sectors, you can see the red crosses. Now coming to the scanning laser polarimetry, the principle it is based on the birefringence property of the retina, and the retardation of the polarized light by the retinal nerve fiber layer is measured. And the GDS is the example. The disadvantage is that since it is based on the birefringence property of the retinal nerve fiber layer, optic nerve doesn't contain the retinal nerve fiber layer, so that it can analyze only the retinal nerve fiber layer, it does not analyze the optic nerve head. So that is why it's not popular now, so I'll just skip that. Coming to the most popular one, the posterior segment OCT. The advantage is that using this you can analyze optic nerve head, the retinal nerve fiber layer as well as the macula. The principle, as you know, it's based on the low coherence interferometry, and it gives high resolution cross-sectional images. So over time we have evolved from the time domain OCT through spectral domain OCT. Now the latest we are standing at the step source OCT, where there has been an increase, better acquisition of images, better resolution and deeper penetration, so that when it comes to the step source OCT you can actually see up to the choroidal vasculature. And the most popular now is a spectral domain OCT. We have different machines. The most common is a Cirrus OCT by Zeiss. We have Avanti RTView, Spectralis, etc. So I'll be concentrating mostly on Cirrus OCT printouts. So in the Cirrus OCT, the termination of the Bruch's membrane, which is called the Bruch's membrane opening, is taken as a margin of the optic disc, and where the termination of the internal limiting membrane, this is the termination of internal limiting membrane, which is taken as the cup margin. So the distance between these two, which is called the Bruch's membrane opening minimum rim width, or corresponds to the NRR. So all the measurements are based on this. So before analyzing any printout, just look at whether it is reliable or not. Just below the patient data, you can see a signal strength is given. So in Cirrus OCT, ideally it should be more than 7/10 for it to be reliable. Then coming to the printout, so these are the components of an OCT printout. So this is the RNFL thickness map. So as I mentioned, everything is given color coding, but the thickness map color coding is different from the other color codes. Don't get confused. So in the RNFL thickness map, the thicker tissues are represented in warmer colors, that is yellow or red. If it is thinned out, it will be represented in cooler colors, that is green or blue. So here you can see normally superior and inferior RNFL are the thickest, so that superiorly and inferior you get the warmer colors. This is the right eye, this is for the left eye. So this is normal, which is called the hourglass pattern or the vertical bow tie pattern. And this is then compared to normative database by the machine, and if there is any deviation from that, that will be represented in the RNFL deviation map. Here there is no deviation, nothing is shown there. Then the Tisnett graph, same as the previous one. So here you can see both the eyes are represented in the same graph. The continuous line is for the right eye, the dotted line is for the left eye, which is shown here. And this is the probabilities which is shown. If it is falls within the green, it is present in the 95% of the population, that is normal. If it is in yellow, that means it is in borderline, less than 5% of the population. If it is in red, falls in the red area, it means it is definitely abnormal, less than 1% of the population. So in this picture you can see both the graphs are falling in the green area, so it is perfectly normal. That is, here also you can see it is falling in the green area. And in OCT, the advantage is that the same thing can be represented in quadrant maps as well as in the clock hour maps, where the 4 quadrants as well as the 12 clock hour thickness is also given. So here everything is normal in both the eyes. But if you look at this picture, in the left eye everything appears perfectly normal. You can appreciate the vertical, the hourglass pattern. In the deviation map, there is no deviation. And in the Tisnett graph also, the dotted line which represents the left eye falls in the green area. But if you take the right eye, you can see there is definite thinning in the superior and inferior aspects, and in the deviation map it is represented more in yellows and red, that means there is a deviation. And in the Tisnett graph also you can see the continuous line is actually falling towards the red area, which is definitely abnormal, and this abnormality you can very well appreciate in the quadrant map as well as in the clock hour map. Now coming to the macular ganglion cell complex analysis. So in OCT, this is the advantage. You can take the macular scan also. So what do you mean by ganglion cell complex? It is nothing but all the components of the ganglion cells are taken into analysis. That is the axons of the ganglion cells which come with the nerve fiber layer, cell bodies which come in the ganglion cell layer, the dendrites of the ganglion cells which come in the inner plexiform layer. So this is the retinal ganglion cell complex. So importance is that 50% of the retinal ganglion cells fall in the present in the macula. And in glaucoma specifically, the retinal ganglion cell loss occurs, so that if you analyze the macular ganglion cell complex, you can actually help in the pre-perimetric glaucoma even before optic nerve head changes begin to appear. So this is done by using a macular cube scan. So the color coding is everything similar to the previous one, where at the fovea we don't have ganglion cells, so that it appears dark, and surrounding that you have a very thick ganglion cell. That is why it is represented in warmer colors. So this is the typical donut pattern of a normal macular ganglion cell scan. And the deviation map, there is no deviation, everything is represented in green. So this is a normal macular cube scan. But if you look at this picture, the right eye and the left eye, you can see there is a definite thinning in the right eye in the infratemporal, and in the left eye also there is a borderline thinning. And the deviation map also, it is represented in red and yellow. And here also you can see the difference. Now coming to OCTA, in OCT angiography, it has been shown that there is a decrease in the superficial vessel density in glaucoma in peripapillary area and macula. So in this case, you can see in the normal eyes, the peripapillary area is dense, the capillary plexus, whereas it is decreased in the glaucoma. And around the macula also, you can appreciate the difference between normal and glaucomatous eyes. But this can be influenced by a lot of other systemic and ocular conditions. So OCTA cannot be used as a sole investigative agent in technique in glaucoma, but it can complement other investigations. So to summarize, using GDS we can analyze only the RNFL, using HRT we can analyze RNFL as well as the optic nerve head, whereas using OCT you can analyze all these along with the macula. Thank you.
Thank you.
Thank you, Rekha. Dr. Rekha, the talk was very nice. You had covered every aspect of imaging in this short time. Now I invite Dr. Meena Nair, who is familiar to us, to talk.
There is a token of appreciation, ma'am.
Okay.
May I invite Dr. Devendra Maheshwari to present a token of appreciation to Dr. Rekha R.S.
Now I'd like to invite Dr. Meena Nair, who is a senior consultant in Chaitanya Eye Hospital dealing with glaucoma services, to talk to us about how frequently we should do a field analysis and how we should analyze fields properly.
Good morning all. At the onset, I wish to thank Dr. Swapna and Team Sreenethra for the invite. And my talk for today is serial visual field analysis in glaucoma. I would start my presentation with my favorite graph proposed by the EGS guidelines, which actually points out whom to treat in glaucoma. As you can see, the x-axis gives you the age of the disease onset, y-axis gives you the visual field impairment, and you can see graph A is a natural graph. D and E actually they have the same onset of the disease, but E progresses rapidly, while D has a moderate progression but doesn't touch and go below the severe visual impairment. B and C have almost the same rate of progression, but C occurs in a younger age, and if you don't treat it aggressively, it goes down the visual impairment. So with this, we come to the two basic things actually in the assessment and management of glaucoma. That is assessment of the rate of progression, which is important because by it you can redefine your target pressure and you can decide on the treatment intensity. What are the recommendations? You have to perform the CGIG, the WGA, the AAO, the European Society guidelines, all of them come to the conclusion that you have to perform at least 6 visual fields for having a good assessment of baseline data, to have a good baseline and to come to a conclusion of whether the field is rapidly progressing or not. Today in my talk, I'll be covering the serial field analysis on the octopus as well as in the Humphrey. This is the standard printout 24-2 of the Humphrey, wherein you have the different loci, where you have the threshold sensitivities being measured. And accordance, the patterns of progression could be either a deepening of defect or an expansion of the defect at a particular locus, or evolution of new defects, or the second hemifield being affected. So how do you evaluate? First of all, you can have subjective methods or objective methods. The subjective is just reviewing all the visual field printouts, which becomes very difficult in a chronic glaucoma patient. Then comes the algorithm, statistical algorithm-based event or trend analysis. Statistical algorithm-based event or trend analysis, which is in the Humphrey is the guided progression analysis, the GPA, and in the Octopus, the I-suit. So it is, the general principle is that if you have more than or equal to 7 decibels, but reproducible in serial fields, it is a deepening of a scotoma. And if you have more than or equal to 9 decibels, it is a reproducible defect. And if you have anything more than 10, it is or 10 to 11, it's a new defect. So new defects, when you have 2 or more contiguous points more than 10 decibels, or 3 or more contiguous points in a normal hemifield more than 5 decibels, or you have more than 10 decibel difference or at the horizontal midline in 2 or more adjacent locations. So in this patient, you can see that from 2010 to 2017, actually the pattern deviation probability plots look almost the same. But if you look into the data, the values show that there is a deepening of the defects. And this is how a GPA appears. Okay. GPA of the patient showing the deepening of the defect. Now coming to this one, 2013 and 2017, what do you see? You see a basic enlargement of the defect. And that is the third one, showing you evolution of a new defect. And this is the development of the new defect. So basically, you have deepening, you have enlargement or evolution of a new defect. And what are the visual field printouts that the HFA machine generates? You can have without statistics, that is your overview printout, and with statistical assistance, you have your GPA. You have your GPA. Appears you can get 16 serial fields in chronological order. You can get 16 serial fields in chronological order, which gives you most of the data, but it just gives you a general assessment. It tells you, doesn't tell you, deeper defects, or doesn't pick up early defects, but gives a generalized overview. You have most of the data that you have in the single field analysis. You have the patient data here, you have the grayscale, you have the raw data, you have the total deviation, pattern deviation, probability plots, you have what test it is, what is the GHT, and what the visual field reliability indices, the foveal threshold, and the global indices. In the earlier generations, you didn't have the visual acuity and the refraction and the pupil diameter. And you can have in one overview both 24-2 and 30- in the advanced fields. This is the GPA generated latest overview, where you get even the pupil size and the vision recorded in it. If you can see for this patient who came to me just yesterday, 2 days back, this is the 2017 and this is the 2023 overview, showing that it is almost stable in both eyes. Left hand is the right eye, right hand is the left eye. Similarly, the 10-2 overview, which gives you a general idea whether the central field is stable or not. This is in the latest HFA3 GPA. So what is GPA? You get 2 baselines, which could be 30-2 or 24-2. You have different symbols like the open triangles, half triangles, pupil triangles, the full frame triangles, and the out of range values. So this is the 2 baselines. You can see the 2 baselines, and the average of 2 baselines is compared to the latest field, and whatever deviation is there, it is actually compared to the test-retest variability, and a deviation from baseline is plotted. Also, the progression analysis, if 2 consecutive fields are showing a deterioration at the same loci, you flagged it as a half-field triangle. If 3 consecutive fields are showing a deterioration, it is flagged as a full-field triangle. And you have the visual field index, which is charted as a histogram, where you can see it is the change over time. And it also plots what would be the change if it is at this rate of progression over the next 5 years in the histogram. These are the two baselines which you can redefine at each visit, which gives you most of the data in the single field analysis. And this is the GPA for an advanced field where you find a lot of these cross values coming up because even you have a lot of fluctuations in your advanced fields. So with the forum viewer, this is how a GPA appears. When you can sit at your desk on your PC, you can actually generate this printout, wherein on the right-hand side, you have all the dates of examination. On the left-hand side, you have what are the overview, what are the programs for GPA available. So this is how the GPA of this patient appears. You can find that 2017 are on the upper and 2022 is on the lower latest baseline, compared to the baseline. And you can see that it is almost stable for this patient. The overview also suggests the left-hand side is the right eye, the left eye on the right side, and you can see that this is an asymmetric field which is almost stable. If you want to browse, you can browse and see what are all the fields that the patient has done so far. And this is the structure function. You find the middle row blank because our cirrus is in another branch and we don't have the cirrus. So if you have the Zeiss same field machine and the OCT machine, you will get the structural progression as well in the middle. So in the lower columns, you can see that in the lower columns, you can see that there is a progression. This is a progression analysis and how the text boxes appear to tell you whether it is a likely progression or possible progression. This is the GPA of the same patient, the top showing the visual field index for the right eye and the left eye. Below that, the two baselines and then the follow-up field and all the indices. And what is important, you look at whether it is possible or likely progression, which is computer generated. Just as the visual field index rate of progression, you can also assess the mean deviation rate of progression, and the value will come here. Anything above 1, you look with, or more than 1, you do have to look in carefully. So you suspect a progression from clinical findings. It is suggested by an overview. And if you look at the GPA alerts, it's a likely progression. It has a high statistical significance. In the eye suit, on the right-hand side, you can actually manipulate. You can get the single eye. You can get for both eyes. You can get a 4-in-1 printout. You can get a 7-in-1 printout. And all these represent the progression analysis printouts that can be generated. Like you have this is the 4-in-1 printout. And here, you can see the 7-in-1 printout. This is the open series where you have serially the deterioration in single eye, and this is the serial deterioration in the both eyes. And you can see the left eye of this patient, which from 2020, it was showing a deterioration in the central field, and that is stable with the correction by 2022. So the trend analysis in the octopus is the global indices, that is the mean defect, the square root loss variance, the diffuse defect, and the local defect. Their rate of progression graphs which can be observed. So this is for the trend analysis for both eyes. This patient had progression structurally with hemorrhages, and you can see that this local defect has been flagged in red, which means the LD slope has progressed.
Ma'am, can you summarize, please?
Yeah. So this is, just one more minute, ma'am. This is one scenario where we have a patient who has progressed, and both the visual field index and the mean deviation slopes have progressed. And this patient actually had a very high progression up to 4 in the left eye. So, so you can see also that there is a significant progression in the left eye to a tubular from these two fields. So you have to think of, do an MRI scan and other things were done to rule out an NTG cause for progression. The second case, this patient is a primary open angle glaucoma who was stable and who suddenly developed a deterioration suggested by the GPA. So because of cataract, GPA on Humphrey was getting difficult. So that was analyzed on the eye suit, and the eye suit showed almost stable progression in the trend analysis. Now this is one patient of my colleagues actually, Dr. Thomas, whom you can see that it's a pseudo-exfoliation glaucoma which is showing the diffuse defect has been flagged red, and the red flag shows that there is significant progression in the slope. But always look out, things can puzzle you, progression is not always linear. Like this patient had cataract, and when that was removed, you can see the lower image improved. Similarly, this patient was puzzling because it was worsening, and finally we realized that the date of entry was wrong, and that's why the third overview is right. So false progression has to be excluded. Whenever there is an intervention, you have to change and reset the baseline, and always correlate clinically. And in general, for low-risk cases, do an annual field. For moderate-risk cases, do 2 fields per year. And high-risk but controlled IOP, you can do 2 to 3 fields. But whenever there's possible progression, you may have to repeat fields in 1 to 3 months. And before I end, I would like to say this patient came to me recently, whom I had seen in 2012 and told that you don't need treatment for glaucoma because the left eye obviously had a lot of pallor, and this was the inferior defect that the patient had in 2012. But when he went elsewhere after a long gap, he was treated and told to be progressing. But because we had the primary data here, we could confirm that over a span of 2012 to 2023, he had stable inferior altitudinal defect with traumatic optic neuropathy being the cause. So always correlate with other investigation modalities as well. Thank you.
Thank you. And thank you. Excellent talk by Dr. Meena.
May I invite Dr. Sheba CS to give a memento to Dr. Meena Nayak.
Now we will move on to the medical management, the keynote address on ROCK inhibitors and new AGMs by Dr. Amit Porwal. He is the head of glaucoma services at Sreenethra Eye Indore.
I think Dr. Amit Porwal don't need any introduction. As we know, he is a senior consultant in Sreenethra. He is a member of scientific committee chairman, and he is involved in teaching more than 19 years, and he is a section editor for IGO. Sir, over to you.
Thank you, Devendra, for my introduction, and I thank Dr. Swapna and Dr. Anila and Team Sreenethra for the kind invitation for this August gathering. So I'm going to talk about ROCK inhibitors, which is a new kid in the block, and about newer anti-glaucoma medications which are in the pipeline. So got no financial disclosures. So we all know that there is an IOP regulation. There's a balance between the aqueous humor production by the ciliary process and the outflow through the uvascular meshwork and the trabecular meshwork. But the majority, they are filtered to the TM pathway, consisting of TM, juxtacanalicular tissue, and the Schlem's canal. But the first line of therapy for lowering IOP, thereby preventing optic nerve damage, is medical therapy. We all know about it. The currently available therapeutic targets on increasing the uvascular outflow or reducing the aqueous production instead of targeting the TM. So there are molecules which are increasing the uvascular outflow and decreasing the aqueous production. But there are no molecules which are acting on the trabecular meshwork. So the currently available therapeutics, basically they increase the uvascular flow, that is the prostaglandin analog and the alpha agonist. Then there is a decreased outflow resistance, that is through, in our conventional pathway, that is through pilocarpine. And the decreased aqueous production is by beta blockers, carbonic anhydrase, and alpha agonists. So there was the need of a novel target which addresses the dysfunctional TM. So what was this? This was done by the newer drug, which is ROCK inhibitors. So basically, what is ROCK? ROCK is a Rho kinase protein kinase, which causes contraction of the cells, cell stiffening, and cell adhesions. They are involved in a variety of diseases, not only in eye, but also in vascular disease, asthma, neurodegenerative disease, and of course, major part of it is in eye, in glaucoma, but other parts of the eye also are involved. So Rho kinase and ocular disease, Rho kinase are widely expressed in ocular tissues. They have been implicated in the pathology of many ocular conditions, such as the corneal dysfunction, glaucoma, cataract, diabetic retinopathy, ARMD, and retinal detachment. So basically, what does ROCK do? Why it is the potential target for glaucoma treatment? ROCK causes contraction of the TM cells, and this decreases the pore size of the TM and decreases the filtration area of the TM by also increasing the resistance to outflow. So basically, this mechanism leads to raised in IOP. So where does these Rho kinase inhibitors act? These Rho kinase inhibitors act basically on the trabecular meshwork, Schlem's canals. They increase the aqueous outflow and decreases the IOP. They also act on the optic nerve head and on the retina, and they have a major role in axonal regeneration. So they have a neuroprotective role also. We also have this molecule in preventing fibrosis. So tenones, microfibroblasts, they act on that. They decrease the fibrosis and they play a role in wound modulation. So reduce scarring of the bleb. So it has a role post surgery also. So how does this basically ROCK acts? ROCK has lot of mechanism. So basically I have concised into how it acts. It acts to regulates cell morphology, cell proliferation, cell adhesion, cytokines, cell apoptosis, smooth muscle contraction, and neurite elongation. So what is the role in glaucoma, which is very, very important, as it's a new molecule we all should know. It basically increases the aqueous outflow by means of ROCK inhibition. It decreases the aqueous production by norepinephrine transporter inhibition. It decreases the episcleral venous pressure at low pressures. It increases the ocular blood flow, and it has a neuroprotective role in the retinal ganglion cells. So the mechanism of action I already mentioned. This is a pictorial depiction of the same. So increase the ocular blood flow, basically it causes vascular muscle, smooth muscle relaxation, which leads to vasodilatation. And the neuroprotection role is basically by the inhibition of axonal inhibition, which enhances the axonal regeneration. So ROCK inhibitors had a potential to reduce scarring after glaucoma surgery. The most common cause of glaucoma surgical failure is the formation of excessive subconjunctival fibrosis. So these inhibitors serve as a potent anti-scarring agents via inhibition and transdiffusion of tenuous fibroblast into myoblast. When we look at the corneal endothelium, they have a role in that also. ROCK inhibitors could play a role by increasing the cell adhesions and proliferation of the corneal endothelium. So it helps in acute corneal endothelial damage that can potentially occur in cataract surgery. So studies have shown positive effect of Rho kinase inhibitors in the corneal endothelium also. So post-surgical corneal edema, Rho kinase has a role in reducing this reducing the corneal edema and improving the health of the endothelium. Even in diabetic retinopathy and macular edema, these increased levels of ROCK pathway activity, they are related to the pathogenesis of these two particular conditions. So basically ROCK inhibitors inhibit this pathology and reduces the diabetic macular edema also. So when was this Rho kinase approved? So it was already, this molecule was available in Japan in 2014. It was used for glaucoma, basically in treatment of POAG and OHT. But then in 2017, in the name of Ropresa, US FDA approved it, and in 2019, the European Society approved it in the name of Rocainsa. And in India, we had this molecule available in 2020. So in India, we have these two molecules, Rapasudil and Netasudil. So basically, what the guidelines recommend? Guidelines basically recommend these two molecules, which is Rapasudil and Netasudil, to be recommended to be treated for POAG and OHT. But looking at the varied mechanism of action of these two molecules, the ROCK inhibitors, we have a wider angle, wider application. We can use in many other conditions also. So when you look at the indication and dosage, basically Rapasudil is 0.4%, which is given twice a day, and Netasudil 0.02% is once a day. When we look at the side effects, this molecule has a side effect. We all know every anti-glaucoma medication comes with a side effect, but the side effect which we noticed with this molecule was more when we compare to the other anti-glaucoma medications which are already available. And the most common was conjunctival hyperemia and cornea verticillata. So patient, we can see that most of the time the patient complains that there is increase in the redness after installing this molecule, but it wanes off slowly. You add a lubricating drop along with that, and slowly it wanes off. But in certain people, it doesn't wane off, and that becomes a concern, and they don't want to use this molecule. Corneal verticillata is also seen. A lot of people complain of injection site pain. Basically, this is when we put this drop, we have pain a lot. So that is also one of the side effects. And the latest which was reported was reticular corneal edema. You can see the pictures. Basically, what are the side effects of these molecules? It causes hyperemia, subconjunctival hemorrhage, cornea verticillata. So again, it has a role in corneal endothelial protection, but again, this molecule has a side effect of corneal guttate also. So it is not answered properly. How does this happen? We have punctate keratitis and blurred vision after the installation of this drop. So there are a lot of clinical studies on Rho kinase inhibitors which are available in the market, in the literature, but I am not going to go into all literature because it's very confusing. So I have just taken out the gist of few studies so that there is a take-home message of this. So when I look at the Rapasudil molecule, so what are the summary of Rapasudil states? It states it is effective as a monotherapy and additive therapy. It has maximum IOP reduction within 2 hours after installation. It has a day and night control of IOP, that is the peak and the trough IOP, both it controls. It has higher IOP reduction in patients with high IOP. It suppresses the inflammation IOP in eyes associated with in uveitis associated OHT also. So as I told you, it has varied role. It plays a role in diabetic macular edema. It plays a role in corneal edema, post-surgical corneal edema. It plays a role in neovascular glaucoma. It also has a role in angle closure glaucoma because it has different pathways through which the IOP is reduced. It is acceptable. It has an acceptable safety profile when administered as a monotherapy or an additive therapy. So these are the gist of the summary of different studies which they concluded. When we look at the Netasudil molecule, basically the landmark trials we should remember in Netasudil was the Rocket 1.4 trials. So what are the gist of that? There is a significant mean reduction from baseline IOP at all treatment times. Netasudil OD was non-inferior to timolol. So all these molecules were compared to timolol or the prostaglandin analog. The trabecular outflow facility increased by approximately 35% from baseline. There was a 10% decrease in the episcleral venous pressure from baseline. The IOP lowering efficacy is stable across different baseline IOPs. So when we looked at it, at 20, 30, 40, 50, the ranges, it was effective equally in all the ranges, whereas timolol was effective only in the lower IOPs and not in the higher IOPs. Nitazoxanide consistently maintained IOP when it replaced previous IOP lowering therapies, and additional 20% reduction was noted when added to PG monotherapy or a combination therapy. So this molecule has a role. So now basically we have heard about ROCK inhibitors, but we should know when we are going to use it. So what do you understand of these ROCK inhibitors? So what I suggest is, as a monotherapy, it can be used in patients who have concerns about the ocular side effects of prostaglandin. They are intolerant to or have inadequate efficacy with prostaglandin, need or prefer alternative to beta blocker, alpha agonist or carbonic anhydrase inhibitor. It can be used as an adjunct to prostaglandin or any alternative other adjunctive agents to improve the patient compliance, because it again the dosing is very effective. After any glaucoma surgery, when the desired IOP is not achieved, if you think that the bleb is failing, we can add this to prevent, because of its anti-fibroblast action, and it acts as another medical option to delay or defer glaucoma surgery. So basically, my choice of this molecule is just to buy some time before I push the patient for surgery. So this is considered as a last molecule for me. Again, it all depends how you want to treat it. Now coming to the second topic of my talk, which is the newer anti-glaucoma medications in glaucoma. So why newer anti-glaucoma medications? The long-term use of topical glaucoma medication, we all know it causes damage to the ocular surface and the membrane gland. Again, the bioavailability of the drug is less than 5% from the corneal surface. Multiple molecules are administered one after the other, and there is a wash off of the. So we all know that earlier, now we have preservative-free anti-glaucoma medications available, but earlier BAC was there in all these anti-glaucoma medication, and it had its own harmful effects on the ocular surface. So the thing was, there is a continuous research going on that to avoid all this, we need newer molecules. Now, what are the things? Everyday installation has to be avoided. We don't want any ocular side effects of the preservative. So sustained drug delivery device are the new things which are being investigated. You have the non-invasive and the invasive. So non-invasive, you have the drug impregnated contact lens, your ocular rings which are inserted to the upper or the lower lids, you have collagen shields and drug eluting punctal plugs. When we look at the invasive research which is going on, you have subconjunctival injections of the solutions, you have drug eluting polymer microparticle and drug eluting implants that is manufactured by Allergan, which is in the name of Durista. So these are the implants in the pipeline. You have the Travoprost XR. So most of these implants are basically with prostaglandin analog. You have Travoprost and Bimatoprost. So these are the different companies which are manufacturing, and some of them are available in the Western world, and in India nothing is available yet. So there are other implants which are usually supraciliary implants. They are micro needles and the intravitreal nanosponges, which are invasive methods. But they have their own set of problems. I mean, punctal plug was tried, but there are disadvantages also. Now, what are these disadvantages? The drug-eluting punctal plugs are very efficient, but the disadvantage, they often fall out. It acts as a foreign body, causing irritation, rubbing, and dislodgement of the plug. The movement of the drug can affect the drug release also, the movement of the lid basically, and it may not deliver the drug consistently over the 90 period of time which the company claimed. Surgical implants again has its own risks of infection, endothelial cell loss, the risk of the component and the devices, and they may float in the eye also after causing mechanical injury to the tissues. Contact lens impregnated drugs, mishandling of the contact lens, infection, these are the problems which can be there. But let us look at few of the implants. Now, Allergan Durista, it is approved in 2020. It is a biodegradable polymetrics material. One-time drug delivery which lasts for 4 months. It is approved as a single implantation only. 10 micrograms of Bimatoprost is released through it. It is inserted into the iridocorneal angle which dissolves gradually. So decreased IOP very well. 80% of the patient did not need any topical anti-glaucoma medication. The visual fields were stable and it did not show any significant endothelial cell loss. Then primarily it is indicated in ocular hypertension and POAG. You have the iDose. It is basically a small titanium implant. It is a fast drug-eluting implant. It has a steady release of Travoprost into the anterior chamber. This device is anchored and held to the trabecular meshwork over the sclera. The duration of this drug delivery is basically 6 to 12 months. So it is intended to remove and replace with the newer device once the drug is completely released. So again, this had a 33% reduction in the IOP. So you can say whether you apply topically or invasive method, 30 to 35% is what is the IOP reduction these molecules are used, and this is how this implant looked. And you have to basically do a direct gonioscopy and inject it into the trabecular meshwork. You also have the OTX TIC implant, which is a preservative-free, fully biodegradable. It's a soft hydrogel impregnated with Travoprost-loaded microparticle. It maintains steady level of the drug in the aqueous and produces sustained IOP lowering. The meshwork is designed to hold the microparticle of the drug, and this meshwork hydrates, allowing the microparticle to dissolve and diffuse the drug. It is placed in the iridocorneal angle with the help of a 26 or 27 gauge needle, and this meshwork which we place in the angle gets completely absorbed also, so you don't have to remove it. The sustained release was there for days and months. Travoprost XR is available in the Western world. It's a biodegradable rod-shaped intracameral implant placed in the iridocorneal angle. It uses nanoparticle to provide a steady supply of drug. can deliver drug up to 6 to 12 months. There's 35.5% reduction in IOP over 8 months period. It was originally created by Envisa, but now ARI and Alcon are doing the research on this. We also have the latanoprost implant also available. So basically, whatever implants are available, they are basically for prostaglandin molecules. You again have a IOL haptic based drug delivery, which is something which is really new. It is manufactured by Spyglass system, in which there are drug eliciting pads which are attached to the optic haptic junction. And basically it's a foldable IOL to which these drugs are patches are implanted. You inject this IOL to the same injector. It is a 2.4 millimeter incision. The IOL stays in the bag. These pads are away from the optic field, so your vision is not hampered, and a constant amount of drug is being sustained release is being released. So there is a sustained release up to 3 years, and the significant IOP lowering also is noticed. So basically this is a different lens on which the drug eliciting implants are there. So there was a mean decrease in IOP up to 45% regardless of the dosage. There was 100% of the patients were at 18% or 18 millimeters of mercury. There was no significant adverse effect noted. Visual outcomes were similar to those achieved with the normal IOLs what you get. You have these external sustained release delivery points. You have this bimatopast ocular ring. You can see in the picture, it's basically a silicone ring wherein the drug is impregnated into it. You just have to put into the ocular surface, and the constant amount of drug goes on getting released. This is manufactured by Allergan. And again, this lasts for about 6 months. The ring was safe and well tolerated. So the retention time also of this ring was more. So these are basically different devices which are being studied, and these are available in the, few of them are available in the Western world. In India, it is still not available. Prostaglandin is the only molecule which is being released through these implants. But this TOD is basically a device where a lot of other drugs also can be impregnated into it, and this sustained release can be available. This is basically there for delivering PG analog, timolol, PG analog, timolol combination, and atropine. It is more cost effective when compared to these invasive implants because it is applied only on the ocular surface, and this is a new kid in the block which is wherein a lot of research is going on. So before I conclude my talk, I just would like to have a small appeal that I am contesting for the member scientific committee in the coming AIS election. So request all your support and blessings to please elect me for this particular post. Thank you.
Thank you. Thank you, Dr. Amit, for a very informative talk. So, yeah, I would like to ask, what is the drug of choice, a second line drug of choice for glaucoma management?
So second line, first line was prostaglandin analog, wherever it is indicated. Second line is timolol. So as I told in my talk, these Rho kinase inhibitors is basically to buy some extra time, and that is the last molecule which I am going to use it. Because even though studies say that the side effects reported are very less, but my patients and what we discuss with other glaucoma specialists, side effects are very common with this particular molecule. We can't use it as a first line of treatment at all.
I agree with you, but little differ from you. Though the side effects are really very mild and firm, and they really reversible. Most of the side effects are reversible, but definitely we can't consider ROCK inhibitor as a first line therapy. I agree with you.
The company people are coming with their own marketing analysis, which they say, no, it is used as a first line of treatment now. But I think nobody would use it as a first line of treatment looking at, because it is like something like a Ramdev Baba's Ramban, it acts on everything. And there are a lot of literature, but still we are not convinced that we can use it as a
second
first
question
line.
I want to ask you, how you told you want to make a preparation for surgery for these drugs. So how do you think we can help in preparation for surgery?
I didn't get your question.
You asked we can buy time by starting the ROCK inhibitor, then we are preparing for surgery. So,
Yeah. So especially like your hospital, today patients come with glaucoma, it's an advanced glaucoma, you want to operate, you don't have time to operate tomorrow itself, you have a long waiting list. So now then these type of patients come to us. I also have a heavy practice like that. So need to buy more time, I need to control the IOP, he's already on maximum medical therapy. For us, maximum medical therapy was all the drug other than the Rho kinase inhibitors. So Rho kinase inhibitors, you can add side effects are there, but at least 20 to 25% reduction, and studies claim 30% reduction will be available. So just suppose my date available is after a month now for the surgery. So at least for 1 month, I have one more molecule which I can add and expect some lowering of the IOP. Earlier I had only 4 molecules, now I can add the 5th molecule also.
So just my last question to you, do you think ROCK inhibitor can help in reducing the chronic conjunctival inflammation? Or something like, do you have some?
Yeah, so I wouldn't say as an inflammation because it causes vasodilatation. So the studies are saying that the inflammation is reduced. So as I told you, this molecule has varied roles. So that's the reason I'm using it as a last molecule, because I don't know how it is going to act, because the mechanism of action, if you see, it acts from the anterior pole to the posterior pole. At every molecular structure, these molecules are acting. but we are still not convinced how it is acting and what are the results. So as I showed you, it is used in corneal edema post-cataract surgery also to reduce the edema. It is used in DME also. But again, one of the side effects of this molecule is corneal guttates. So how do we explain guttates and again resolving of corneal edema? So a lot of questions are there which are unanswered. So it's still a new molecule which needs a lot of experience.
Yeah, I think, yeah. But my take will be there. I think Repasidol actually more helpful, especially in post-operative period in compared to the Nitarsodil. So somehow, as you spoke in your talk, Repasidol have more the corneal friendly drug in compared to the Nitarsodil.
Yeah. So Repasidol is more corneal friendly, and again to revive your blebs. I mean, post-filtration surgery, you have this ACE inhibitors. Carbonic anhydrase inhibitors. Now we have this ROCK inhibitors also, which can prevent fibrosis and have the blood revival is better with these molecules.
Thank you. Thanks.
Thank you.
May I request Dr. P.S. Girija Devi to give a token of appreciation to Dr. Amit Porwal.
Any question from audience by the time?
I just have one question. Amit sir, you can just keep it. Just one question. There's always a confusion regarding the dosage of these drops. So what is your recommended?
See, Repasidol is twice a day because the duration of action is based on that. So immediate IOP lowering after 2 hours it is noticed and it lasts for 8 to 12 hours. Nitarsodil, there is a study, the rocket studies which I mentioned, the landmark trials, it compares Nitarsodil OD and the BD dose. And the side effect with the BD dose was more when compared to the OD, and the IOP lowering effect was almost same.
Okay.
That's why OD dose is recommended to avoid the side effects.
Thank you, sir.
Okay, so our next speaker is Dr. Lalit Sohanraj. He is a chairman of the Department of Ophthalmology at Amrit Eye Hospital and Amrit LASIK Center. He is a renowned cataract and refractive surgeon. I heard he is one of the best cataract and refractive surgeon in Chennai.
No, I don't know why, who added those words.
He is a prophylactic cataract surgeon and he is a ranked, one of the top ranked at the Chennai. Correct, sir? Yeah.
I'm not sure about that, sir. Anyway, thank you for the kind words.
I think he's speaking on MIGS from cataract surgeon perspective. I think it's a quite interesting topic. Today, presenter, we are all talking about the micro-invasive, minimum invasive glaucoma surgery. I also feel it a future of the glaucoma surgery. So over to you.
Definitely. Thank you for the wonderful introduction. In the first place, I'd like to thank Sreenethra and especially Dr. Swapna Nair for having me here for this talk. So I'm going to talk to you about the eye stent, which is the stent for the eye. See, stents have been conventionally used in various fields, especially cardiology, urology and things. So basically what a stent does is it bypasses an area of resistance so that it, opens up the flow, especially in the eye, it opens up the flow of the aqueous into the Schlemm's canal directly. So before I actually go to my presentation, I just want to give you a little brief about the anatomy of the angle. I know all are glaucoma surgeons, but a little brief about the anatomy of the, because this is the most important thing when we do these stent procedures. So the closest to the iris is the ciliary body band, which is slightly brown in color. Next to that is the scleral spur, which is again a white line, followed by the trabecular meshwork, which is again slightly brown in color, and finally the Schwall base line. So this is how the angle structures look like. And our most important point of interest is the trabecular meshwork. So the inclusion criteria for this stent is patients who have mild to moderate primary open angle glaucomas, pseudo-exfoliation glaucomas and pigmentary glaucomas. The cup disc ratio should not be more than 0.8. The intraocular pressure should be uncontrolled, maybe around 25 or more with 2 or 3 medications. Patients who are non-compliant. Now this is the kind of patient which I usually get, where they are really old, they don't have anybody to take care and they are not able to apply medication, provided they are rich also, because this is quite an expensive stent. And it can be used both in phakic as well as pseudophakic patients, and angle should be wide open, at least Schaffer grade 3 to 4. And the exclusion criteria is basically advanced glaucomas where the cupping is more than 0.8. Narrow angle and closed angle glaucomas are an absolute no-no. Patients with PAS are not good candidates for this. Secondary glaucomas, which can be because of neovascularization, uveitis, or traumatic glaucomas, are exclusion criteria. Patient with significant corneal opacity. Now why this is important is because a good visualization is required for you to place these stents in the angle, in the trabecular meshwork. So definitely if you have a corneal opacity, that hampers the view, and those are not good candidates for the stent procedures. and patients with ciliary body tumor or mass. So this is how the stent looks like. It's a really small device. You can, the pointer, yeah, sorry. So this is how the stent looks like. It is a really small device. This is a, maybe you can compare it to a 10 rupee coin, and it's not visible to the naked eye. So basically it has to be seen under the microscope to identify the stent. So this is the mechanism of the stent. So basically the stent is a medical grade titanium device which is placed inside the trabecular meshwork. So what it does is it leads the aqueous directly into the Schlemm's canal, bypassing the resistance at the trabecular meshwork. So these are the two types of stents. The previous one was the eye stent. This was more of an angulated device which had to be kept into the trabecular meshwork. But the newer version, the eye stent inject, is much more simpler and less complicated. So it's just a straight device. You can compare it to your punctal plugs. You know, when you place the punctal plugs inside the puncta. So this is how, there is a small ridge which actually goes and sits itself into the trabecular meshwork, and it snugly fits there. So this is a small video of the surgery being performed. So I don't have very extensive experience with this, but I've done around 4 cases, and all the 4 cases have good reasonable results. So this is a patient after cataract surgery. I'm injecting sodium hyaluronate. You have to use 1.4 to 1.8% sodium hyaluronate for these cases. Nicely inflate the anterior chamber and put a little bit of sodium hyaluronate on the cornea also. Then you have to tilt the head 30 degrees away from you. At the same time, you have to tilt the microscope also 30 degrees towards you. So basically the angulation totally is around 70 degrees. And this is a direct gonioscope. So we all have to get used to using this direct gonioscope on our normal patients also before you venture into this kind of a procedure. So the eye stent inject comes with a guard. So basically you enter the eye, pass halfway through the cornea, and then open up the guard. And this is the trocar. You can see there. I'm just going closer to the trabecular meshwork, just dimpling it a little. And with once I'm sure that I'm in the right place, I'm just pressing the plunger on the injector device, and there the stent goes and sits into the trabecular meshwork. That's it. I just nudge it a little to make sure that it is in place and it is not falling off. You can, each eye stent inject has 2 devices, 2 stents. You can actually place it in one go, but since it was my second case, there's a lot of viscoelastic which was coming out, so I had to come out, inject a little bit of sodium hyaluronate again, and I'm going in the second go. You can see there is a guard. Once you are crossed halfway across the cornea, you retract the guard, go to the trabecular meshwork, make a small dimpling at the trabecular meshwork like you can see in this video, and just inject the stent, and it goes and sits nicely in the trabecular meshwork, as you can see here. You can nudge it a little, make sure it is in place. It should not fall off, because to get this stent out and reload it and put it back is a real pain. It happened to me once, and it took me almost 45 minutes to just reload and bring it into position. So make sure everything is done gently, and you can actually practice this on your cataract patients also. You can, tilt their head, move the microscope towards you, get that 70 degrees tilt, and you can use just your Sinski or something, go to the trabecular meshwork and come back. So that way your hand-eye coordination becomes better. And one of the good signs is whenever the stent is in place, you will have a little bleed from the stent, which makes sure that it is actually in the Schlemm's canal. So that is a good sign, and that means that you are in the right place. After you place the stent, you remove all the viscoelastic agent from the eye, and that's the end of the procedure. So initially it takes time, but once you master it, it is a beautiful, very simple, straightforward procedure. It's absolutely non-invasive, as you can see in this video. So to conclude, I would like to say it is a minimally invasive procedure, the MIGS surgery. So tissue alteration is very, very minimal, and hence the outcomes are better. The eye looks unoperated almost. It's a very good alternate in mild to moderate glaucoma patients. It helps in achieving the target IOP, and the chances of failure is very minimal, and a lot of studies have shown that the intraocular pressure maintenance is quite good for a very long time, maybe many years in fact. Thank you for the patience here.
Thank you, I think excellent talk.
It was a nice talk, and you had thrown light on a very important topic.
Yes.
And the video was very demonstrative.
Thank you.
It was so clear. Thank you.
Thank you.
Now I would like to invite Dr. Devendra Maheshwari to...
Inviting Dr. Sheba CS to present a token of appreciation to Dr. Lalit Sohandra.
यहाँ एक पड़ा है, आप भी मैं निकाल देता हूँ, आप लगा दीजिए. नहीं, ये मेरा है, ये कंपनी का है, आपका शायद वो है टिप. The previous version is around 95,000. I have not used that. I have used only the iStent inject. The billing rate is around 1,08,000 or something. But the best part is the medical insurance reimburses it in most of the patients. In most of the patients, provided the premiums are high or whatever, so they reimburse. Above that, whatever you want, you can charge.
Sir.
Inviting Dr. Sheba CS to present a token of appreciation to Dr. Lilith Sohanraj.
So, Lalit, you were talking about the eye stent, but I still feel, I mean, we have a Devendra on the podium. I think he has the highest number of bang and GAT. He's been doing it. He's doing Tinoto. In India, eye stent first was with a single injector, single stent, then came 2, and now the Western world is using 3 stents also.
Exactly.
And looking at the cost and the indication, mild to moderate glaucoma, it is very difficult. We don't know how long it's going to last.
Very
because
true,
we
very
had
true.
Express, it was a wow factor. A lot of people started using Express.
Even I've used it.
It went off. But I feel Bang, GAT, the results are published also, and it is more economical, and we can give to our population. And what I would like to tell all the audience is, earlier as a glaucoma specialist, we used to stress everybody that you should do gonioscopy.
Yes, yes.
But now as a cataract surgeon, we stress everybody that you should buy a direct surgical gonio lens. And as you mentioned, follow the steps of 30 degrees, the patient should be away from you, and the microscope should be tilted 30 degrees towards you, 30 to 45 degrees, and start practicing direct gonioscopy.
Definitely.
These gonioscopes are available in the market. They are very cheap. They are not
Yes,
expensive.
yes.
You buy those disposable ones which are available for 3,500 to 4,000 rupees. You have this, what you showed was an eye prism. We have from Katina, Vogue, which are with the handle. And we also have the self-fitting like a contact lens.
Exactly.
So you use that, start practicing. If you're an ETO, you always ETO it and reuse it. So the need of the hour is, mix is going to be there because it's a part of the cataract surgery. It's going to get you money also. And you should know how to use the surgical gonio lens.
Yeah. Sir, personally, I feel this procedure as a cataract surgeon, okay, it was a little easier, but the other procedures like GAT and all are quite challenging. I've seen those videos, so maybe, you know, it is just a different, a glaucoma person's
Cataract is not
point.
easy.
Huh?
Cataract is not easy.
I'm not talking about cataract, sir. I'm talking about the...
So when we say cataract is not easy, Bang is more easier. If you know the surgical gonioscopy.
Thank you, sir.
So good morning, everyone, and thank you, Sreenethra team, for inviting me here. So today I'm going to talk about minimum invasive glaucoma surgery. I think part of my talk has been covered by Dr. Sohanraj. And in this setting, we see this, why we need the glaucoma, what's the mode of treatment wearing. I'm not going into the detail, already I'm told. But still I want to highlight why people go blind in glaucoma, because either they are undiagnosed or they are improperly treated. And there's a lack of compliance to the medication. So why this a lack of compliance? Because the treatment modality, what we are using as a medical management or laser or ultimately surgery. So what the problem with medical treatment, we have to use 1 medication, 2 medication, and at the end of the 2 years, more than 75% of the patient require the 2 or 3 medications. And the compliance in Indian scenario, cost is a big issue. Then coming to laser, though we have some recent laser like SLT, MLT, even micropulse, they really works, but ultimately they have to repeat again. The efficacy not last long, the effect wean off so soon. Then coming to the surgical intervention like trabeculectomy and tube, they are good and produce the good IOP control, but they have their certain kinds of own challenges. So there's a large therapeutic gap between the safe medical laser treatment versus the surgery. So you can see these are some side effects. I think some postgraduates are here. Anybody can answer? What are the drugs name? Yeah, I think everybody knows, yeah. So then coming to the newer drugs, they are also not devoid of complication, as Amit sir already mentioned it. Then coming to surgery, really surgery is gold standard, trabeculectomy gold standard since 50 years. And it's still gold standard. I'm not saying it's not. It's still gold standard, but again, there was their own set of complications like the cataract, failure, again, need to maintain it. We have to again to work on injection, bleb needling, and all these things. And I think some certain kind, if you do the surgery, you can see such kind of nightmares in post-apilectomy cases. So here this MIGS come. So MIGS bridging the gap between the pharmacotherapy laser and the conventional surgeries, between tubes and traps. So what is the ideal surgery we want? We want reproducible, no blab, easy to perform, less post-operative effect, cost-effective. So Iqbal I Ahmed described the minimum invasive glaucoma surgery. If we compare this ideal surgery, I think this somehow we have come near to ideal surgery. Is MIGS should be ab-internal approach, it should be minimum traumatic, and it still have the modest efficacy, extremely safety profile, and should be the very, very fast visual recovery. That the present scenario everybody wants. So look into the here, how this, we talk about the MIGS, how MIGS is more effective because it works in more physiological way. So you see here what the most of the MIGS are doing, they are communicating between anterior chamber, Salems canal to the outer conductor channel. So these procedures are the more physiological. If we talk about the market, if we look at the market, we see by 2025, most of the surgery will be done by the MIGS, more than 50% surgery. So what are the surgeries are available in India right now? We can have the eye stent, as I told, then come to the GAT, then trabectome, microhook trabeculotomy, KDB, and Bang. We'll discuss one by one. So this is the device-based MIGS, like the Hydrus, Gen implant, eye stent, and TM-based are the GAT, Bang, and trabeculotomy. So this is the, again, problem. India, there's affordability and availability of the devices is the big issue. So what we can do, so we can perform such kind of surgery. These are the Bang, microhook, trabeculotomy, KDB blade, and the GAT. These are the surgery we can easily perform, though they have little bit learning curve. So before starting the MIGS, you should very, very necessary to be a master in gonioscopy. You have to intraoperative practice, do the intraoperative practice to do the good microscopy. As the sir told, already patient and surgeon head positioning is required. Then your table should be the reverse Tendelberg position. Then now we talk about the procedure base. So this is a gonioscopic assisted transluminal trabeculotomy. How it is done, it is highly done. We cannulate the Salems canal either by the eye tract microcatheter or the Prolene suture. So when we talk about that eye science, it's costing $750 US. I think it's near impossible to do in Indian countries. So we have alternative. We can do the GAT by using the Prolene suture. Who are the candidates? Really, we can do such procedure, especially in primary opening glaucoma, mild to moderate stage, with or without cataract, and secondary opening glaucoma without any whatever the all stage, with or without cataract. Apart from that, the recent literature, recent studies are coming. We are doing such procedure even in the angle closure cases. So now we see this the video where how to perform the GAT. I think sound is not coming. So these are the basic instruments required, and most important, to adjust the head position and microscope. Microscope should come 30 to 40 degree toward yourself, and patient head should go 30 to 40 degree away from you. Then you need the cohesive viscoelastic, put into the cornea and dock the lens. The docking lens is very important. Your hand should be very gentle. You should not apply force onto the cornea. And this is the tip of the Prolene. It has to be blunted with help of the low voltage cautery. Just you put the lens, then you take the small goniotomy. After goniotomy, and this is a very good sign. If you see the blood in the MIGS surgery is a good sign. Blood is always good in the angle surgeries. So it's showing you are perfectly on the Salems canal. And slowly you have to put the 20 to 25 strokes. Then the other end will come and just we take out. So this is another second case. The silicone oil induced glaucoma. Again we wash the silicone oil, blunted the tip. So really it is not easy, it's not coming in a 1 or 2, really it need 80 to 20 stroke you have to push, and really sometimes we feel the resistance also. Then other end come, when other end come, just we have to take it out, and with other end forceps, just you have to remove it. And right now we are doing almost our 50% surgery is the MIS in my center. Then coming to the cohort dual blade, in this blade we do the kind of the trabeculectomy. Goniectomy, what we do, this is a taper blade interned to the Slange canal, and after which this device stretch the tubercular meshwork and cut it out. So again, this is a new blade, this comes called the cohort dual blade is a glide blade. So again, I will show in this video how to perform the surgery. And right now it's costing 30,000 for one case, company recommend, but easily we can perform 4 to 5 cases. We can see the efficacy up to 3 cases, it works well. After that, that efficacy sharpness is enough. So after performing the phacoemulsification, I think this part I'm skipping, similar way, dock the lens. After docking the lens, so identify all the landmark in the angles is most important. Don't perform any surgery in a hurry and without seeing. So always identify each and every structure of the angle. That must for any kind of angle surgeries. And this is the cohort dual blade, yes, I showed you. And how to do, there is one animation here. This is the blade going into the tubercular meshwork, stripping. We strip the part of the tubercular meshwork. This is a 2-way, one other side and go other side. And you can, the way, whatever you want, but at least it should cover the 60 degree. So this is a cohort dual blade is going in. We are stripping the tubercular meshwork, and sometimes we can easily identify the strip. You can come into the anterior chamber, and sometimes we have to remove it with the help of the forceps. Though it can be considered, but again cost is a concern. It costs 30,000 rupees for single blade, and you can re-sterile, and you can use for the another cases. So this is the procedure. Once you done, then you have to do the anterior chamber wash and form the AC. So now we have alternative of this. We can do the bang. So what is bang? Bang is a bent ab interno needle goniectomy. So how we have to do? We can do with help of the 25 gauge needle. It's just costing the only one. I need 1 minute extra. Yeah. So this needle just you have to bend. Upper side sharpness is 1 mm. You have to bend this side. Then you have to, after performing the cataract surgery, place the IOL, and this is the 25 gauge needle. Routinely we use in our OR setting. Just tip of the needle, just you have to bend. Only problem with this procedure, the tip is very sharp, so you have to be very careful when you're working on the angle. So put the cohesive viscoelastic. Again, identify all the structure, very important. Don't do anything in the angle without seeing. So take the tip, go into the Slange canal and just scratch it out. So when you scratching, something like you are scratching from the upper part of the tubercular meshwork, and you can do in the both sides, 30 degree from this side, 30 degree from our side, so 60 degree. Then after that, just wash it. After washing it, again most important part, when you are making doing such procedure, at the end of procedure you have to make your chamber a little bit tight, and sometimes we have to leave the viscoelastic into the anterior chamber to keep the IOP sustained, maintained for longer period of time, because once is hypertony, it may lead to the bleed. Then another procedure is called the microhook trabeculotomy. So these are the various procedures. This is a various instrument. 1 minute. These are the straight, right and left trabeculotomy. So in this procedure, the various study has proved it, and we have done the largest prospective study of the trabeculotomy. So after doing the phacoemulsification, IOL has been placed, and these are the various kind of the micro hook. So again, you just identify the angle and throw the side port. There are some side ports are there. Throw the side port. This micro is going into the anterior chamber, and this micro hook are very blunt and they are very safe. So this micro hook goes into the Slem's canal, and you can just make the cleavage of the trabecular mesh work. So this kind of procedure, the beauty of this procedure you can do up to the 240 degree. The rest of the procedure we are working at the 60 degree. So come in this way and do that. And similarly, you can do other side also. Go to the nasal side and do the temporal size. So by this procedure, you can treating the angle almost the 40 degree. I think we have done the study, and our result has shown at the end of the 6-month IOP control is much better in compared to the phaco group. So I think I stand I'm skipping already has been spoke by the Dr. Sohan Raj. I think for my setting really is quite costly affair. I don't think some of the few patients can afford it, because 1,05,000 is the stent price, and if you have Mediclaim, really you can enjoy such kind of procedure. So I think MIGS combined with cataract surgery provide a new and safe option for IOP reduction. MIGS does not affect the outcome of the future incisional surgery because of conjunctiva sclera, everything preserved, and tube and shunts can be choice of the procedure where we want the really IOP control very, very low. Thank you for kind listening.
Beautiful videos by Dr. Maheshwari. But all surgeries will look very simple at an expert's hand. What complications you have met with in these surgeries?
If you can do the good, really phaco surgery, you can do the MIGS. And really every surgery has some complications. You have to very, very master in the intraoperative gonioscopy. If you are master in intraoperative gonioscopy, any good phaco surgeon can perform the MIGS. And worst to worst complication you can do iododialysis, cyclodialysis cleft, and vitreous hemorrhage that reported in one single case report. I had worst complication iododialysis in one case. Yes. Yeah, you can have.
So, but this DM again gets reattached, and basically if you are more anteriorly, DM detachment is more common. If you are more posteriorly, iododialysis is more common. If you are more deep, you will go to in making a cleft. But this is a very promising surgery. I think I discussed with Devan quite a few times. Indication being not only mild to moderate glaucoma, even in advanced glaucoma, if you don't want to take the risk of a snuff-off phenomenon, you can always do this procedure. So at least from 4 molecule, he might come to 3 or 2 molecule. So this is always a good surgery with a good safety profile compared to invasive surgery also.
Yes, I think you produce some extraordinary outcomes, and I think we are doing more than 1 year. Really, you can get the IOP control, like in some cases in the 10, 11, 12, over a period of the 8 to 9 months, because we can promise that only because we are doing since 1 year only. And really it works beautifully, especially in advanced cases also, though literature didn't support it. And recently we started our work on doing the GAT onto the angle closure cases. And really, if you're good at doing, then only you to go into the angle closure cases. For the wide information, I can say strict up to the open angle cases.
Thank you.
Near 100%, you'll have some degree of hyphema on the post-op. Angle surgeries. Quite a few say blurring. I combine it with my cataracts. So compared to the other cataracts, which say I can see very well, quite a few have told 2-3 days to clear up will be there. It will clear up, but there is some degree of hyphema.
Yeah, so I would say really not all cases has the hyphema, but definitely some of the cases will have the hyphema. We have to talk to patient, explain the patient. You can have hyphema, you not able to see next day. Really we have to explain to you're not able to see next day, but they have confidence in you. After 1 week they come with 6. without anything. So what we are doing a comparison between phaco trap and the GAT. So GAT patient come with happy within 1 week, phaco trap will be set up to the 1 month also. And apart from that, how to avoid this hyphema? So this depend upon how are you closing your eye. So when you're closing your eye, you have to make AC tight and leave quite viscoelastic into the anterior chamber, or whatever you're using, either using the coordinating sulfate or using the aerosol, whatever you're using, leave 20 to 30% of the viscoelastic into the anterior chamber. Keep in mind your IOP should be around 30 to 40 mg when you're closing your eye. Even the certain cases, by taking all the measures, some of the cases we can see the hyphema. So we have to ready for that. Yes, usually I don't consider the patient who is on anticoagulant therapy, really they need it, really they're demanding, then I stop the anticoagulant for 1 week, then consider such procedures.
This viscoelastic left in the anterior chamber, does it produce a post-op hike in IOP?
Sorry, madam, can you say again, please?
You said you will be leaving behind some viscoelastic at the end of the surgery and the IOP at 30 to 40. But in the immediate post-op period, is it going to create problems?
Oh, so what I mean, if you leaving the viscoelastic into the anterior chamber and making the anterior chamber, so when you're closing the anterior chamber, that should be tight. So how tight should be there? So tap that cornea and find out the IOP should be around 30 to 30 mg. That means IOP that time, point of time, it should be on 30 mmHg. This is a rough estimation to understand how tight is the globe is there. That means, and really, and you see the next post of the day, you check the IOP, hardly 10, 12, and 15, not more than that. And subsequent visit, they come with IOP 10 or 11.
Especially bang GAT, because it is economically more cheaper. So with less surgical time and less post-operative manipulation, this surgery will stay for a longer time and will take over dominance compared to trap, I think.
Yeah, I think once everything works well, I won't say you can finish, but really once it works well, really you can finish the phaco GAT within a 10 to 15 minutes. But we can't promise anything. It may take some time. It can take to the 15 to 50 minutes also. We don't know. But really, most of the time, surgery finishes in 15 minutes. And really, most rewarding part is the patient comfort and patient visual recovery is very, very fast in compared to the phacotrabeculectomy or phaco-shunt procedures.
Sir, when you are not able to pass the suture 360 degree, what you do? You do 10 to 12 cases per day, but all cases we are able to pass through the GAT suture 360 degree.
So really it's not necessary. Every case you can go to the 360 degree. There's so many things we have to consider. If you pass from other side, you're not able to do, make another goniotomy, pass from the other side. It's called the hemi-GAT. This is popularized by Dr. I.K. Ahmad. So he used to do hemi-GAT. So hemi-GAT passed from the 180 degree from this side and 180 degree from the other side. Then you can complete up to the 360 degree.
How many, like post-op, how you manage pilocarpine, how many weeks you usually?
Usually we give pilocarpine for the 1 month, and certain cases we stop in the 2 weeks. Some patients are demanding, they need that refractive correction early, so we can stop in the 2 weeks also. But uniformly I give pilocarpine in all my cases.
Thank you, sir.
Thank you.
Thank you.
Thank you.
Now we will move on to the next topic.
May I request Dr. Sheba CS to present a token of appreciation to Dr. Devendra Maheshwari.
Next talk is by Dr. George P. Pathuran on pediatric glaucoma pointers. Dr. George Pathuran is the Chief of Glaucoma Services in Aravind Eye Hospital, Madurai.
Good morning, everybody, and thank you very much, Dr. Sapna and Sreenethra, for this invitation, and it's my privilege to be here with you today morning.
And it's our privilege also to have you here.
Devendra.
And just 1 minute, sir. So I think Dr. George doesn't need any introduction. He is one of the most famous surgeon in the India for the tube. I think he is my mentor. So I'm very glad to have you in this podium. And everybody know the glaucoma drainage device, then everybody know the George sir. So George sir and GDD, they are the synonymous to each other. And he is heading the department of Madurai Arvind Eye Care System. And really, he is the one of the key sole person behind the oraless aqueous drainage device. Not only that, how to popularize in the developing world, taken into the world level to the RD. I think all credit goes to the George sir. Apart from that, he is a very nice human being, one of the best teacher I encountered in my life. Thank you, sir, to having you here.
Thank you, Devendra. I don't have words to. So this is like, I wish we had something like mix to take care of pediatric glaucoma, but this is real hardcore, and sometimes it's such a bleak picture with so much of blood vascularization, tubes come out. So anybody who is interested in taking care of pediatric glaucoma, I would strongly recommend this Consensus Series 9 from the World Glaucoma Association. Actually, the World Glaucoma Association has come out with a series of reports covering different aspects of glaucoma, and the Consensus Series 9 is dedicated to childhood glaucoma. They have adopted the Childhood Glaucoma Research Network Group's classification and diagnosis of criteria for glaucoma in this Consensus Series. So the definition of glaucoma is 2 or more of these criteria have to be satisfied: an intraocular pressure more than 21 millimeters of mercury, optic disc cupping, corneal findings like Harv's striae, corneal edema, corneal diameter 11 millimeter or more in newborn, 12 millimeter in more than 12 millimeter in child less than 1 year, and more than 13 millimeters at any age is highly suspicious of childhood glaucoma. Progressive myopia, again reproducible visual field defects. So coming to the classification of childhood glaucoma, again from the CGRN group, it's divided into the primary childhood and the secondary childhood. The primary childhood, the primary congenital glaucoma and the juvenile open angle glaucoma are components of the primary childhood glaucoma. And again, the secondary childhood glaucoma is also beautifully classified in this CGRN classification. The first is the glaucoma associated with non-acquired ocular anomalies. What this means is the child has an ocular anomaly at birth, like an aniridia, an Axenfeld rigor, a congenital ectropion uvea, a Peters syndrome, glaucoma associated with non-acquired systemic disease or syndrome. That is, again, there is a systemic anomaly at birth, but may not be associated with, may or may not be associated with ocular condition. The phacomatous group, the Sturge-Weber, many metabolic disorders like mucopolysaccharidosis, connective tissue disorders like Marfan's, Weil-Marchesani, all this fit into this group. Then comes the glaucoma associated with acquired condition. Here the acquired condition has been diagnosed and treated before you diagnose glaucoma. Uveitic, post-trauma, steroid-induced tumors. One thing we should note here is that any surgery other than cataract surgery comes under this group. Glaucoma associated with following congenital cataract surgery has been given a separate group for the CGRN classification, just to highlight the importance, highlight its importance and its frequency. It is the most common cause of secondary childhood glaucoma. Again, the CGRN classification is what peer reviewers expect in the peer review process, and we also see that primary congenital glaucoma and glaucoma following any publication you take, these are the two major groups in pediatric age group. Coming to determining glaucoma progression, key features to monitor are intraocular pressure. Applanation remains the hallmark. It can also be the Perkins. eye care is also picking up for an office assessment of intraocular pressure. Optic disc changes remain the hallmark for diagnosing and assessing progression in even in pediatric age group. Corneal features I've already mentioned, the edema, the harps striae, extremely important to document corneal diameter in all children undergoing cataract surgery. Refraction, as I was mentioning, progressive myopia, axial lengths, which can increase up to 7 years of age. Corneal diameters can enlarge up to 3 years of age. Visual fields is challenging, but sometimes highly rewarding. Ultrasound and ultrasound biomicroscopy are also useful investigations sometimes useful in progression. A slide on central corneal thickness. See, the role of central corneal thickness in pediatric glaucoma care is not yet well established. You cannot be adding or subtracting from your measured intraocular pressure just like how you do for your adult patients. And despite the theoretical overestimation of intraocular pressure, in children with aphakia, developed glaucoma, they progress, and optic disc assessment, as I said, remains the most important feature of assessment. Coming to the examination under anesthesia, this is the protocol which our anesthetist follows. 3 to 12 years, this is just for the EUA. 3 to 12 years, he uses the intravenous propofol, either with the fentanyl or the ketamine. Less than 2 years, it's always the IV ketamine, very rarely an inhalational sevoflurane, but you should also keep in mind that inhalational route with sevoflurane can dramatically and profoundly bring down intraocular pressures. If you're planning to do a surgery after the EUA, induction is always done with thiopenton sodium for newborn to 3 years with intravenous propofol in 3 years and above. Muscle relaxant, which they prefer, is a succinylcholine or a vicronium or an atracurium. And I always ensure that the intraocular pressure is measured before the intubation. You just have the induction. As soon as the induction is over, try and get your intraocular pressure checked. Intubation is best done with an laryngeal mask airway, and maintenance is with nitrous oxide, oxygen, and sevoflurane. Medications alone rarely show sustained efficacy as primary treatment for glaucoma in infants and young children, but it's frequently needed as a temporizing intraocular pressure lowering treatment before surgery, and also as adjuvant therapy after partially successful surgical procedures in childhood glaucoma. Surgery remains the mainstay, critical component in the management of childhood glaucoma. Prepare patients and parents, caregivers for lifelong follow-up and possible future surgeries. Again, it would be advisable to get this done by trained surgeons in centers with sufficient volume to ensure surgical experience and skill, and also to ensure safe anesthesia. It should be a fine balance between increased efficacy and decreased complications as far as childhood glaucoma is concerned. These are the surgical procedures that we have in our armamentarium to tackle childhood glaucoma: goniotomy, trabeculotomy, which can be a conventional harm trabeculotomy, or your circumferential suture trabeculotomy with a blunted 6-O-proline, a CTT, a combined trabeculotomy, trabeculectomy with mitomycin, trabeculectomy with mitomycin, aqueous drainage implants, and cyclodestruction. See, there are very few randomized surgical trials for us to go back and see about the efficacy of each procedures, and in a setting like this, consensus becomes very important. So I've just taken some perspectives from the largest ever worldwide surgical consensus survey from experts taking care of pediatric glaucoma, and the procedure of choice for primary congenital glaucoma was goniotomy in 28% of the experts surveyed. This is the initial surgery of choice. Trabeculotomy in 41% of the experts. 28% of those experts did a conventional trabeculotomy, and 13% of those experts did a circumferential trabeculotomy, and CTT was preferred as the primary procedure of choice for PCG only in 14% of experts. I am absolutely convinced now that the first choice of surgery is not often, is the best chance for success. And again, surgeons' training and experience significantly influence their choice of surgery, and also the facilities, equipment. It's all about what works in your hand in your population. very early in my career, I was exposed to so many of these children with very cloudy corneas where there is absolutely no chance of visualizing the angle to do a goniotomy. And somehow over the years, this has been, suture, even now the Harm's conventional trabeculotomy continues to be my procedure of choice for a primary congenital glaucoma. It's a phonics-based conjunctival flap, and it's a rectangular scleral flap that I prefer to raise. And it's very carefully and meticulously dissected. Partial thickness scleral flap was dissected towards the limbus. And the limbus of these children are most often highly stretched. And within a matter of seconds, you can just have a full thickness hole and you can see aqueous coming out. So, and another very important part is to identify the Schlemm's canal. Probably that is the most important step. It lies at the corneoscleral sulcus where the gray-white zone joins the gray-white, that gray area joins the white zone. That's the transition between the cornea to the sclera at the limbus. So a 2 millimeter radial incision is made here right at the junction, and then this is progressively deepened by careful dissection till, see, there is a little bit of aqueous and little bit of blood coming out. That is where your outer wall of the Schlemm's canal has been dissected. You pass your Harm's trabeculotome, and once it's fully in the Schlemm's canal, it is usually almost without any resistance, it cuts through whatever trabecular meshwork still remains there. Suppose your anterior chamber collapses after one half of the trabeculotomy is done, you can still go ahead, form the anterior chamber with viscoelastic and proceed to do the other part. We usually do 90 to 110 degree of Harm's trabeculotomy for all our PCG patients, and this still remains my nightmare. I'm extremely happy if I can do about 90 to 100 trabeculotomy for a child. I know that's the best success in my hands for these kind of patients, even though now surgeons all over the world may be slowly shifting to the 360 degree suture trabeculotomy wider. And also a point to be kept in mind is usually these bilateral PCGs, we have to tackle them at the same sitting as long as the anesthetist allows. I have gone through all this. I'm not going to. I'm also convinced that trabeculectomy with mitomycin has very, very limited role in treatment of childhood glaucoma, because even with antimetabolites, because the scarring is very high. Again, this consensus survey, this is not surprising. 44% of the experts felt GDD as the primary surgical option in glaucoma in aphakia. 44% of experts. And failed angle surgery, 53% of experts preferred as GDD as the next surgical option rather than a trabeculectomy. 63% Ahmed, 41% Bawel, 92% of the experts thought a better drainage device was needed for childhood glaucoma. So just 2-3 points about GDD surgery in childhood glaucoma. The Ahmed glaucoma valve tends to have very bad encapsulation and sometimes even Tenon's formation. Long-term intraocular pressure, the blebs are much more higher and much more localized. Probably it might be prudent to have your non-valved, Bawel-like non-valve, the Orolab aqueous drainage implant in the younger age group, because the blebs are much more lower, low profile, larger surface area, and probably work longer. I'm not able to get the. So we will cover most of this. I'm not able to take this forwards. Okay, I'll just leave this because I'm not able to fast forward it. I'll go to the next slide. The one thing I wanted to show in that video is how, which I'll also be demonstrating in my other talk on a safer surgery system. I like to flaunt this paper very often. It was very difficult to convince surgeons to adopt this long scleral track without a patch graft tube implantation, especially in children. It has to be seen to be believed. The healing is much better. The conjunctival elevation is as low as possible, and it is as natural. The transition from the conjunctiva to the cornea is as smooth as possible. So this is another, and especially in the very young, even for a child who has a failed angle surgery, 6 months to 1 year of age, we would still prefer not to use the patch graft and still have the 23 gauge needle generated long scleral track for your tube implantation. And over the years, when we looked at our results, we also found that we have taken, you must have seen a tube extrusion picture in my first slide. We found that tube exposures have been taken out of the equation to a large degree, and tube retractions remain the most common adverse effects of tube surgery in childhood glaucoma. Cyclodestruction, difficult to titrate, limited long terms, and most clinicians reserve cyclodestruction until other treatment options have failed. But it's also important to note that 15% of experts advocated it early in the treatment regime as a first choice as a temporizing measure for intraocular pressure control, especially in Sturge-Weaver and glaucoma and aphakia, before going in for surgical options. The cornea and the glaucoma and the intraocular pressure share an intimate relationship. The corneal edema is the source, is the reason for this bad corneas, and they have to be tackled before you plan for any kind of corneal procedures. And this is my last slide. It's extremely important to address amblyopia, which is a major cause of suboptimal visual recovery in childhood glaucoma. You need to send these patients for good visual rehabilitation with low vision aid services, and patients and caregivers' quality of life is now becoming such an integral part of pediatric glaucoma care. Thank you very much.
Thank you, sir. Excellent talk. I just want to, with the interest of audience, you skip the one slide, how to identify the Schlemm's canal. I think these are questions for PGs also. Intra plus trap. And really is essential to know how to do that.
I'm happy, Devendra, you raised that question, because even now I have a primary congenital, it's so difficult because the parents come with so much of hope and they are with so much of cloudy corneas, and suppose you're not able to identify the Schlemm's canal. See, whatever tube surgery, whatever cataract surgery we do, I'll do in my OT. If I cannot identify a Schlemm's canal, it's horrible that day, because in literature it says about 15% of children, it's difficult to get into the Schlemm's canal. But for us and for that child and for the parents, I don't know, it ultimately lands up with another surgery tube. But suppose this works well, you get your 90, 100, and probably Devendra will be doing a 360-degree suture trabeculotomy for these patients. If this works well, it's a different world. The cornea just clears, the child is almost always normal, needs a little bit of visual rehabilitation. If it doesn't work, it's the other side of the coin. Just for the PGs, I still go in and see the shields the previous day so clearly, and once you read, next day you can see it on the microscope. You see the corneoscleral sulcus, and under high magnification, if you dry that area, you can even appreciate droplets of aqueous above the Schlemm's canal, just above the Schlemm's canal. These are the few lines written in shields. Corneoscleral sulcus lies at the blue-gray-white transition between sclera and corneal tissue. Again, high magnification cellulose sponge, appreciate droplets of clear aqueous beading precisely above the canal, and radial incision 2 millimeter in length made at that point. Deepen posterior, this is another excellent clue for surgeons who are doing pediatric care. Sometimes we can even slightly extend the radial incision posteriorly to see the choroid, then come forward, you see the scleral spur, the canal lies just in front of the spur. But I still tell you, this is my biggest challenge in taking care of adult and pediatric glaucoma put together. I don't know whether Thomas has any other opinion on this.
Yeah, Second question, once you pass the Helms trabeculotomy on one side, your AC collapse. So how do you form the AC? Either from your same incision or you want to do the side port and then make the anterior chamber?
I make a small, almost less than a millimeter paracentesis. You could attempt to inject visco on the side where you have done the trabeculotomy, but this would be much more safer. Fill it with anterior chamber and then continue and do the trabeculotomy on the other side.
I also had a question for you, sir. After pediatric cataract, it's very hard to measure the intraocular pressures in the clinic. So we usually take them under ketamine and try to do that. But in the clinic, suppose because of a struggling child, you often get the IOPs to be something around in the 30s. And you were talking about disc progression being a nice way of knowing whether there's glaucoma. I also use myopia as an indicator. But both these take some time to happen. So can we wait for these things to happen? And then, because in children sometimes it may be reversible, or do we err on the side of caution and just start with the AGMs?
It depends on what your pressures are and what your central corneal thickness is. Even though I said that you cannot directly equate, but if you see a central corneal thickness of close to 660, 700, which you do see with glaucoma following cataract, with children with following cataract surgery, and you have a pressures about 28, 30, you can still do an EUA, document everything, document your disc findings, and you can still afford to wait. But you have to closely monitor it at the slightest evidence. And I agree with you, it suddenly progresses. You always, but I wouldn't err on starting treatment for a very thick cornea with a pressure of around 28 millimeters of mercury in a child whose otherwise the cornea is clear and the optic disc is absolutely normal. And also, an eye care rebound tonometry nowadays is becoming very useful, especially not in the very extremes, but in close to the normal range. It becomes a very useful tool by which you can check your intraocular pressures.
And what happens to the cornea? Because I've seen that sometimes some of these children get very bad cornea following administration of anti-glaucoma drugs. Sometimes they present with nummular keratitis type of lesions. So what would be advice on that?
Nummular lesions?
Yeah, I have a child that had undergone congenital cataract surgery, and later on had a secondary glaucoma, bilateral. So on continuous AGMs for a very long time, so she must be around 8 or 9 now. And her cornea has nummular lesions which cannot be attributed to any previous conjunctivitis. And each visit she comes back, the surface is of course very irregular, and she's going on ample lubricants, but there was a sudden, a slow development of nummular lesions in the stroma.
Probably,
so I was wondering on...
Probably this is intractable, is uncontrolled IOP, because usually most of our children either are on a single fixed drug combination, like a timolol dozolamide combination, never on somewhat adults, like you have 3-4 drugs. No? In pediatric glaucoma care, you cannot afford to have so many medicines. It has to be well controlled with 2 medicines. I don't know, but probably this is inadequate intraocular pressure control. I cannot think about anything else. I haven't seen.
Okay, my last question, sir. Suppose we are treating with trap plus trap with 1 year or less than 1 year old kid. Most of the time we do like that in PACG cases. When your first trap plus trap fail, what's your management of line? Your management of line.
Devendra, I'm assuming, what did you say?
First, trap plus trap fails less than 1 year of the kid. So
see, this is the difference. We are from the same institute. Devendra prefers to do a trabeculectomy with trabeculotomy as his primary procedure of choice for primary congenital glaucoma. I would definitely prefer to do just a trabeculotomy. So it's all a question of what works in our hands. Suppose my first angle surgery fails and I was able to do a good angle surgery, I would still try to repeat the angle surgery in a slightly different quadrant. And suppose that, and it also depends, like suppose you have a 14.5 millimeter cornea, horizontal, vertical, it's very difficult to do these kind of surgeries. Angle surgery or trabeculectomy, I would directly risk a GDD. I would, even for a child who is less than 1 year of age.
Thank you, sir.
What? Somehow, Thomas, I feel, yeah, a lot of even LV Prasad and PGI Chandigarh has a lot of obligations on CTT. Somehow it doesn't work in my hands. And I don't prefer to do a trabeculectomy alone with mitomycin as my second choice, and especially in the very young. That's what you are referring to, Thomas.
No, I mean, you said you are one of the few people who do otomy alone. I am in the same group.
I always get support from Thomas everywhere. I still remember.
I agree with you. If you have a 15 millimeter cornea, your harms doesn't go even one quadrant. So you got one more quadrant to work on it before going further. Nothing like a clean otomy with no bleb, controlled pressures.
In one of the GSI meetings, two very senior surgeons said you should not have shown a patchless tube implantation. Thomas immediately said, I also do the same thing. I have absolutely no tube exposures. You remember that, Thomas? Thank you.
Yeah, I also do the same thing. So, yeah. So our next speaker is Dr. Amit Porwal. Again, he is talking about the phaco triple surgeries.
I would like to invite Dr. P.S. Girija Devi to hand over a token of appreciation to Dr. George V. Puthuran.
And really, by the time Amit sir is ready, but I feel really when we combine the CTT, really over a single sitting, you are doing the both surgery at the same time. And really somehow in my hands, strap plus strap, trabeculotomy plus trabeculectomy works well with my childhood glaucoma patient. Probably I trained under Dr. R. Ramakrishnan, and I think he is doing since quite 35 years, he is doing the combined trabeculotomy plus trabeculectomy. So in our hand, this combined procedure works well in my case, my hand and my mentor's hand. Over to you, sir.
So after the congenital glaucoma talk, I'm going to talk about the phaco triple surgery, the adult anti-glaucoma and the cataract procedure. So why do a phaco trap? So one surgery helps in both clearing up the central vision loss from cataract and in controlling the peripheral vision loss from glaucoma by lowering the IOP. So the possibility of worsening cataract after glaucoma surgery is eliminated, and after glaucoma surgery, subsequent cataract surgery may induce inflammation and which may cause the glaucoma surgery to lose its effectiveness or even fail. So phaco trap provides early visual rehabilitation of the patient with cataract and glaucoma, reduces the risk of severe post-operative pressure rise, may provide long-term reduction of IOP and decrease the need for glaucoma medications. So what are the indications for phaco triple? First, the patient should have a visually significant cataract with glaucoma who is having failure to achieve target pressures by medications. There are issues related to compliance and adherence to medical therapy. There's adequate IOP control but significant drug-induced side effects. There's a borderline controlled IOP. There's a disease progression or near maximum medical therapy, and there's moderate to advanced glaucomatous damage. So coming to the techniques of phaco trap, you have two types of techniques. You have a single site surgery and a twin site surgery. So single site surgery is basically phaco and trap is done to the same site. It involves less surgical time. Twin site or a two site surgery is phaco is done to a separate temporal corneal incision as the first step and trap on the superior quadrant as a second step. It involves slightly more surgical time. So when we compare single site versus the twin site had 1 to 2 millimeters more IOP reduction and required less post-operative medication, although this difference was not statistically significant. So coming to the video on both these procedures, so basically I'm going to show this trap phaco in a case of small pupil. So it's a phaco triple procedure. It's a case of complicated cataract with secondary uveitis, chronic uveitis. So always take the anchoring suture. You can take a superior rectus anchoring suture or a rear corneal stay suture. Always mark your congenital flap for a phaco surgery. I mark a phaco triple. I mark 3.5 to 4 millimeter. Do a subcongenital dissection. Do a posterior subcongenital dissection as much as possible because you want the bleb to be a posterior diffuse bleb. When you are doing the cauterization, remember to cauterize only the bleeder. Never over cauterize it because if you over cauterize it, there will be chances of flap shrinkage. If you are using any antimetabolite sponges always count the number of sponges which you are implanting into the subconjunctival space. Decide your own concentration in the holding period which is suitable for your patient. Count again when you are taking out the sponges. Wash off whatever antimetabolite is there. Most of the time what happens is there's a lot of ballooning or chemosis of the conjunctiva. So you iron it out so that your view is not obstructed. Again, mark the scleral flap. 3.5 millimeter is what I mark. I usually do a triangular flap. So you can do a triangular flap or a rectangular flap, whatever you are comfortable with. My mentor was Dr. Satyan and he has taught me how to do a triangular flap. So I'm used to this triangular flap. So with the 15 number blade, make a triangular flap, and the trick is to lift the apex of this triangular flap. So you lift the apex of the triangular flap, so there is some stretch which is created, and with the help of a 15 number blade, just touch the cutting edge of the 15 number blade at the junction, and you will see a uniform flap being formed. Then shift temporally. Now, because it's a twin side surgery which I am performing, so the superior flap is created. I have not entered into the anterior chamber. I have shifted temporally, and I am doing my temporal phaco which I have started. So we being glaucoma surgeon, we face a lot of time, this patient with small pupil. So pre-operatively, we have to plan up how we are going to tackle this small pupil. So after doing synecholysis and viscometriasis, I knew that the pupil is not sufficiently dilated. So I had in my mind to use a pupil expansion device. So this is a Malugin ring. The trick to insert the Malugin ring is very, very easy. You just have to engage the distal scroll first, then the two lateral scrolls, and with the bimanual technique, you can engage the proximal scroll which is there. The advantage with these devices is it makes your life more easy. The surgery becomes less complicated and more easy. These devices stay in the pupillary plane. I always prefer to use these expansion devices than iris hooks, because iris hooks we have to create another 4 or 5 stab incisions. The peripheral AC is shallow and a lot of pigment dispersion which we don't want. This, it lies in the pupillary plane, so your AC is maintained. And what I advocate is a slow motion phacoemulsification when I am doing a small pupil case, and my preferred technique is a stop and chop technique. So basically in a phaco triple, what is important is the flap creation first as a first step in the twin side surgery, and then temporally phaco. Whatever technique is comfortable on your hand, go ahead with that technique. Do a traumatic cataract surgery, which is very, very important. You should have less pigment dispersion. That is the second criteria. And you should be prepared how to tackle your pupil, because most of the time as a glaucoma surgeon, as I told you, you will come up with a small pupil or a mid dilated pupil. So the IOL is being injected after thorough cortex wash and PC polishing, and this IOL, make sure the IOL is in the bag and not in the sulcus, because quite a few times if it is in the sulcus, through the large base peripheral direct-to-me, what you do at the end of trap, sometimes the haptic may come out. So disengage the Malugin ring, reload it into the inserter, pull the button behind, and the whole ring gets inserted into the injector. Now you shift superiorly, you find out the blue-white junction. You can prepare the internal ostium with the help of a 11 number blade or with the help of a Kelly sponge. So this, I am using a 11 number blade, a 2.1 millimeter internal ostium is being created. The trick is never overinflate the anterior chamber with viscoelastic. If you do that, there will be iris prolapse. Do a broad-based iridectomy with the help of vanas and limb forceps. In this case, these are the initial videos of my career. So in this case, I am using a single intermittent suture at the apex, and then I am going to use 2 releasable suture at the 2 side walls of the triangular flap. So releasable suture is a must, and every surgeon who is going to do a trap surgery should know how to insert the releasable suture, for the simple reason being, you can have a tight AC and then you can titrate the pressure post-operatively by releasing the releasable sutures. So the complication rate is decreased if you use a releasable suture. So the technique of releasable suture is very, very important, which you should know how to put it, and you should know when to release it and how to release it. So this is the conjunctival closure. Always take an episcleral plight at the limbus so that the bleb doesn't get retracted because of the lid movement posteriorly, and there is no bleb exposure, the flap exposure. And interlocking sutures are used. You can see it is nicely tightened with the 80 Vicryl suture. By using this technique, the bleb is anchored at the limbus itself, so the posterior migration of the conjunctiva is avoided and you get a tight closure, and you should make sure that there is a taut end at the limbus, so there is no leakage or seepage to the aqueous through the limbus. So this was a technique of basically twin site surgery which I had showed you. Now coming to a single site, as I told you, the anchoring suture is very, very important. Whatever you are comfortable with, you can take a superior rectus anchoring suture or a clear corneal anchoring suture. Again the trick, mark your flaps. This is very, very important because you should know which area you are doing. Whether slightly superior nasal is preferred, because if the surgery fails, you have more virgin area left, and if you have marked your area, you know how much area you have dissected beforehand. So for a resurgery, you know the area which is virgin or which is still available. So mark again the scleral flap, as I told you, identify the bleeders, cauterize the bleeders if they are obstructing your view. And in this case, subconjunctival mitomycin was used beforehand. So earlier I used to use sponges, but now what I use is a subconjunctival mitomycin, 0.02 milligram per 0.1 ml. I give as much posterior as possible the subconjunctival mitomycin, wait for a holding period of 2 to 3 minutes, and then I start with my trap surgery. So in this case, you can see the flap is being made, but as mind it that every time you won't get a nice flap. So in this case, the flap was not regular. You can see compared to the previous surgery, this flap is a bit thinner at some quadrant, and it is not a uniform thickness flap. So now I'm entering the anterior chamber through the same wound at the blue-white junction. I just anterior to that with the help of a 2.2 millimeter keratome. I'm doing my cataract procedure through the same 2.2 millimeter entry superiorly at the same site where I'm going to do the trabeculectomy also. So you can see the IOL is injected. Now with the help of a Kelly's punch, I am making the internal ostium. So it all depends how you want to make the internal ostium. This is a 1 millimeter Kelly's punch. You can make an L-shape opening or a mushroom shape opening. So basically surgery is evolving. You should always titrate your procedure, what works best in your hand, and you always have to refine. So nowadays I am using only a single releasable suture in my phaco triples. So the releasable suture, as I told you, you pass a suture 10-0 ethicon into the clear cornea parallel to the limbus in front of it, then perpendicular to the limbus from the clear cornea into the scleral flap, and then from the scleral flap into the intact sclera. So now I am passing from the scleral flap into the intact sclera. A loop is created over the scleral flap, pass 4 throws over this loop, and a releasable suture is put. Now, as I told you earlier, the anchoring suture and then the interlocking conjunctival sutures are placed so that the bleb is not retracted. So once the right end of your suture is sutured, right end of the conjunctival flap is sutured, when you want to suture the left hand, try to stretch the conjunctiva as much as possible so that you get a taut opening and there is no seepage of aqueous at the limbus. Otherwise, you need to give a matrix suture at the in between the two conjunctival sutures what you have implanted. So this is the way of doing a single site surgery and twin site surgery, and that's what I have to say in my phaco triple surgery. Thank you.
Thank you, sir. Very nice illustrative talk.
The videos were so nice. It was so clear, and everybody, we have got an idea about these surgeries, triple surgeries. Now I will invite our moderator of our session, Dr. Devendra Maheshwari, to deliver his second talk on augmented trab.
So like previous talk, some of the talk has been covered by Amish sir. Yeah. So I'm talking about the mitomycin C augmented trabeculectomy. I think this is the most commonly performed surgery is the trabeculectomy. This has dramatically changed from the way it was described in long back in 1968. So basically, right now in glaucoma management, trabeculectomy and anti-metabolite become a gold standard in the management of the glaucoma. So indication we all know when all the modes of therapy like laser or medical therapy on laser is failed, then we go for the surgery. Apart from that, certain conditions like socioeconomic factors, patient can't afford have the side effect of the medicine, we can consider the trabeculectomy. And the recent primary tubes and trab study has shown the trab with MMC really works well even after the 3 years in compared to the tubes. So previously we have some outlook with the TVT. Trap has a lot of complications, not a good outcome. But PTBT again has shown the trap with MMC works well, even over a period of time. So what we want by doing the trap, we want good IP control, low diffuse bleb with happy patient. Really, we don't want, but most of the trap patients are not happy patient. We should be keep in mind. Really, it takes time to stabilize this kind of blab over a period of 2.5 months to 3 months. So how to get such good functioning blab with good IP control? So there's certain preoperative, intraoperative, and post-operative measures required. Mostly my talk I limited to the use of the intraoperative antifibrotic agents. So just we come to know how the bleb is failed. So with the site where the bleb failed around the bleb capsule and the skull flap and the sclerostomy. But the main cause of the failure of blab at the scarring at the surgical site, where at the level of the episcule or the subscale fibrosis occurs. How we can avoid it? By using the antimetabolite, either the 5-FU or the mitomycin C. In olden days, we used the 5-FU lot, but various such study has shown mitomycin C is more potent in compared to 5-FU. So 5-FU has been used just for the post-operative management, especially using the, when bleb fail, we put the subconjunctival 5-FU for the 3 to 5 injection in post-op cases. So coming to the mitomycin C, it's an anti-neoplastic antibiotic agent that improves the glaucoma filtering surgery outcome and good IOP control by properly inhibit the fibroblast proliferation and reduce the postoperative episcleral fibrosis and bleb failure. So these are the certain factors are involved, like the neovascular glaucoma, uveitic glaucoma, young patient on the long chronic medical therapy, and such patients really they need the use of the antifibrotic agents. So there's a lot of confusion is there. When we have to use mitomycin C, what should be the concentration, and how we should use either 0.2 mg or 0.4 mg, how to reconstitute it. So this is, then again, this is some people use 0.2 mg, some people use 0.4 mg. So this is a big confusion. So make it simple. If you have the vial of the 2 milligram, just add 5 cc of the saline, 5 cc saline, they are making the 0.2 mmHg. When you're making it 5 mg, then, sorry, when you're adding the 5 ml, is making the 0.4 mg per ml. When you're adding the 10 mg, making the 0.2 mg per ml. As simple as. So there should be no confusion. When you want the 0.2 mg, use the 10 ml saline. When you want the 0.4 mg, use the 0.5 ml saline. And you can use either you can use the injection or you want to use the sponge. So now we come what is the difference between the both techniques? So most commonly used are the sponge. Apply the sponge to the ocular surface for a few minutes and cupidly irrigate it, as shown in this video. So better to use the Waxel sponge or polyvinyl alcohol sponges like this. And really after the finishing it, we have to just wash it thoroughly. And similarly, again this video I'm showing you. So only the care has to take, the margin should not be touched here and has to keep for 2 minutes, then you have to remove it. So this is the sponge, but there is a certain drawback of the sponges. Sometimes we retained sponges may cause that blebitis or infection sometime. So what not to do when you are using the sponge. So this is the technique showing here. This the way we should not use. We should not touch the edge margin of the conjunctiva when using the sponge. It should come in not in contact. You should not, margin should be away, and this should be keep as posteriorly as much possible. Because you see in the video, the most of the sponge near the limbus. So this should be much away from the limbus. And really sometimes we can have such kind of complication by improper use of the sponge. You can see here, this is a sponge. Post-operative surgery, the surgery is done by one of my fellow, and really he left the sponge while closing it. So you can see here, this sponge is there. The patient coming with a recurrent uveitis and inflammation. So this is the video. Here what we want, we just want to remove the sponge, but with a small incision, we want to remove a sponge as intact as much as possible, as well as we don't want to harm the bleb also. So making the smallest incision and trying to taking out a sponge as a whole. And really sometimes because if such kind of sponge left, we can have such kind of complication. And really main drawback of the sponge are the insufficiently treated area, mitomycin burn, risk of retaining sponge, and enable to the exacting the what amount of the mitomycin has been used by using the sponge, we don't know. So that's why what the way to avoid this such kind of things, count the sponge, how many you're using, or you can just irrigate thoroughly, and at the end of surgery, just find out, thoroughly check either you left some sponge or not. So there is a certain modification of using the mitomycin C. You can use the trap injection. We have done the study and find out that both sponge and injection both works very well. These are the other studies. An advantage of the injection site is allow the exact titration of MMC, no chance of the sponge being lost, less risk of the MMC1, less risk of the tenon cyst. So I'm using since long time. This is the way I used to use mitomycin C after taking the corneal traction suture. Around 6 to 8 millimeter away from the limbus, we inject the mitomycin C. After injecting the mitomycin C, just spread all over behind where you want the trap site. So the desired side of the blab has to be posteriorly. It should be away from the limbus as much as possible because to avoid the limbal ischemia. Then similar fashion, the trap has been done. Take the partial thickness flap. It works how you want to do, either with 15 number blade or some people use the crescent. And I always use the Kelly sponge because it's more controlled and we have the nice ostium, and apply the 3 flap suture. I always take the 3 flap suture. I close the my conjector always using a anchoring as well as the mattress suture. So this is another way. If you are not using the corneal traction suture, using the bridle suture, then you have to inject mitomycin C along the side of your bridle suture. After injecting the both side, just spread it as posteriorly as possible. And you can proceed by surgery the way you want to do. So again, this is the one more modality because the injection is causing the limbal ischemia. So we come with the new technique. It's called the visco-augmented trachelectomy subconjunctival injection. So what we are doing here, we are injecting the viscote near the limbus. So we are making a barrier between the limbus and the subconjunctival space. So the viscote has been injected, and after that we are here. Once it's there, so this is then we inject the mitomycin C behind it. This is the way, and then we proceed for surgery. So advantage is there. The injection viscote augment the technique will reduce the risk of limbal ischemia, limbal stem cell damage, and loss of the MMC application. Some drawbacks are there, definitely invent conjunctival tear, some conjunctival hemorrhage can be there. So the injection MMC, safe and effective method at conventional sponge. It's just to conclude, awareness of the proper constitution and accurate technique of MMC application will help the novice surgeon to achieve the better outcome of trachelectomy. Thank you for kind attendance.
Thank you, Dr. Devendra Maheshwari. Since we are running behind schedule, we will stop the session just now and we will move on to the inauguration session.
We have a slight change in program. We are just preponing the inauguration session and we'll come back for the same continuation of the same session just after the inauguration. Because some of our speakers and seniors might be leaving early.
Next, we move on to formal inauguration of Sacon 23 with traditional lamp lighting ceremony. I would request the following dignitaries to come over and grace the dais. I would like to invite Dr. Thomas Cherian. Welcome, sir. President-elect, Kerala Society of Ophthalmic Surgeons. Dr. Sushila B. Nair, President, Trivandrum Ophthalmic Club. Dr. P.S. Girija Devi, former Director, Regional Institute of Ophthalmology, Senior Consultant in Ahalya Eye Foundation, Eye Hospital. Dr. V. Sahasranamam, Senior Consultant, Director in Academics, Chaitanya Eye Hospital and Research Institute. Dr. Sheba C.S., Director, Regional Institute of Ophthalmology. Dr. Asha Shivaraman, Managing Director and Senior Consultant in Vitreoretinal Services, Sreenethra Eye Care. Dr. Swapna Nair, Senior Consultant in Sreenethra Eye Care. We welcome you all. May I request Dr. Asha Shivaraman, Managing Director and Senior Consultant in Vitreoretinal Services, Sreenethra Eye Care, to deliver the welcome address.
Good morning, all. Good morning and a very warm welcome to each and all of you. I thank each one of you present here today with us for sharing your time with us, and we really appreciate and are grateful to all the speakers who have come. Sreenethra is a teamwork, and a teamwork which was born with the dreams of providing quality care, providing dependable and affordable care to the common man, with the dreams of being a support and help to young eye care professionals who love to excel in the field of ophthalmology. Sacon is one of our baby steps to achieving this goal. At Sacon 23, we are concentrating on pediatric ophthalmology and glaucoma, which are special subjects in the field of ophthalmology with a lot of fine information pouring in every time, and is very important for general ophthalmologists and ophthalmologists in other specialties to get updated with. We are so glad that we have eminent speakers in the corresponding areas sharing their knowledge and experience and sharing a new perspective to common ophthalmic disease we face in our day-to-day OP. We also hope it provides an excellent learning experience for postgraduate students present here today. We are proud to announce this conference is under the aegis of KSOS and Trivandrum Ophthalmic Club. With that, let me welcome our guests. Dr. Thomas Cherian, President-elect of Kerala Society of Ophthalmic Surgeons, an eminent retinal surgeon and a leader of ophthalmology in Kerala. He has consented to inaugurate our CME. We are indeed grateful to you for finding time for us from your busy schedule. We welcome you, sir. We are honored by the presence of Professor Dr. Sushila B. Nair, our former RIO director and a leading light to most of the young ophthalmologists of our generation. She is the person who always see the bright side of things, and we wonder on her ability of dealing any complicated thing with a smile and get simple solutions. We welcome you, ma'am. Professor P.S. Girija Devi, ma'am, our former RIO director, a strong and honest personality whose confidence in dealing issues and bold decision-making skills, which has personally inspired me to be of more confident in myself and also to a lot of young ophthalmologists in our generation. We are honored by your presence, ma'am. We welcome you. വരുന്ന ആൾക്കാർ പ്ലാൻ ചെയ്ത് ഇവിടെ നിന്നാൽ മതി, ഇങ്ങോട്ട് നിന്നാൽ മതി. താങ്ക് യു. Professor Dr. Sahasranaman sir, again our former RIO director, past president of Kerala Society of Ophthalmic Surgeons, and the most wanted ophthalmologist in Kerala, especially to the masses and equally to all sectors of the society. Apart from the lessons in ophthalmology, we try to learn from him the everlasting smile and gentle problem-solving skills. We are honored by your presence, sir. We welcome you. Professor Dr. Shiba, ma'am, the director of Regional Institute of Ophthalmology, a great clinician, lovable human being, a great leader who has always been very kind to the young generation ophthalmologists and a leading light to many of them. He is a strength for many of us, including myself. We are honored by your presence. We welcome you, ma'am. I take this opportunity to also welcome our guest speakers traveling from far and near for gracing this occasion with their presence. They bring with them their vast knowledge and experience in their respective fields, and because of them, this gathering is happening. Let me welcome the eminent speakers of glaucoma session first, and then pediatric ophthalmology. Professor Dr. George Puthuran. Professor Dr. George Puthuran, sir, is Chief of Glaucoma Services at Aravind Eye Care Madurai. He is a leader in glaucoma today. Sir is an excellent surgeon, a mentor to a lot of glaucoma specialists in India. In spite of his busy schedules, he has consented and come all the way from Madurai. Thank you, sir. I welcome you. Then Dr. Devendra Maheshwari. Dr. Devendra Maheshwari, the leading glaucoma surgeon in India, especially doing great work in micro-incision glaucoma surgery, is a key leader in glaucoma and his surgical skills par excellence. Despite this, he is a humble and kind person. He has consented to come. Thank you for coming. We welcome you, sir. Dr. Amit Porwal, a leader of glaucoma in India, an excellent surgeon and clinician, is head of glaucoma in Sreenethra Eye Indoor. He has found a time to travel all the way from Indore to Trivandrum to share skills and enlighten us. We are glad to have you here, sir. Welcome. Dr. Lalit Sohanraj, Chairman, Department of Ophthalmology, Amrit Hospital and Amrit LASIK Center, Chennai, is an excellent anterior segment surgeon. He has traveled to Trivandrum to enlighten us. Thank you very much for coming, sir. We welcome you. Dr. Meena Nair, Senior Consultant at Glaucoma Services, Chaitanya Eye Hospital. We work in the same city, and she has been a friend for many years. We welcome Dr. Meena Nair. Dr. Rekha is Associate Professor of Ophthalmology in Gokulam Medical College and is a good friend of us. We welcome you, Dr. Rekha. In the field of pediatric ophthalmology, too, we have distinguished speakers. Dr. Jitendra Jidani. Dr. Jitendra Jijani, Senior Consultant in Pediatric Ophthalmology, Director of Children Eye Care and Skin Center, Baroda, is a legend in pediatric ophthalmology in India. He has come to share information with us, traveling all the way from Baroda. We are so privileged to have you here. We welcome you, sir. Dr. Ramesh Kekoneya, Head of Pediatric Ophthalmology, LV Prasad Eye Institute, Hyderabad, is a great scholar, surgeon, teacher and leader in the field. We are glad to have you, sir. Dr. Deepa Bhaskaran. Dr. Deepa Bhaskaran is a pediatrician, Director of Child Development Center in Medical College, Trivandrum, and she is working in the field of child development and adolescent care and development. She is a master in development and neurology and adolescent medicine. We welcome you, ma'am. Dr. Neelam Pawar. Dr. Neelam Pawar, the Senior Consultant of Pediatric Ophthalmology and Strabismus at Aravind Eye Care Trivandrum. She is a scholar, excellent surgeon and teacher. She has found time to come to us from her busy schedule. We welcome you, ma'am. Maybe doctor, if she is absent, maybe Dr. Devendra can receive the... Dr. Meena C.K., Senior Consultant in Pediatric Ophthalmology and Cataract in Little Flower Hospital and Research Center, Angamali, Kerala. She is a leader of Pediatric Ophthalmology in Kerala. We welcome you, ma'am. Dr. Sheera Kayar, Senior Consultant in Vitreoretinal Surgery, Aradhana Eye Hospital, Trivandrum. She has done research in retinal pathologies, including ROP and ocular oncology. We welcome Dr. Sheera. Myself, video, please get ready the video. Myself being a proud student of my guru and mentor, Professor Dr. S. Nadarajan, I am very glad that he has shared his video greetings to me and the Sreenethra team and to all of us. Love to show you it here. Is the sound or the sound is not? Can you replay it sound, please?
I am Professor Dr. S. Nadarajan. So even though I am not able to physically present, I am Professor Dr. S. Nadarajan. So even though I am not able to physically present, I am there to bless all of you, and I am glad that Dr. Ashad Sivaram is taking a lead in conducting a CME on this important subject, that is pediatric ophthalmology and glaucoma. And today we also had, as the president of the Eye Cancer Society of India, we did a program on retinoblastoma, which was a pediatric tumors, where February 15th for a retinoblastoma awareness day. Wish you all a grand meeting and a great learning. Thank you.
Thanks to sir. I welcome each and every one of you who have found time to come to this CME and blessing us. Thank you.
Thank you, sir. Now, it's time for the ceremony lighting of the lamp. I request all the eminent guests on the dais to please come forward for the lamp lighting. And we request Dr. Thomas Cherian, President-elect, Kerala Society of Ophthalmic Surgeons, to inaugurate the ceremony by lighting the lamp and thereafter deliver the inaugural address. May I request Dr. Thomas Cherian, President-elect Kerala Society of Ophthalmic Surgeons, to deliver the inaugural address.
Good morning. Greetings from the Kerala Society of Ophthalmic Surgeons. Trivandrum always makes me nostalgic because this is a place where I grew up and my parents lived for a long time. And I am happy that Arshad, Swapna, and the Sreenethra team have invited me and bestowed me with this honor of inaugurating this CME. The pandemic has taught us a lot of new habits. We have been in the webinar mode for almost 2 years. We have been learning at the comfort of our homes, but then we lost out on the byproduct of a CME, that is the camaraderie and the socializing. Now we are slowly getting back on track, and this year we expect a very busy academic calendar for the Kerala ophthalmologists. The CMEs are expected to pick up. We have the All India Ophthalmological Conference coming up at Cochin in May. Then we have our Drishti, our state conference at Thrissur in November, followed by the Vitreoretina Society of India conference at Trivandrum in December. So we are going to be extremely busy with the academic calendar this year. From the KSOS side, we had our first executive committee meeting. The venue inspection for Drishti was over, and the Lulu Convention Center at Thrissur has been approved for Drishti. The Lulu Convention Center at Bolgati, Cochin has been approved by the AOS team, and the preparations for the AOS are in full swing. I request all of you to register for the AOS before the deadline of the early bird registration, which is closing on the 28th of this month. I wish the CME Sacon 23 and the Sreenethra Eye Hospital all the best, and my warm regards to all the faculty, the senior members who are present here, and the delegates. I declare this Sacon 23 open. Thank you.
Thank you, sir, for the kind and encouraging words. Carrying forward the tradition of honoring the senior fraternity members, this time we seek blessing and support from two eminent senior members of our family who played significant role in developing ophthalmology in Trivandrum, Dr. Shantama Chako and Dr. J. Anthony. May I request Dr. Shantama Chako to please come to the dais.
Dr. Shantama Chako belongs to the 1961 MBBS batch of Trivandrum Medical College. She did her DO and MS ophthalmology from the Eye Hospital in Trivandrum. She has worked in several hospitals under Kerala Health Services and has retired from the services as Additional Director of Health Services. She had a very fruitful time during this period. And now she has a clinic at Artingal where she extends her community services. Dr. Shantama Chako has 3 sons. Her elder son, 2 of them are doctors, and 1 of them is an engineer. I request Dr. Ashad Shivaraman to adorn the Punnada on Dr. Shantama Chako. Dr. Anthony J. I request sir to come on the stage, please. Dr. Anthony J. did his MBBS, DO and MS from Government Medical College, Trivandrum, and joined as a tutor in Medical College, Trivandrum. He has worked in various capacities as assistant professor, associate professor, and professor in Kottayam, Kozhikode, and Trivandrum medical colleges, namely all the medical colleges in Kerala. And he retired after 24 years of tireless service. He thereafter worked as the HOD in Department of Ophthalmology. And he has released a very eminent book which is very popular among our postgraduate students. It's called Basic Measurements in Ophthalmology. And he's a humble teacher of fundamentalists. He has been awarded the Knight of the Blind Award by Lions Club. His wife, Dr. Annie, is a pathologist. She was the head of the Department of Pathology, and he's blessed with 2 children. I request Dr. Asha to adorn the Punnadon.
Now, may I request Dr. Swapna Nair, Senior Consultant in Cataract, Cornea and Refractive Surgery, Sreenethra Eye Care, to deliver vote of thanks.
First and foremost, I'd like to thank all the delegates who have attended this, because I think the success of any conference depends on their presence. I'd thank all the postgraduate students as well. I thank Dr. Thomas Cherian, the President-elect of KSOS, who has traveled a long way to be with us for this ceremony. Our seniors who have agreed to grace the occasion, Dr. Anthony J. and Dr. Shantama Chako. Many thanks to our chairpersons of the sessions, Dr. P.S. Girija Devi, Dr. Sheba ma'am, Dr. V.S. Sahasramam sir, and our faculty that have traveled from different parts of the country. I mean, they have come from all over India virtually. And I think they are the key to making this conference a success, because we have imbibed a lot of new things by leading practitioners in their respective field. I'd like to thank all our trade partners who have helped us to the best of their capacity, especially Micro Labs, Messrs. Sun Pharma, Messrs. Ophtho Life Sciences, Messrs. Alcon, Messrs. N. Todd, His Highness, Mankind, and Ostrak Pharmaceuticals. I'd like to thank the Hotel Hyatt and their staff for arranging the conference, the rooms, and making our delegates comfortable. I'd like to thank our event managers, ANZ team, especially Mr. Naveen, Mr. Vignesh, and their audio-visual team who has ensured seamless transmission of this, both online as well as the physical part of the conference. Then, not the least, my own team of Sreenethra, all the doctors, namely Dr. Anila George, who was responsible for all the presentations made here, Dr. Harshali, who has been not seen in this site because she's out there conducting the PG quiz and, getting the younger flock together. Dr. Anup Shivaraman, who was here managing the stage show, and not the least, the MD of the group, Dr. Ashad Shivaraman. My staff members, namely Mr. Srijit, Mrs. Shashi Rekha, and all others who are responsible for creating the program and presenting to you as it is, they have my entire gratitude. Thank you very much. I request Dr. Harshali Yadav to announce the results of the postgraduate quiz that took place in the morning. Please give us some details regarding that.
Good afternoon. So we had this postgraduate quiz which was Dr. Swapna's brainchild actually, and Dr. Ashad very graciously supported us with the finances. So we had around 21 teams who had actually registered all over Kerala, but I think 18 teams could make it here today. So I thank all the participants who came in from far. We have participants from Angamali, we had students coming in from Angamali, Kottayam. Thank you all. So coming to their, it's not showing. It's not showing, the results are not showing. So coming to our finalists, the finalists are Dr. Reshmita CS and Dr. Sahala from RIO, Dr. Devi Karthia, Dr. Alan again from RIO, Dr. Vishnupriya P. Soman, Dr. Rehana Ibrahim Kuti coming all the way from Little Flower, Angamali, Dr. Devika MS and Dr. Radhika Krishnan again from RIO. So all these students actually had MCQ with the best answer option, which they answered in the morning, 50 questions, and these were the top 4 scorers, who will then proceed to the finals on podium quiz at around 2:30. So please stay back. Thank you.
We will continue with the rest of the glaucoma session. I request the finalists who have been announced to please meet us in the adjacent hall.
Now we will move on to the next talk in the first session, Safe Surgery System for Tubes by Dr. George V. Puthuran.
Dr. Akila, can we have these lights a little dimmer here? Thank you once again. So I thought I will just go through an edited video where the main steps are as minimally edited as possible to show you, to show certain aspects of this tube surgery which has made GDD, especially in children, much safer than before. So see, we have tried to refine this technique over the past decade. And as most of you know, supratemporal quadrant is the most preferred location for placement of the episcleral plate of any GDD, whether it's a valved or a non-valved device. So it's extremely important to get into that particular quadrant because we are not pediatric or squint surgeons, and for placement of your non-valved bowel-like the Orolab aqueous drainage implant, you need to identify and isolate muscles and create space beneath these muscles to tuck in the episcleral plate there. So once you get into the supratemporal quadrant, it's relatively easy to identify first the superior rectus, that is the first muscle hook, and then the lateral rectus. So this non-valved implant which I am demonstrating, even for your Ahmed glaucoma valve nowadays we prefer to identify these two muscles so that the plate doesn't slip over to and place it exactly between. This is also a very important, creating space beneath the muscles. If there's any kind of adhesion there, the plate just doesn't go in there. So a second muscle hook is used to make sure there's no adhesions between the tenons or the conjunctiva to the sclera. So phonics-based conjunctival incision flush with the sclera. So this is the Orolab aqueous drainage implant. It's 350 millimeter square, designed to resemble the state-of-art bowel 350 millimeter square glaucoma implant. So initially, we just need to make sure that the tube is patent. There is in an Ahmed glaucoma valve, you need to do the priming to make sure the valve system is functional. The silicone elastomers are separated and the valve functions. So this is something which we have started doing for every patient with a non-valve implant. This is multi-filament nylon 3-0 supramid, and I'm extremely happy to say that after so much of struggle, we are finally able to commercialize the suture. This is available, the 3-0 supramid suture, and it has made tube surgery, the non-valved implant surgery, much safer. Again, extremely important to have complete watertight closure. So this is the 6-0 vicryl that goes in above the supramid, which is inserted into the tube lumen. And two throws and you make sure that it is complete watertight closure. You cannot afford to have any kind of seepage of aqueous in the immediate post-op period because there is no valve mechanism and you're prone to land up with lot of hypotony. Usually it's a 2-1-1-1 knot which we prefer because invariably one of the knots might become loose after your manipulation in placing the episcleral plate beneath the rectus muscles. So this is one of the wings of the RD going underneath the superior rectus muscle. See, this design is nicely contoured to the shape of the globe and flexible, and it snugly fits in. Even though it appears very large and difficult to handle, probably you might think it's much more difficult to implant this plate compared to Ahmed. It's very flexible and contoured to the shape of the globe. In any quadrant, it nicely slips in. Apart from the infratemporal quadrant, which we have probably not tried, including the supranasal or the infranasal quadrant, this plate, this beautiful design that Professor George Barwell has bequeathed to the community, it just slips in so easily. And again, once you underneath these two rectus muscles, you can see that this to and fro motion on either side, it's very easy. But anterior migration, because of this particular design, placed beneath the rectus muscles, anterior migration doesn't happen. Many complications of glaucoma drainage devices are because the anterior edge of the episcleral plate is not sufficiently posterior to the limbus. You should ensure that it is at least anterior edge of the episcleral plate is 9 to 10 millimeters posterior to the limbus. Again, this is something which we learned. Having a partial thickness 7/0 silk suture posteriorly on the tenons greatly facilitates exposure, because we are not used to working such posteriorly, unlike vitreoretinal surgeons. So it greatly, and two sutures are placed on either side corresponding to your episcleral, to the positioning holes of the episcleral plate. So now the fixation of the episcleral plate to the sclera, extremely important to see that the suture, the needle and the suture through the sclera while passing your bites. These are very thin areas of the sclera. You need to be extremely careful that you don't damage the choroid or the retina. So this is 9/0 nylon non-absorbable suture to fix the plate to the sclera. Again, the suture knots are rotated into the positioning hole to again minimize the chances of exposure. This is what I was saying. You should be seeing the suture, just seeing the suture through the sclera. So that is the thickness you need to aim for. This is just a tube stabilizing suture. Once we place this suture, the tube nicely obeys the contour of the globe. And also lateral mobility of the tube is minimized. So the second vicral suture, we always have two vicral sutures. The second vicral suture is placed anterior to the 3/0 supramid suture. So a lot of things which are being done now was learned by mistakes and errors. We found that one of this supramid suture exposed in one particular patient. And when we pulled it out, both the vicals were above the supramid. So once we pulled it, and it happened much before 5 to 6 weeks, where the vical suture is intended to dissolve spontaneously. So we found, again, this is important, making sure that the tube is completely occluded. So having a vical suture in front of the supramid allows you that margin of error. Again, with some accurate measurements, we are able to make sure that an optimal length of the tube is available in the anterior chamber. So a small groove is made, 4 millimeter posterior to the limbus and 2 millimeter medial to the original position of the tube. So for your right eye or for your left eye, prefer to have the initial groove. This is also extremely important. Knowing where exactly, how much the needle goes in before you dip into the anterior chamber. So initially this movement, this is 2.8 millimeters. Still here is 2.8 millimeters, still here is 3 millimeters. And your track is 4 millimeters. We found that playing in this area between 2.8 and 3, depending on your anterior chamber depth, and then abruptly changing the position of the needle into the anterior chamber maximizes the position of the needle and the tube from the anterior chamber. And also, we need to pay particular attention to make sure that the needle comes out in the same track. You don't enlarge the track, and try to release pressure on the globe so that as minimal of aqueous disturbance happens while taking out the needle. Your only incision into the anterior chamber is this 23 gauge needle track. Again, we found that trimming the tube 2 millimeters anterior to the limbus and then routing it into the anterior chamber 2 millimeters medial to the limbus, we found that we are getting an adequate 2 millimeter length of tube in the anterior chamber. Also, a 23 gauge, yeah, I'll finish in 1 minute. The 23 gauge needle generates a track in the sclera to which tubes of all modern glaucoma drainage devices fit snugly without any peritubular leakage. This sometimes becomes a little difficult to thread the tube in through this tract, but burying the tube in patient's own sclera, believe me, we have seen the results. It's a sure shot to minimize tube exposures. And tube exposures were something which probably 20 years back or 25 years back, which really demoralized glaucoma surgeons, and that is the reason why tube surgery probably did not pick up to the extent which we expected it to. So there is no patch graft, no corneal scleral patch graft to cover the tube. Most of the tube exposures happen within 4 millimeters from the limbus. So if you can bury the tube into the patient's own sclera in that 4 millimeter track, you can ensure that most often times we don't have to face these. In children, tube retractions occur, tube corneal touch occur, tube lenticular touch can occur, but tube exposures in the patient's own, if you bury it in the patient's own sclera and you have adequate conjunctival and Tenon's closure, that is something which is really taken tube surgery in both adults and children to a much more safer level. Thank you very much. And that is the supramid that was tucked in, which can usually be taken out if necessary after 7 to 8 weeks post-operatively. But we have a lot of children with supramid just there, lying there with good pressure control. Thank you very much.
Thank you, sir. Thank you. Excellent talk. I think nobody can do justice to this talk except you. I think really we are learning a lot, still learning a lot. I think this video are wonderful. And the clarity you have, how to put the tubes in talks, really excellent. Every point you pointed out nicely, how to put, it should be lateral. I think this is teaching skills we learn. Your fellows who is with me, they're doing great job because you are a wonderful teacher. Thank you. Thank you once again.
Thank you.
So now I'm requesting Dr. Lalit. He is speaking on precision of control of IOP during phacoemulsification. Over to you, sir.
Good afternoon to you all. Since we are talking so much about intraocular pressure, I thought I'll give a talk on maintaining the intraocular pressure, the ideal physiological intraocular pressure inside the eye. And the only system which I could think of was the Centurion Vision system, the phaco machine which is available, which allows us to operate at the natural intraocular pressure, close to the natural intraocular pressure inside the eye during the surgery. So usually, whenever we do phaco surgery, there is something called post-occlusion surge, and and that causes a lot of fluctuation of intraocular pressure inside the eye. So what do we do to reduce surges? One is we can decrease vacuum, decrease the flow rate, raise the bottle height, but again that increases the intraocular pressure inside the eye. We can use air pump. I've seen some surgeons using air pump, but then the chamber is so deep, the pressure is so high, not ideal for patients who are already having glaucoma and a compromised optic nerve head. We can use non-compliant tubings and a venting mechanism, just in case if the chamber fluctuation is too much. So I always felt that, we had a lot of restrictions and limitations, and we felt that our hands were totally tied. That is when I was introduced to the Centurion Vision system, which has something called active fluidics. Now I'll go step by step to explain what active fluidics actually is. So now I don't have to decrease vacuum. I can work at really high vacuum, 600, 700. I need not reduce the flow rate. I can work at very high flow rates. I need not raise the bottle height because we can work at lower or near normal physiological IOP. And we need not use non-compliant tubings. We can use small bore tubings, which is the special feature about this particular phacoemulsification machine. So the Centurion Vision system basically consists of active fluidics, which is the main part, the balanced energy tip, which is a special phaco tip, which increases the efficiency during the phacoemulsification, and applied integration, which the integration between all the machines made by Alcon basically. So the active fluidics works in 3 phases. First is the surgeon actually sets the target intraocular pressure. So to begin with, I used to set the target intraocular pressure as 50. Then now I'm operating at around 40. I've seen surgeons operating at 20, 30 also. So it's almost near to your normal physiological intraocular pressure. We set the target IOP, the patient eye level, the irrigation factor and the flow rate on the on the graphic interface on the machine. The active fluidic system monitors parameters like the aspiration, the flow rate, the infusion pressure and vacuum within the eye with the help of the irrigation pressure sensors and the aspiration pressure sensors, which are present in the fluidic management system, which is the so-called cassette. And to take it to the next level, they have the active sentry handpiece, which actually even has a sensor in the handpiece itself, which gives you real-time intraocular pressure measurement inside the eye. So all this helps us to, operate at a very low IOP, thus not causing damage to the optic nerve head. And the active fluidic system automatically adjusts fluid compression. So basically it has a back bay where there are two plates. So the sensor talks to the back bay and it compresses the BSS bag between the two plates and monitors the amount of fluid which is entering the eye. That is the beauty about this system, and I think this is the only system which has this kind of a mechanism. So the active fluidics basically consists of active irrigation, the IOP settings where we set the target IOP, the IOP ramp. I'll be discussing everything in detail. The patient eye level, and a beautiful feature called irrigation factor. So now, what is active fluidics? Basically, active fluidics is the sensors which are present in the FMS or the cassette and a back bay. A back bay is basically an area where you actually, there's no gravity fluidics, there's no pole, IV pole or anything. You just keep the BSS bag inside a zone where there are two plates which compresses the BSS bag, and that pushes in fluid inside the eye to the desired intraocular pressure which we actually set preoperatively. So what is IOP control? It's constant monitoring of the operative intraocular pressure and the rigidity of the ocular structures. It is measured in millimeters of mercury, and it is controlled by applying the pressure on the BSS bag by the two plates. And the beautiful part about this machine is it gives you the intraocular pressure in millimeters of mercury, and it also tells you how much is it equivalent to the bottle height when it's compared to the gravity fluidics. So usually bottle height of IOP of 55 is equivalent to 75 centimeters of water, the bottle height when it is translated into the gravity fluidics. So the advantages the surgeon has is he can control the IOP, the anterior chamber depth in high myopics. So if you reduce the intraocular pressure in high myopes, when you enter the eye, there is sudden deepening of chamber in high myopes. Everybody must have seen that. So that causes a lot of patient discomfort because there is zonular pull, and this is again translated on the ciliary body where there is pain. So definitely when you operate at lower IOP, the discomfort to the patient or the pain to the patient is quite less. And if just in case if the chamber is shallow, you can actually increase the IOP. So that will give you a little more space to operate. So these are the advantages of this particular system, and you can play around with this to give better results, better outcomes for your patients. And especially patients who has compromised zonules, floppy iris, this works beautifully well. The chamber is rock stable. That is what I'm trying to say. Now, what is IOP ramp? IOP ramp is one of the special features with this machine. So basically, whenever we enter the anterior chamber with a phaco probe, you must have seen that the chamber suddenly deepens, especially in myopes. So you can actually set it at the IOP ramp as 0 seconds or 2 seconds, 0 being fast and 2 or 3 seconds being slow. So if you are operating on a high myopic patient, you can keep it as 3 seconds. So when you enter the eye, it takes 3 seconds for the intraocular pressure to actually build up to the target level which we have kept. So that increases the patient comfort in these particular patients. Now, one more feature is the patient eye level. Now, this is a very important thing. See, everybody has a different OT setup. Few people, operate at very lowering the eyepiece of the microscope, or the table might not be optimum. So here what we can do is we can set up the patient eye level. There are lights on either sides of the Centurion Vision System console, and this is very important because the pressure sensors, the irrigation and aspiration pressure sensors which are present in the FMS helps us to maintain that intraocular pressure. So the patient eye level has to be kept properly depending upon the table height. And the default setting is -5, but you can actually adjust it between +10 to -40. Now this is one more beautiful feature called irrigation factor. So this is basically a factor which compensates for the fluid loss. Just imagine you have a 2.8 millimeter incision and a 2.8 millimeter sleeve. So the amount of fluid which is going to enter the eye is actually going to be more. So you can keep the irrigation factor less, say you can keep it as 1. But if you are all of us have shifted to MICS or 2.2 millimeter surgeries now. So in 2.2 millimeter surgeries, you can keep the irrigation factor a little more because the sleeve size is less. The amount of fluid which is going to get into the eye is also going to be less. So your chamber stability might not be that great. So you can keep the irrigation factor as a little more. And many a times what happens is we make our side ports, which is sometimes it's uncontrolled. So there's a lot of fluid leakage through the side ports also. In such a situation, you can again increase the irrigation factor. So that compensates for the fluid loss from the side ports. So that is a beautiful feature in this machine. And talking about the peristaltic pump, this is a comparison between the Infinity on this side and the Centurion on this side. So Centurion has 7 rollers, whereas the Infinity had only 4 rollers. So you can see that the pinching of these tubes between these rollers is actually more in the Centurion. It's at 7 segments in the Centurion vision system. So basically this helps us to, you know, maintain the anterior chamber stability more. So the post-occlusion surge is also very, very less, in particularly using the Centurion vision system. And it also has a dual segment pump. Now, the Infinity had a single segment peristaltic pump, and what happened was the fluctuation between the single fluid wave had larger peaks and troughs. But the dual segment pump, what it does is actually, you can see that the peaks and troughs are actually compensating each other. So you have a much more rock solid chamber, and I'll be showing you a video at the end of it. So there are no absolute fluctuation, there's no fluctuation in the anterior chamber at all. And plus this has a small bore aspiration tubing. The machine has small bore aspiration tubing, so the vacuum buildup is much more faster, and the chamber is much more stable. So this is a small slide on post-occlusion surge. You know, whenever there is occlusion and the piece is automatically completely eaten up, there is a basic surge, and whenever the occlusion breaks. So the recovery time with the Centurion vision system is quite quick compared to any other system. So you can, what I'm trying to say is you can actually operate at a target IOP, whichever you set, whether it is 30, 40. So initially everybody starts at maybe 50, which is equivalent to around 75 millimeters of bottle height compared to a gravity system. And as you progress, you can reduce it to 40, 30, you know, and the chamber is rock stable. The only thing which you have to change is the irrigation factor and the vacuum rise time, which you can play around and have rock solid chambers and clear corneas. One more beautiful addition to the technology is the balanced energy tip. So the balanced energy tip is, I think I'll just take one more minute, is almost like a straight tip. See, we are all used to using straight tips with our previous phaco machines, and now we have shifted to the Kelman. Now the balanced energy tip, the amplitude, the movement, the torsional movement is around 190 microns. So you can imagine, compared to the Kelman tip, where the movement is only 130 microns. So the phaco cutting efficiency is also much better, and this tip works like magic in really dense cataracts. Believe me, you can do any grade of cataract with this particular kind, using this particular tip. So to finish my talk, I would like to say that active fluidics is a wonderful technology, and we should all try to adopt it, because it allows us to operate at very low or near physiological IOPs, and the chamber stability is rock solid. The balance energy tip has increased the efficiency of the phaco, you know, so you get much more clearer corneas, and you can handle any grade of cataracts. And the applied integration, where one machine talks to each other. So if you have a Verion, if you have a Centurion, if you have the Lensex, they all integrate to each other. They guide us where to put the incision, how much of astigmatism will be induced. So that is the beauty about the applied integration. Thank you for the patient hearing.
Thank you, Lalit sir. Excellent talk, making it much simpler and easier to understand the fluidics. We have question later on, end of the session.
Definitely.
So now I invite Dr. Meena madam to speak on uveitic and neovascular glaucoma. Can I have one question to you, sir? So did you see any difference between doing the PACG cases versus POCG cases? PACG cases, what the IOP you keep in such cases when chamber is very, very narrow?
Okay. Now, whenever the chamber is very, very narrow, you can actually increase the intraocular pressure. That is one thing which you can do. Or you can also increase the irrigation factor. So both these things actually push in more fluid inside the eye. Okay, so that makes sure that your chamber is a little more deeper compared to a patient who has a little more deeper compared to a normal, patient where the anterior chamber depth is quite good. Usually PACG patients have a narrow, shallow chamber. So this you can manipulate here. Like basically in normal gravity fluidics, you increase the bottle height.
Yeah.
You need not do that here. You can increase the intraocular pressure a little.
And what's your target IOP, especially is in high myope, like operating in 26 or 27 axis length. So what IOP you keep in such?
I usually keep it between 30 to 35, sir, in high myopes. Normally in all my cases 40, but if the chamber is too shallow, I go up to 55 also, sir. This is my usual.
No, I'm talking about high myopes. High myopes.
High myopes, you want the chamber to be, see, high myopes already have very deep chambers.
Deep chamber, yeah.
So you can actually reduce the IOP. I keep it at 30.
Okay, 30, okay. And have you any chance to operate on nanophthalmos cases in such cases?
Not
doing
really, sir.
phaco?
Nanophthalmos, microphthalmos, I have not operated much, sir. Not
Okay,
really.
okay. No,
Maybe.
just I want
No,
to-
I have not operated.
And I think this technology works beautifully when we're dealing with nanophthalmos. There's active fluidics going to play very helpful to the phaco surgeons to maintain the anterior chamber and making surgery much more comfortable.
Definitely, definitely.
Right, thank you, sir. Yeah, over to you, ma'am.
Good afternoon, everyone. I'm expected to cover both uveitic and neovascular, which I don't know whether I'll be able to give justice to two large topics. But first of all, I would say uveitic glaucoma is one of the most difficult forms of glaucoma to manage because you have to address two prongs. That is, one, the elevated IOP on one hand, and the other, you have to control the inflammation wonderfully well. And second thing is you have to differentiate between uveitic ocular hypertension and uveitic glaucoma. Uveitic glaucoma occurs when you have progressive neuroretinal rim changes with or without field effects. So the entire manifestation depends upon the etiology, and the etiology varies with ethnicity as well as location as well. And what are the etiologies? So you can have joint diseases contributing with the juvenile idiopathic arthritis, ankylosing spondylitis, psoriasis. Infective causes, you can have toxoplasmosis presenting with an reactivation presenting with a high IOP, the herpetic groups as well coming with high IOP. Other diseases like the Posner's coming to you with an acute rise, Fuchs, the VKH, sarcoidosis, pars planitis, all of which we see in practice. And in Grant syndrome, you just get precipitates and they respond to steroids but not to the anti-glaucoma medications. The prevalence is about 10 to 20%, of which we can see in this table varied prevalence, and herpetic keratouveitis ranks up there at 54%. The pathogenesis, in the initial phase, obviously we are expecting a ciliary body hypotony and low IOPs, but there is a decrease in the conventional outflow as well as an increase in the uveoscleral outflow, and immune-mediated cytokines, interleukins, have a role in the elevation of IOP. Herpetic as well as in Posner's, you can have direct insult on the trabecular meshwork and trabeculitis as a cause. Mechanisms, you can have open angle as well as the angle closure variety. As well as in the open angle, you can have steroid-induced effects. In angle closure, you can have without pupillary block, posterior peripheral anterior synechiae contributory, and the inflammatory membrane contribution in the ocular ischemic syndromes. So first of all, you have to do gonioscopy, find out open angle or closed angle. If open angle, look for iris pathologies. If you see sectoral atrophies, you can think of herpetic zoster, etc. Heterochromia, think of Fuchs, and the pigment atrophy, etc. Think of uveitis glaucoma, hyphema syndrome. And if the iris is normal, then in a child, you can rule out rheumatoid JRA. And recurrent attacks, think of Posner's. Then you need a close association with a rheumatologist as well. Closed angles, again in hazy media, UVM is useful to know what is the causative factor behind. And coming to the signs and symptoms, you can have congestion is there, raised IOP, and you have to look for the KPs. What the type of KPs are there, and management of the inflammatory condition is the key factor in the management further. And in investigations, I would say that do not do an OCT in the active phase because always you may get false results. Management, again, I said identify the etiology and treat it. Steroids are the mainstay of treatment. If it is a steroid responder effect is noted, go for immunomodulators. The angle closure, the seclusion pupic can be managed. The iridotomies for the iris Bombay, multiple iridotomies, and if there's neovascularization, now you have the combination therapy with the anti-VEGF followed by aggressive PRP, and phaco combined with goniosynochiolisis. I would say that even now, there was a hype that it's the GDD, glaucoma drainage devices, which are preferred in uveitic, but I would say that with the advent of the anti-VEGF therapy, there is a big role and change come up with 3 to 5 days prior to surgery, give the anti-VEGF, control the inflammation, control the new vessels and new vascularization, and do an augmented trap, which is said to be successful. The encapsulation of the bleb, I'm sure Dr. George would be the better person to talk about the role of the GDD. Is it still the top in the management of uveitic glaucomas? And for the MIGS, Dr. Devendra, there are reports on eye stent, but I don't have much of an experience in this direction, because I would say in uveitis you expect PAS, and I don't think that MIGS has a great role in the management of secondary glaucomas due to uveitis. The cyclodestructive procedures, especially the TSCPC, holds good if it is even, you can spare one area for the trap, and you can go up to 270 degrees, but limit the quadrant. And this is one case who came to me with a CF 3-meter vision, pseudophakic 4 years back, done elsewhere, and a lot of mutton fat KPs and CF 1-meter vision, long-standing vision diminution. And he had multiple mutton fat KPs, which actually with the start of oral acivir as well as ganciclovir gel, we found in 2 weeks' time a good amount of reduction of the mutton fat KPs. And the vision, however, did not come up beyond 660 because of the glaucomatous optic atrophy, since it was long-standing. So what I would like to say is that this is the open angles, no sine K. So it's a hypertensive unilateral panuveitis where viral etiology was the cause. And he is still due for follow-up. And I would say that he has done well with good control of systemic management. Coming to my NVG series, this patient came to me, 68-year-old hypertensive diabetic, coronary artery disease, recent hemiparesis, and with unilateral 3-month duration of vision reduction. And he had NVI peripupillary unilateral 360 degrees. Note the fine tufts at the pupil margin, and the anisocoria, and we suspected ocular ischemic syndrome, and though there were not multiple hemorrhages, probably it was a little old. The disc was pale and aggressive, referred to the retina department for aggressive PRP, and the FA really shows the delayed arm retinal time, which actually clinches the diagnosis of ocular ischemia, even though there are no hemorrhages, and the Doppler revealed it. So aggressive PRP done inferior, and in a 3-day span, the superior as well. And we have seen that despite it, there has been hyphema, and there is a little bit of worsening. The second case is actually, you can see a patient came to me with a IOP of 50s, and the right eye, he came as the last patient towards the OP end, and we sent him on maximal topicals and systemic, and he was again unilateral neovascularization, florid with corneal edema. Next day itself, you called him up for a detailed evaluation, and we found florid NVA in all the 4 quadrants, and we found a bleed in the right eye. But when you look back, the same patient had attended the retina department with a CRVO in October and had undergone a significant PRP and had improved, but still came with a recurrence as an NVG. And despite all the aggressive treatment of PRP sessions, the patient actually went in for a synechial closure in 2 weeks' time. And so what is going to be done next? I would say when you have closure, you have to think of a surgical intervention after aggressive control of the neovascularization. The third case is a patient who is a POAG for long, as well as diabetic, had PDR, came for cataract surgery, and was found to have PDR. So PDR is, in this case, another cause for the raised IOP, but understand that the other eye status of advanced management differs. And he underwent combined cataract with vitrectomy in one eye and is being followed up on anti-glaucoma medications. So neovascular glaucoma is a blinding, intractable secondary glaucoma, difficult to control IOP, progressive closure is there. In hospital setup, the prevalence is not that low. CRVO, diabetic retinopathy, PDR, and ocular ischemic, very, very common etiological factors, but you can have other causes like inflammatory, retinal detachment, tumors, then other systemic diseases as other causes. So 97% cases it is retinal ischemia with diabetic retinopathy, PDR about 33%, and CRVO as well about 33%, and occlusive carotid artery disease about 13%. In 3% cases you can have inflammation without retinal ischemia. In this slide, you can say that because of ischemia, you basically will have the VEGF causing leaky vessels and NVA setting up, and the transforming growth factor breaks down the blood-retinal barrier, and you have a lot of fibrovascular proliferation. So you have synechial closures coming up. And this is an interesting table which I found in an article in the IGO, where you can grade the NVI and NVA and the stage of the disease based on if it is more than 2 quadrants. And these are the few tests which have to be done to screen all patients at risk. So determinants of the disease are potential, visual potential, and media clarity. Treat the retinal ischemia, treat the underlying systemic disease, control the IOP, avoid miotics, and control inflammation with cycloplegics and steroids. And in surgery, I would still say with the advent of the anti-VEGF, TRAB still, augmented trabeculectomy is the treatment of choice. And when not, and probably the drainage devices, GDD, should be reserved where filtering surgeries are not feasible or for patients with persistent new vessels. And here, like I said in my second case, the moment you have progressing synovial closure with a good disc and a chance for saving that disc, go for surgical intervention alone. This is one of the patients who had bilateral NVG because of PDR, but she underwent complete PRP and an early TRAB augmented, because of which she has still got good results in that eye. But cases like this, which have, this was a chronic postoperative glaucoma, which has a bleed, which had no vision, but in cases which have like this, do a B scan, and if the patient is symptomatic, what do you go for? What are the management options? So cyclodestructive procedures can be done if the patient has pain, and those include the TSCPC, the cryo, the diode CPC with the ARC, or endocyclophotocoagulation, or endocyclophotocoagulation can be combined after IOL surgery or after vitrectomy. This patient had actually bilateral NVG, IOP of 56 and 62 in either eye, but left eye had a mature cataract. You can see the NVI crossing and across the collarette. So it is very advanced, and the other eye, so don't give up hope on treating the 56 IOP in the right eye, because this is what was done. A B scan was done, which was relatively normal. So an anti-VEGF was given, and 6 weeks later, note how good the eye is, despite a low vision, which is attributable to the cataract. So we have a hope of saving that eye if you do a combined surgery. So the take-home messages are: recognize in patients at risk, recognize NVI before angle closure, correct the underlying pathology, early diagnosis and a systematic multidisciplinary approach preserves useful vision, and with the advent of anti-VEGFs, a dramatic outcome improvement has become a reality. Again, in uveitic also, the risk factors have to be assessed for elevated IOP, for steroid response, and early diagnosis is very important, and strict control of inflammation before surgery and aggressive post-op management of the inflammation are mandatory for successful outcome. Thank you.
Thank you. Thank you, Meena Madam. Covering the both topic in short period of time, beautifully covered, very illustrative talk. Now I request Dr. Swapna Madam, he is discussing some of the cases. So I request Dr. Jaj sir and Dr. Lalit sir to put your inputs, need your inputs for cases.
Yeah, like Dr. Devendra said, this is a very selfish part of the program because I wanted specific input on how to manage post-refractive surgery glaucoma, which is becoming very common. So I just want to show a few slides. These are namely patients that I've met, and I just wanted a very short input on what you do in your clinical settings. So now this is a post-LASIK patient who had trauma followed by angle recession, and this is how he presented. It was done elsewhere, the trauma happened elsewhere, and he presented to me. So you can see that there is some interface fluid over there, so he had come with glare and halos, and it's the OCT which revealed the interface fluid. His IOP was, mind you, in the low 20s, though the cornea looked like this. Now, once AGMs were started, this is how he responded. You can see that the fluid has gone off, but there is still flap granularity, so which indicated that the IOP was not completely resolved. And later on, when it resolved, I got another complication because that potential space was opened up. There was epithelial ingrowth into the space. So again, he is a steroid responder. So now that is the story continues. Another patient, she's a medical student who had conjunctivitis post-LASIK.
Can we discuss one by one, or?
No, I think I'll just present these slides. I want a general discussion on the topic. And you can see the interface opacities that have happened. So naturally, like any other cornea person, I started on steroids, and she was these things went off. But then again, she turned out to be a steroid responsive. Again, her IOPs were not proportional to, you know, the amount of steroid put, or even when you withdraw, it didn't come back fast. And her pachymetry, please note, was like in a regular post-myopic LASIK case. So it was not as if her cornea was swelling up inadvertently, but she started showing some disc changes. So this happened over a course of 6 months. Now the third and the final part was an ICL patient. So he went off, had a good ICL in the other eye. He came for the second eye, and following the ICL, he was fine till he was discharged. In the evening, he started calling up saying he has some pain, and next morning he presented with this kind of a dilated pupil and a lot of pain. His IOPs were raised. So again, I thought the pupil was stuck, and you know, there was some problem with the drainage, so there's a hole in the center for the new ICLs, but it was not responding fast like a normal angle closure. We tried using pilocarpine, it was not coming back. So I realized it's Ured Zawali, it's rarely reported, but there are few cases in literature which have been reported, but this is seen, and it usually happens in one of the eyes, and it was a very slow comeback from the wide dilatation. The IOP also fell in a very, very phased manner, and now his pupil is actually more physiological, but you know which eye this happened in because it's not as equal to the other one. So these are some of the scenarios. So my basic questions are on how to manage a post-LASIK glaucoma where you don't have any indicators, like even if the pachy is normal, or you cannot rely on the GAT. Secondly, what do you do in steroid response? I mean, what do you want to get rid of the SPEs, or do you want to manage the glaucoma? What is the kind of dosage you'd like to keep them on? That is it. So the panel, I think I'll start with Dr. George. A mic, please.
Luckily, the third patient is settled down. We don't need to do anything for the third patient.
Yes, it was not persistent.
It's settling down.
Yeah, it was a one-time event, I should say.
One time. So, and the first patient is still having a corneal problem.
Yes, he after his edema went off from the interface, he had corneal granularity. Again, that was controlled by anti-glaucoma medications. But because of the epithelial ingrowth, there is recurrent inflammation. So I need to keep on putting in steroids, which again is causing a rise in IOP.
And how's the fundus? How's the fundus?
Fundus as such was not showing any changes. So the fact of the matter is the patient is lost to follow-up right now. So it hadn't started showing any disc changes.
Probably you deal with this like any other glaucoma which doesn't respond to medical treatment. You need to have your field evaluation and your disc evaluation very carefully to exclude progression. If there's absolutely no progression, just continue on anti-glaucoma medications. Along with whenever you need to give, if you feel like, see, either way you lose. You take out steroids also, you're going to lose the clarity of the cornea even further. So as long as there is no progression of optic nerve head changes, no progression in the fields, continue what you have to do. But if there is progression, I think we have no option but to risk a trabeculectomy in this patient.
So the indication, yeah, for surgery would be?
Definitely, even for this patient, and also, if I'm not mistaken, the second patient also, where you say there is a lot of steroid response and the namula scars are still remaining the same. But I'm not sure whether the namula scars are going to come down if after a certain particular...
They disappeared. Then I stop the steroid or taper it over a very long time. Then slowly they start coming back again. I start the steroids, and this was the second or third phase that she started having a steroid response.
And this typically looks like reactivation of viral keratitis.
Yes.
And I'm hoping that the patient is not on prostaglandins.
No.
Because prostaglandins have rarely been reported to have a reactivation of viral keratitis. I think here also, if there is progression, I think we will have to risk a filter. Because it's very important to know that once you have progression, whatever you do with medical treatment, you're going to spoil the conjunctiva even further. See, one fixed combination and a third medicine probably is what, because you talk about rho kinase, you talk about adding the fourth medicine, in the prolonged run, the chances of filtration success is going to be minimized with prolonged medical treatment. So if there is progression with whatever maximal available treatment you're doing, I think you will have to risk a filter in both these patients.
Thank you, sir. Dr. Devendra, your take?
For your second patient, I don't think it need any kind of treatment. It's quite frequent. Either it is a LASIK or without LASIK. Such kind of patient have reactivation quite frequently. I personally don't use steroid, even the low dose steroid, until unless they are hampering the quality of life or deterioration of vision. If patient is comfortable with nebular scar, really not active lesion we find out, don't start any low dose steroid, just give him the NSAID and give the lot of lubricating. And I personally, I have experienced such patients, so what I used to insist them, use the lubricating drop at bedtime, just before sleeping, either put the gel or either put the whatever the sodium hyaluronic, the drops are using, put at just bedtime. And just keep on for the 2 to 3 months for the chronic lubrication therapy. So such patients the lubricating drop works very well for such patient. This is for second number of the case. And third number case, if the arrest jubilus syndrome is there, then really I think you have done nothing to do much. But what we do in routine practice, always check for the central hole, what we get in an ICL. Sometime despite of the hole, they go into the such kind of picture. So in our routine practice, we don't have that clinical study, but in routine practice, we do the external one more PI before any ICL patients. Because we have seen even with all the ICL cases, either biotech or any other eye care also, so we routinely do one extra PI for such cases in routine practice. First case, I think I don't start treatment, as Joshua told, I don't start treatment unless I find the IOP more than 25 or 26. There is no high risk factor, no further risk factor for having glaucoma in such patient. Just keep an observation, look for the optic nerve head, OCT and visual field, and just observe them. Unless it's not progressing, no treatment.
Yeah, regarding the first page, what you said, I would beg to differ because the patient had a definite angle recession and he had been normal till before trauma, and you could see fluid in the interface, so something must be driving that fluid there, which probably is the intraocular pressure because I cannot think.
Probably, I not agree with the patho mechanism what you are saying. I don't know, but usually if the angle recession is controlled, till now really it's not having developing any glaucoma. Even so many angle recession we used to see, until unless patient don't developing any kind of glaucoma, any kind of optic nerve changes, we don't treat. We just keep eye on observation. We do the serial evaluation for 6 monthly. We don't treat angle recession only.
Thank you very much. Dr. Lalit, any opinion on this?
As sir said, my take on it is, instead of using a stronger steroid, you can use maybe FML or lotiprednol really works well.
No, lotiprednol is what the second patient was on, and she
so
had
she
a
responded
response
to that also.
Yeah, that is where I was thrown off balance.
You could actually try FML. I don't know. I have not seen much responsiveness to fluorometholone compared to lotiprednol. That's one thing. Second thing, the second patient with viral, I'll actually put this patient on antiviral also, oral. That somehow, works maybe for a long time, maybe 3 times a day for say 5 days, and then 400 milligram for a month or 1.5 months. This is something which I've tried and it works well. That's one thing. I think that's pretty much it. I would use a shorter steroid. And regarding the epithelial ingrowth, if it is coming into the visual axis, we don't have a choice. You'll have to actually lift the flap, scrape it off. And sir, one more question which I always had in my mind. This is to the panel, to everybody. What is the effect of oral steroids on intraocular pressure? Because I generally, whenever there is inflammation and there is raised IOP, I put the patient on oral steroid for some time. I've seen that does not have much impact on the actual intraocular pressure, but I don't know, maybe it's open to discussion, because that is how I manage. In fact, I would have put the patient on oral steroid, put the patient on FML if the inflammation was really much. So this is what I generally do. I don't know what is.
This steroid response is almost always corresponding to how much of you have these acetate and phosphate preparations for steroids. So you have prednisolone acetate, which really diffuse goes into the eye, which crosses the cornea very easily, cornea-scleral junction, and it is directly proportional to your anti-inflammatory property and also directly proportional to your IOP rise. So all prednisolons available are prednisolone acetate. Dexamethasones and beta-methasones are also available in the acetate format. So these are very potent steroids causing lot of anti-inflammatory effect, but also has the propensity for IOP rise. Luckily, in the Indian market, many of the dexamethasones and beta-methasones are phosphate preparations, which don't get into the eye as much as your acetate preparation. So that is one thing the postgraduates can keep in mind. Phosphate preparations have a lesser propensity for intraocular pressure rise. Second thing what Lalit was raising, I think we don't have much evidence in literature, but anecdotal, I also agree with what Dr. Lalit says, that oral steroids may not increase pressures as much as topical steroids. But again, there is a beautiful classification in one of the BJO articles where some of the, a certain percentage of population are very high steroid responders. So irrespective of what you give them, the steroid response is going to be very high, and it's going to be very fast also. I don't think we have a full solution to this rather than making sure that the glaucoma doesn't progress.
Thank you very much.
This one more, what sir told, this systemic steroid, really in short period of time it works well, but suppose it's a long period of time, chronic therapy of steroid is always cause the high responders. And really we see the very, very bad glaucoma, especially the asthmatic patients. You use the very low dose steroid in inhaler form. Sometimes they don't tell you. Sometimes some of the SLE patient and some of the skin diseases patient, they use little bit oral steroid on and off. Some asthmatic patient, they take the tablet just to have the oral steroid, one sort of injection. Then they say, I don't take any kind of steroid. They don't reveal you. But really such oral or systemic steroid can also produce the glaucoma or high IOP.
I think these were some of the take-home gems that I myself wanted, and I want any refractive surgeon in this forum to have. Thank you very much.
So, I think this is the end of the session. I will ask Girja Madam to just concluding remark from Girja Madam.
Thank you to all the speakers for their excellent talks, and we are running behind schedule, so we will stop just now and leave the place for the next session.
May I request Dr. Sushila Binair to present a token of appreciation to Dr. P.S. Girija Devi.
By the meantime, any question from the audience? No? I think everybody is hungry. I think it's a
when we do in PACG cases only cataract, there is lot of positive pressure and every side port, main port, iris started coming. That point of time we have to decompress the AC. But sir told when we are going to increase the IOP, like it is contradictory, how we will do?
No, not increasing. The machine IOP is increasing.
The machine even if
I didn't say, you mean the shallow chamber increase the... See, in such a situation, I know, this
So
is a very...
I
Sir will
will
answer the
answer.
question.
So what you are asking, whatever he is talking about when the crisis not happened. Yes. Okay, you are talking about when you already made the crisis, then you asking taking his point to increase the IOP. He is talking about the IOP when you beginning your surgery, starting your surgery, keep your IOP high to make the anterior chamber deepen. Not at the time when you come into the crisis, your iris coming from the both side port, really nothing. First you have to put the IV mannitol, deepen the chamber, and devolume. I think put the IV mannitol, keep a IOP low, then proceed for surgery.
And try to, if possible, try to do a one-hand phaco. Don't use a chopper or something. You know, if you
Sir, everybody is not expert like
No,
you.
I'm just saying, sir, that if you can, try to divide and conquer or do something, do a one-hand fake or don't do much manipulation inside the eye, try to get the pieces out. That's the plan here.
Right. I think, thank you. I think we have, start the next session. Huh?
Inviting Dr. V. Sahasranamam to present a memento to Dr. Sheba C.S. Next, we move on to the pediatric ophthalmology session. It's a great honor to invite Dr. Sushila B. Nair, President, Trivandrum Ophthalmic Club, Senior Consultant in KIMS Hospital, and Dr. V. Sahasranamam, Senior Consultant and Director in Academics, Chaitanya Eye Hospital and Research Institute, to chair the session, and Dr. Swapna Nair, Senior Consultant in Sreenethra Eye Care, to moderate the session.
Warm good afternoon to all of you. So we'll go to the first topic, which is of too much importance nowadays. They say that by 2050, almost 50% of the global population will be myopic. So let us listen to Dr. Ramesh Kekunia regarding how to control myopia or make their lives a little better. Over to you.
Okay, good afternoon, and thank you, Sreenethra team, especially Dr. Swapna Nair, for this invitation. It's always nostalgic. Most of you don't know my home state is Kerala, so thank you so much for having me here. I'll be talking about comprehensive approach for myopia management. I think the refractive surgeons might feel that we are reducing the myopia, but it's not the case. There are always cases for everybody. So it's an epidemic cause for concern, because if you look at this map, everywhere around the world, the number is going up. Most of this is in the urban population, but also in the rural population it's going on, be it from Africa to India to Asia to anywhere, it's going up and up. What is our target is, myopia is there here. Can you see here? These are all myopes. Can we prevent this myopia? That's number one, if possible. I think there are some remedies where we can. Can we identify some of these are high-risk patients? Can we identify early so that they don't grow to the potential growth of myopia? And third part is difficult, very, very difficult in my opinion. This part of pathological myopia, we may not be able to do anything at this point of time. So what are the management options available to prevent developing from myopia, and once they develop, myopia progression? Lifestyle modifications, all of you know. Pharmacological therapy, optical, both spectacles and contact lenses, and orthokeratology. Why this is important? Anybody sitting in this hall can manage this, provided you know the concept. It's not that only pediatric ophthalmologists are required to control this myopia. Obviously, the family history, lifestyle, sports, academics, parental concerns, all these are important. But at the outset, I would like to say that it's not the screen time and the reading. Many people blame many things on screen time. That's not the only thing which leads to myopia. There are family histories, other things which can lead to. But at this point of time, it's not that reducing the screen time will lead to, not developing myopia. It's more and more proof is coming in terms of outdoor activities, outdoor games, outdoor lightings, and the sleeping behaviors. These are more important in developing myopia, or if they develop myopia, in preventing the progression. So this all of us has to understand, and if you see this, any child in this range, people say that, okay, once myopia starts, let's begin this process. But in my opinion, anybody who is coming to your clinic for screening for refractive error, even if they are low high probe, we need to, or most of the times I see a lot of astigmatism, kids coming with just astigmatism. After 3-4 years, they develop this myopia also. So we need to consider them also. Obviously, education and other related activities are important, as you can see here. But what we do is every 3 to 6 months, you monitor what is happening to them. This is the kind of activities what we need to do in these 3 groups, what I said. Because people talk more and more about, moderate myopia and severe. But your myopia management starts much earlier, which we all see in our clinic, be it a pediatric ophthalmologist or general ophthalmologist, anybody, we see this kind of patients. But if they are stable here, this is very important what I'm showing here. If they are stable, routinely it's less than 0.5 diopters per year, you can probably observe. If it is not more than 0.5 diopters per year, it's time to do something to them. So what is that something you will do? Obviously, you need to measure axial length and also do a cycloplegic refraction every 4 or 6 monthly. And the simplest thing what you can start is the pharmacological treatment, that is 0.01%. It's available everywhere. Sometimes alternatives. How to start this alternative? This is the scenario most of us will be there seeing this. What are the alternatives also? I will tell. If they are stable, the atropine treatment does not stop in 2 months or 3 months. It goes to year, at least 1 year, 2 year or 3 year, depending upon the age. If they are progressing, you can continue. You can even make it BD dosage, or you can even increase the dose to 0.05%. Or else you have other things, like you need to measure everything. You can do these kind of things before you consider stopping the myopia treatment like atropine. Minimum course is around 2 years, minimum. And this is a quick table. I don't want to go into the details of all these studies, but this everybody should know. 1%, 0.5%, 1%, 0.01%. Look at the myopia progression between this. Look at the rebound phenomenon. Lower the dose, rebound phenomenon is less. Higher the dose, prevention of progression is higher. So more and more things are coming in terms of, this is the latest study. The recent study, LAMP2 also has come just 2 days before. So more or less, this is a good dose to start. It's not the 0.01%, it's the 0.05%. It's not still available, but it will be available soon in India also. One of the things what we need to know is the peripheral refraction of the patients. Without that, we can't customize. I'll come to the customization of the treatment. We are developing one of the peripheral auto-refraction, which is cheaper. This is around 30 lakhs, but Eli Prasad's Center for Technology, which will develop in the next 4 to 6 months, it will be available for everybody, which will be cheaper, so that we can do. Whenever there is a retinal peripheral hyperopia, if you do a peripheral refraction, this is one of the lens. DIMS is called. You can see the difference between the DIMS lens, single vision lens, highly aspherical lenses, how these things are. There are around multiple defocus segments in this DIMS lens. I'll show you in this video. Hopefully it should run. See this? Multiple defocus segments. This is something non-invasive. We don't even have to put a drop. This is, you can start a little bit early also, because all the atropine studies have started from 4 years onwards or maybe 5 years onwards. For a child whose parents are highly myopic, very high chance of progression, this could be one of the things to start also. So this is the step ladder approach you can take in this patient. But for me, how do I decide for a given patient? We have developed this kind of myopia kind of pyramid. You can see, always do the refraction, check for any kind of alignment problem, then look at the axial length, see what is happening, and also the refraction and other things you can do. Then check the family history. Everybody who comes, they should get these things done. I know it's a little bit tedious for a myopia, but if you want to make a difference to the child's life, we need to do that. Obviously, open refraction, if you can have. The base is that more outdoor games. This is something we can advise to most of these patients. Second thing is not under-corrected glasses, fully corrected glasses, and then probably the drops, atropine, 0.05 is the most preferable one. And then in some patients we can start bifocals, and some of the patients I said if they have a retinal peripheral hyperopia, you can start this Hall or DIMS, defocus integrated multiple segment there. And also you can use in some extreme cases orthokeratology. This is what we have. And never forget the sunlight. More you follow the sun, less the chances of having anything. Because earlier days what used to happen is 6 o'clock or 6:30 people used to get up, or maybe a little bit early. Everything used to close at 6 o'clock because there is no electricity. Things are becoming more and more once the sun sets nowadays, if you look at. And earlier parents used to call the children home. Now we have to send them out so that they can play. So that's the change what has happened over a period of time. So sometimes atropine plus DIMS lenses and probably ortho-K also can work in this kind of patients. So this is the base up approach what you can have for myopia. But always never forget cases like this. This is a microspherophakia on atropine for a long time. -11, obviously because of this Wells-Marchesani syndrome. You can see here, you can see the axial length is 22. Lens thickness, look at this. Whenever you do measure something, look at in total, never forget comprehensive examination of a child. You might miss some of these cases. High myopes, it's not going to work. When you have an axial length like this, it's not going to work. ROP, retinopathy of prematurity, already they have a retinal peripheral defocus. It's not going to work. As of now, there is no data saying that atropine is going to work. It's mostly a lenticular one. So this is the last slide I just wanted to share. What is the consensus guideline? These are guidelines what we can give in terms of any patient who comes with the myopia, identify a case of true axial myopia. This is the first step we should do. Second step is identify the risk of myopia. You know, where both the parents are myopic, then the chances are more, and then there are other history which can tell that, okay, sibling has -6. Identify the risk of myopia progression and measure it, how much it is progressing, both in terms of refraction as well as in axial length. And the third point is identify the potential risk factors, whether there is more of a near work, lag of accommodation. I just forgot to tell every patient check the alignment. If they are esophoric, probably better to give bifocals. If they have lack of accommodation, you can probably give contact lenses. So depending upon that, you can give the treatment strategy. And recommend appropriate treatment. This is the fourth step. What is appropriate? I'm coming here. Relative peripheral hyperopia, defocused glasses are good, or orthokeratology. But this is available, the limitation is this is available only up till -10 diopters. Beyond that, it's difficult to give. If there is a high lag of accommodation, so you can give central distance, EDO design, or bifocals of pads. Because why am I stressing is these are the things except for the peripheral refraction, everything we can do in our clinic. Wherever you are, you can do it in the clinic, it's possible to do it. If they have near esophoria, you can give bifocals or PALs, and low dose atropine in all of these cases, probably it will work. These are guidelines which can help you to customize the treatment for individual patient. And the fifth one is monitor the efficacy. Unless you monitor, you are not going to get anywhere. This is important to monitor. At every 4 months or 6 months, you need to do it. And the sixth one is starting combination therapy in some patients. It might work, but the evidence is not very clear on which cases it will work, which cases it will not. And finally, tapering the treatment. You need at least 2 years of stability before you stop. Age, I have put it around 17, but most of us do it around till 14 or 15. But if somebody comes at 17, just before they are into that LASIK, I want LASIK, probably if they are still progressing, I will start one of the strategy, especially this one. And the last slide I wanted to share is there are 4 M's in myopia mantra. Master, understand the multifactorial nature of the disease per se, because we don't know, there is no single gene which can cause high myopia or moderate myopia. Measure the X factors, estimate and quantify the possible myopia risk factors, and monitor closely. When I say closely, around 4 or 6 months of gap we need to see, and start with management of appropriate myopia management strategy. Thank you so much for your kind attention.
So, thank you, Ramesh. So regarding, as you said, now it's attributing everything to screen time. But I think even in the pre-COVID days, regarding the studies which have been done regarding the incidence of myopia in Far Eastern countries, where the incidence is very high. So more of near work, early schooling. So because most of the developed countries, they start schooling by 6-7 years, where we start here by 2.5-3 years. So early schooling, more of near work. So that I think still works. So when we say screen time, we mean to say it's more of near work. So especially studies which have been conducted regarding increased myopia in COVID days, though it's short-term studies, we can't comment very much on those studies. But I think more of screen time means more of near work. So near work naturally adds on to myopia, as we always say on all the studies. And I think, as we said, we should encourage students to move outdoor games. So even now in flats and all, whatever games, it's all indoor games. So in bright sunlight, outdoor games, I think parents, school teachers, all we should educate them.
Yeah, well, absolutely right, sir, in terms of near work and screen time. Because if they are working a lot on studies and everything, even indirectly their outdoor activities also comes down. And as you see more and more recently, everything is around, indoors. So it's all a surrogate measure. If they do more and more near work, more and more studies, it's not that they don't have to study, but they have to kind of work towards this achieving outdoor games as much as possible within their own thing. Especially in India, it's possible. If you talk about Middle East, it's not possible, because outdoor is so difficult to go there. So because of summer, all that. So it's multifactorial, but what we can do from our side, we need to do it. Like in Ali Prasad, we have this pyramidal model. When you are in Hyderabad, the incidence is very high of myopia. As we go down to the secondary center on our monthly visit, when we do a 80 or 50 OPD, we hardly see any myopia. Why is that? Because urbanization and other things, we are still seeing it in 2023. So there is a significant difference and a divide between the urban and rural population. This is very, very clear. Yes, ma'am.
Is there any degree of myopia where you think about defocusing lenses and orthokeratology lenses, all those they are given to wear? Even simple myopia less than 6 diopters, do you have to give all that?
Yeah, orthokeratology is a little bit, it's practiced in some patients, but I would not start it as a primary first line therapy. But you asked about defocus lenses, we can start as early as 3 years or 3.5 or 4 years. If there is a definite history of progression, we can start. Only thing is, when the child sits in the front row or maybe in the back row, the board may become a little bit hazy because there are multiple segments. Instead of 6.6, they might be having around 6.9 or 6.12. So that modification we need to. But there is no age bar to start these DIMS lenses. We can start early. Orthokeratology in a 4-year-old or 5-year-old, I will not start them as a first line therapy. I will start them little bit beyond when the primary first line treatment does not work, especially 8 years or 9 years or 10 years old. That kind of thing.
Okay, thank you.
Hello, sir, just one question.
Good.
For the low dose atropine, you told that high myopia. So up to what range you usually give low dose atropine? Do you give beyond -6 also?
Yes, I give beyond -6 also, -6.57. There is no limitation to use that. But again, the higher the myopia, you might have to use it, higher the dose. And maybe sometimes there is no, that particular literature is a little bit hazy, but I will increase the dose if they are fast progressing. For example, -7 comes. They are progressing in a rate of -1 diopter per year. Then probably we need to be aggressive. We might have to start combination therapy like defocus as well as low dose. But defocus, as I said, there is a limitation of only -10 we can give it. So it's a case-to-case basis. We'll start combination therapy in these patients.
When do you stop, Dr. Ramesh? Because you were talking about rebound, which we all say. So, what is the time period when you're sure that this is a safe case and whatever rebound happens will be, negligible?
Yeah, again a case example, -3 diopters, 6-year-old has come and under your follow-up on low dose atropine. In the first visit you have seen 0.25 increase, which is negligible. Without that change also, child is seeing very well. I'll continue. Maybe in the second visit also 0.25, not much of a change. Vision is stable. Axial length is not exactly at the same spot, maybe 0.05 difference. Probably I would continue it for another year and probably stop. But looking at the history of the child, and if the siblings are really gone beyond that, probably I would continue. But even if you stop, you will have to see them very closely. It's not that now I am stopping, I don't have to see. Maybe in another 6 months they will have a rebound phenomenon. Probably we'll have to start them again. So I will not stop immediately. I will ask them to use it on alternate day, maybe for 6 months to 1 year. Then once I'm sure that it's not progressing, I'll stop. But these kind of kids are very rare at 6 years or 7 years. I've seen 13 years, 14 years becoming stable. Many kids are there. At 6 years, 7 years, it's pretty rare to have this kind of group of patients. what's the earliest for the atropine? Personally, I have started at 4 years. Even if you look at the LAM study, they have started. But before at 3 years or so, we can still start it, but I have not started it. I use DIMS lenses in them just to make sure that we buy some time before I start any kind of medication in that small toddler. So I would say 4 or 5 for sure, but less than that, depending upon the case-to-case basis, we have started. Even for some of the patients with post-cataract surgery, if there is a significant, we have started even earlier than that.
Can I respond to that?
Yes.
So the earlier stage is normally 4 years. The only reason is that you have to document that it is axial progression. Atropine is going to prevent axial progression. It is very difficult to document in a child less than 4 years that last year his axial length was this. There will be some kids, like kids of doctors, in which we have taken the patient for EUA to document their axial length because the father said that I want to find out whether it is axial myopia or not. For pediatric cataract patients, we know their axial length because we have implanted the IUL. So we have an idea that this particular patient had progressed. I just wanted to comment on whether the lenses are available beyond -10 or not. So there are lenses available beyond -10, not the Hoya and Stylist, but there is a company, MyKiddo. It makes customized peripheral defocus lens, and they can make up to 15 also. Also, they do customization of peripheral defocus. They put up to +6. Like they will leave the central 9 mm and put +6. So
thank you.
So thank you, Ramesh. So we'll be talking and hearing a lot on myopia in India in the coming years, and because our country is becoming more and more affluent, we are becoming developed. So
May
we'll be
I
hearing
invite
more
Dr.
of it.
Sushila B. Nair to present a memento to Dr. Ramesh Kekune.
So meanwhile, Dr. Anila can be ready with her talk on current concepts in amblyopia management. So Anila is with Sreenethra, and she's talking on current concepts in amblyopia management.
Good afternoon all, I am Dr. Anila George. Amblyopia, what is amblyopia? Everyone knows the definition of amblyopia. Electrophysiological or anatomical abnormalities in the striate cortex or lateral geniculate body due to visual deprivation, strabismus or anisometropia is the physiology behind amblyopia. And children with amblyopia exhibit visual defective higher order visual processing skills, visual inattention and lack of visual search. So the functional impact of amblyopia is much more than what we see. And the prevalence of amblyopia is about 1 to 6% in India. The prognosis of treatment depends on several factors, and the current treatment strategies for amblyopia is mainly depend on the PEDI group studies and amblyopia treatment studies. In children 1 to 17 years with amblyopia, initial treatment is correction of refractive error. And according to amblyopia treatment study 5, adequate spectacle correction alone improves vision in 77% and corrects in about 25% of the kids. Further treatment of amblyopia is required only after 18 weeks if vision doesn't improve. And impact-resistant lenses provide greater safety and is preferred in children with amblyopia. And surgery to treat the cause, it should be done within the first 6 months of life, like surgery for the unilateral cataracts, non-glaring vitreous opacities, corneal opacities, strabismus, etc. And corrector-refractive surgeries is an off-label FDA-approved procedure for the treatment of amblyopia, and PRK can be safely performed for children with anisometropic amblyopia who are non-compliant with refractive correction. Patching. It is used to be and still remains the mainstay of treatment for amblyopia, and the duration of patching required was studied in amblyopia treatment study 2A and 2B, and it was found that 6 hours of patching is effective in severe amblyopes and 2 hours of patching is effective in moderate amblyopes. And amblyopia treatment study 6 showed that the near and distant activities with occlusion show similar results. But there are several disadvantages to patching. This leads to the search for other options for the treatment of amblyopia. First is penalization. It works best when the non-amblyopic eye is hyperopic. In cases of latent nystagmus, when there is an occlusion failure and can be used as a maintenance treatment. Amblyopia treatment study 9 and 4 showed that twice weekly dosage of atropine is effective. But there are several disadvantages to atropine, and also its side effect in less than 3 years of kids is not studied. Coming to the pharmacological treatment, the non-compliance and inadequacy of conventional treatment lead to greater interest in pharmacological therapy. It is usually combined with other treatment strategies, and the drugs mainly studied are levodopa-carbidopa combination, citicoline, donepezil, and citalopram. Levodopa crosses the brain and is converted to dopamine, and it increases the brain plasticity and improves the VEP response. This is the dosage. And the advantages of levodopa is that it can be used in the treatment of residual amblyopia and can be used as an augmentation for patching, and it has effects in older children. But it has several side effects. However, PEDIC study in 2015 doesn't show any significant improvement in combining levodopa plus 2 hours of patching versus patching alone. But Sophia et al. In her study showed significant visual improvement in treatment-naive children, but the dose of the drug was almost 3 times higher. Citicoline, citalopram, and donepezil are other drugs which are under trial for the treatment of amblyopia. The liquid crystal display glasses. In this, the eyeglasses alternate between clear and opaque lens before the eye. And the principle is same as that of intermittent occlusion. And a pilot study found that 4 hours of wearing specialized glasses give the same result as 2 hours of patching. Then Bangarter filter can be used in children with mild to moderate amblyopia and can be used as a maintenance treatment after patching. And it is useful in latent nystagmus. And its effect is studied in amblyopia treatment study 10. Coming to the treatment modality, where the majority of investigations are going on in the field of amblyopia, it is dichoptic or binocular digital therapy. It is based on the principle that since amblyopia is a binocular disease, forms of binocular treatment are ideal for restoring normal visual functions. It can be done in 3 ways. First is anti-suppression therapy, where contrast to the non-amblyopia eye is reduced, balanced binocular viewing, where a non-amblyopia eye is projected with blurred image, and interactive binocular treatment, where different parts of the visual scene is projected to the each eye so that binocular summation is used. And then Binox is a novel cloud-based comprehensive binocular vision assessment and management software, and which uses the concept of binocular summation. It suppresses or reduces the contrast in the dominant eye. Then falling blocks and rigorous game are based on this principle. This is a rigorous game where amblyopic eye sees the red object and the non-amblyopic eye sees the blue object. But both ATS amblyopia treatment studies 15 and 20 failed to prove its benefits compared to patching, but the results were thought to be because the kids got bored of the game because of its repetitive nature, and the complaints become less than that of patching. But several studies, especially one on Binox from Sreenethra Eye, showed that the dichoptic therapy is non-inferior or superior to patching, especially in those who have reached a plateau in improving vision. American Academy of Ophthalmology Ophthalmic Technology Assessment assessed all the journals published in dichoptic therapy and published a conclusion that there is no level 1 evidence to support the use of binocular treatment as a substitute for current therapies of amblyopia, but it is published in 2019. Then other newer dichoptic treatments include REMED, which includes a virtual reality plus dichoptic based game therapy, where the principle is anti-suppression, and the visual acuity improvement was comparable to patching. It can even be tried in kids with small strabismic amblyopias because prisms are incorporated. Then QRSight system, it is a novel cloud-based dichoptic device for binocular home treatment, which received FDA clearance in September 2022. It allows passive watching of video content with anaglyphic glasses. It blurs the central vision in non-amblyopic eye using continuous gaze tracking. It has a computer, an eye tracker, and anaglyphic glasses. This is how the amblyopic eye sees. This is how the amblyopic eye sees, and the lower one is where the non-amblyopic eye sees with central blur. It is the only randomized control trial showing that the binocular treatment was non-inferior to patching after 16 weeks of passive video watching. The other advantages include proven improvement in the visual acuity, improved stereopsis, less treatment time, higher adherence, and parent preferences. But the limitations of this study is that It is tried in children 4 to 9 years in small angle strabismus and in moderate amblyopias with less than 2 interocular line differences. Then monocular action video games with like Call of Duty has shown to improve visual acuity, potential acuity, and spatial attention and stereo acuity in adults with amblyopia. Coming to Revital Vision, which uses the principle of perceptual learning. That is, visual performances may be improved with repetitive practice or specific controlled visual task. It facilitates neural connections at the cortical level. It uses Gabor patches as target for visual training, especially in deep amblyopias and adult amblyopias. It helps in improving contrast sensitivity and visual acuity. But the drawback is that it takes a lot of time. These are some of the apps used in vision treatment. Thank you.
Thank you, Dr. Anila, for that update on the recent concepts in the management of amblyopia. So, as of now, most of these things come as because we are mostly talking about children with amblyopia. So most of these are video-based things, and I think in that way it becomes child-friendly. But the thing is, proper advice for us is now available from very few centers. So, and another thing I have always thought that, you know, though we have more and more gadgets coming up for amblyopia management, and the early identification of amblyopia is very, very important, which even now sort of seldom happens. So I have always felt that like vaccine becoming mandatory, you know, like in children, at least by 4 years of age, the government should ensure that all children have their vision screened, at least by 4 years, so that it's not so difficult like screening in 3 and below. So at 4 years, no, screening is rather easy. So early diagnosis I have already. So I think government should make it mandatory that all children should be screened for visual acuity by about at least 4 years of age, if not earlier. Ideally by 1 year of age also it can be done, but at 4 years at least it has to be done. So thank you, Anila. And for next talk.
The next talk is by Dr. Deepa Bhaskaran, Director, Child Development Center, Trivandrum. A few words about Deepa. She is Associate Professor in Developmental Pediatrics in Government Medical College, Trivandrum. She is the Director in Charge, Child Development Center. She had her MBBS and MD Pediatrics from Government Medical College, Trivandrum. So over to Deepa, please.
Good afternoon, respected Madam, Sir. Thank you, Dr. Swapna, for asking me to be a part of the CME. I think this is a totally non-ophthalmic topic. I'm a developmental pediatrician. I work with differently abled children in Child Development Center. And Dr. Swapna has actually asked me to talk about neurodevelopmental disorders in the eye. There are more than 10 neurodevelopmental disorders, so I'm just going to confine this talk to autism, which is a subject very close to my heart, and just a few slides on ADHD. So what exactly are neurodevelopmental disorders? Neurodevelopmental disorders, as the term itself specifies, these are due to an insult to the developing brain. So if you take an MRI in all these children, we may be able to find a structural defect, only very few of them. Most of it is a functional impairment to the brain. So as I said earlier, there are a lot of neurodevelopmental disorders, more than 10, of which some of them are intellectual disability, autism spectrum disorder, attention deficit disorder, and communication disorders. Most of you would have heard of autism. Most of you would have seen children with autism. Autism is basically a condition, neurodevelopmental disorder, where a child has impaired socialization skills, communication skills, and repetitive behaviors. These are the three main features of autism. Socialization means he prefers to be on his own. He does not want to mingle with his peers. There is more of solitary play. Solitary play means he likes to play on his own. He doesn't give you eye contact. Those are just some of the few social issues with them. When you come to the communication issues, they are not able to communicate with you, even not just verbally, even non-verbally. These children are not able to communicate with you. And because of all this, they don't mingle with others. They restrict themselves to a few activities which they know, and they keep on repeating the same behavior again and again and again. So this limits their everyday functioning, as is well evident. As I said earlier, they have difficulty in responding and processing sensory stimuli. And in these children, when we talk about sensory stimuli, we talk about visual stimuli, tactile stimuli, olfactory, proprioception, and vestibular. Proprioceptive senses and vestibular senses may either be heightened in them or it may be less in them. So those are two senses which we give more importance in autistic children. And these children are mainly visual learners rather than auditory learners, which is very important when we manage them. Now, as an ophthalmologist or as a physician, when do we suspect autism spectrum disorder? When a child does not respond to his name by 12 months of age. He does not point to objects or show interest. Pointing is a very important communication milestone which we actually take for granted. But by 9 months of age, a child is supposed to point for his needs. If he wants water, he's supposed to point. If he's sitting across us in the examination table, he should point for a toy on the table. The next pointing that comes is a proto-declarative pointing, where the child points to something which he wants. It may be a balloon, or he may be seeing an aeroplane and he wants his mother to tell him. So there he points at the aeroplane and looks at the mother. So it's a three-way communication. That is a more advanced pointing. So these are some things which are not there in our autistic child. And if you see a child who has no pointing, these are just some clues where if you have a child you feel has autism, you can ask these very simple questions. And if you feel that he could be autistic, please refer him to a pediatrician or a developmental pediatrician, because as we all know, early intervention goes a long way in rehabilitating these children. Early intervention would be as early as less than 3 years. So the earlier we get them, the better it would be for the child as well as the parents. These are some of the other features. Echolalia, we all know. We ask him, what did you have for breakfast? He will also ask you, Enda kaichadu. Enda kaichadu, he'll say, what did you have? What is your name? He will ask you, what is your name? He won't give you the answer to it. Gets upset by minor changes, has obsessive traits. These are all some of the features which an autistic child can have. So the first one shows that he is not aware of danger. Even if he jumps from somewhere above, he does not take care as to how he is jumping down. The second one is where he is actually lining up toys. If you see here, he likes to line them up. And even if you upset one of this, he gets very upset because it has to be in a perfect alignment for him. Some of them line it from the smallest object to the biggest, or sometimes based on color. This, he's tactile defensive. He does not want to be hugged. He does not want to be touched. This, it affects sleep. They have tremendous problems with sleep. Here they have toe walking. This is what I said about the vestibular stimulation in these children. Here you can see children playing in one corner. He is engaged in zone play. Here he is not able to communicate. He is not able to socialize. So if he is upset, he is not able to communicate and he is prone for tantrum behavior. Here he is upturned the car and he is just spinning the wheels. They tend to be hyperactive. Around 30 to 40 children with autism tend to have ADHD. They may be very sensitive to sound. As they progress to adolescence, they go into depression, they develop anxiety. All those issues can be there when they go into an adolescent. Now, what is the relevance from an ophthalmologic point of view? As I said earlier, these children have poor eye contact. They have corner gaze, that is, they tend to look from the corner of their eyes. They do not follow a pointing finger. They have difficulty processing faces. They have repeated hand flapping and flickering movements, mainly for visual stimulation. They have a poor visuospatial skill. Coming to just a few points, as ophthalmologists, what can we do? One is called a visual orienting task. That is, you establish central fixation in the child, and then if you give a peripheral stimulus, beyond 4 months of age, a child has no problem in shifting his gaze from the central gaze to the peripheral gaze. But in an autistic child, he remains stuck on the central field. He does not shift his gaze to another stimulus, which in turn goes to show that even if he has a social stimulus, he's so preoccupied with the first stimulus, he's not able to shift his gaze to another stimulus. So social stimuli are less attractive for these children. That is one thing called a visual orienting task, which we can test. And actually, this is supposed to be one of the earliest features of autism. So that is what I would If you have a small baby at least 4 months, if you feel that he is not able to shift from a central focus to a peripheral focus, keep in mind that he could have. I'm just saying that this is because early markers are very difficult in them. We have developmental tests which pick up autism by around 1.5 years. So if you can pick it up even by 4 months, you can imagine what is the effect that we can bring about by early intervention. So one of the earliest features would be this inability of a child or an infant to shift from a central fixation point to a peripheral point. 2 to 4 months, this is normal, but beyond 4 months, a child should be easily able to shift his fixation point. That is what is said in all those slides. Beyond 4 months, a child should be able to fix from a central fixation point to a peripheral point. And meta-analysis has shown that this inability to respond to socially relevant stimulus is very prominent in these children with autism, and it persists across ages, and it also worsens with time. Next is called eye tracking, which is very simple. When we look at a picture or when movie clippings are shown to us, we mainly concentrate on the facial features of the person, especially the eyes, the mouth, but these children do not focus on the eyes. When you track their eye movements using equipment, we see that they look at socially irrelevant areas. They might be looking at the mouth, they might be looking at the forehead, but none of them actually look at the eye because they don't have that social drive to look into a person's eyes. Because as we know, eyes speak volumes. When you look at a person's face to understand whether he's angry or whether he's happy, the eyes give out a lot of information. The children refuse to look at the eyes because they don't think of it as relevant, and so they miss out on a lot of social information. So eye tracking is also a very early marker of autism. As I said earlier, face processing, numerous studies have done where they show patients with different expressions, even emojis, an angry expression, a sad expression, a happy expression. These children are not able to differentiate. They're not able to pick nonverbal cues. So they have difficulty in face processing. Biological movement meaning when we talk to children, if there are two people standing, one person, or you're showing two images. One is with the patient waving bye-bye or giving a flying kiss. The other is a stationary person. Autistic children tend to look at people who are stationary. They are not aware of these movements, neither do they recognize these movements which are made by others. So as you are well aware, when a person says bye-bye, the child is expected to say bye-bye, but this child does not even recognize that, so he does not respond at all. So these biological movements are also not appreciated by children with ASD. Visual perception. Agnosia is something where you don't even recognize something. That is, he is not even aware that there is, some children come into the OPD, they look through you, they don't even see you, that you're sitting there. They are so preoccupied with things around them, they don't even see you. There is something like an agnosia, that sensory stimulus is not even making an impact in him. Simultagnosia is where you give him an object, if you show him a picture of an elephant, he may be just looking at the tail. He's not looking at the legs, he's not looking at the tusk, or the trunk. He does not get a full picture. So he just looks at one particular aspect of the object. So he is not able to put everything together. Now, if you show an autistic child this picture, he might just say cake or water. He will not be able to put it together that it is a party, all the children are together. It could be a birthday party. That is something which will not cross his mind at all. He'll just see bits and pieces of the picture which he really wants to. Semantic agnosia is where you give him an object. Most children, when you show them an apple, they know that it is an apple. But if you show an apple to an autistic child, he may have to smell it, he may have to feel it, he may have to put it in his mouth. So we find these children need sensory input in a very different way to understand what an object is. There are children who put everything in their mouth. There are children who smell everything, not just food. Whatever they get, they have to smell. So they need additional sensory input to understand what objects are. This is face blindness, which I said earlier. Next thing that I would just like to mention is eye contact. Eye contact is something which is of great importance in autistic children. As I said earlier, eye contact is a very important form of nonverbal communication. Even if you go for an interview, you have a very proper eye contact, it exudes confidence. But these children, they don't have eye contact, they don't want eye contact in fact. If we force them to have eye contact, they become extremely distressed. So, as I said earlier, since they do not have eye contact, they lose out on a lot of social cues. And certain theories which have been explained are a hyperarousal theory or a hypoarousal or a mind blindness framework. I'll just mention what these are, just to just to have an awareness of how complex this condition is. Some say it is a hyperarousal, that is they are actively avoiding eye contact because establishing eye contact actually stimulates a lot of unwanted stimuli in their brain, especially in the amygdala. So they get extremely distressed and they are actively avoiding your eye contact. Another theory says that eye contact, when somebody looks at me or I give them eye contact, my social circuit, especially my limbic system, is extremely stimulated because I am trying to get maximum information from the other person. But in these children, the social circuit is not getting stimulated at all. Their limbic system is hypo-aroused, so they are not bothered about eye contact at all. The third theory that they see is the theory of mind, which is very important. That is, if I see a picture, I may be seeing, if I see a scenery, I may be just concentrating on the ships there. An autistic child also sees just the ships there. But there is a horizon, there is a sun setting, but he feels that whoever sees that picture is seeing only the ships. They can see only what I am seeing. He cannot think from another person's mind. That is why these children are supposed to slightly lack empathy because they are not able to think what is going through another person's mind. They have a lot of emotions, but they find it very difficult to understand the emotions or expressions of others because of the lack of theory of mind. Those are some of the theories regarding poor eye contact. Now, the other side is you have a very severely visually impaired child. That child can also have autism features, which I'm sure most of you would have seen. Severe visual impairment also may make the child defective in socialization, defective in communication. They may also show repetitive movements. But one difference would be these children would have an intent to communicate. They would want to communicate. They do want to communicate. And once you correct the visual error, the autistic features also may disappear. Just a few slides about ADHD, 3 slides, and I'm done. ADHD, as we all know, is hyperactivity and inattention. But should we attribute everything to just ADHD alone? These children can also have visual problems, which they have said that they can have convergence insufficiency, poor focusing, astigmatism, and color perception. Some studies mention they may have difficulty with the color blue. What I just wanted to say is convergence insufficiency. If a child is not able to say what is near him, he will definitely become inattentive in class, he will become hyperactive, he will go back in studies. So if we have an ADHD child, we should definitely rule out any of these visual problems because if we correct convergence insufficiency, I'm sure his hyperactivity and inattention would come down. So to summarize, I have just talked about the definition of NDD. I've tried to tell you about autism, about the visual problems in autism, some of the theories, and just a few slides about ADHD. And the take-home messages would be, if you find poor saccadic eye movements beyond 4 months, poor response to biological movements, poor tracking, poor face preference in a child, please do think of autism and please do rule it out. And always we should rule out visual problems in a child with ADHD. Thank you for your patient hearing.
Thank you, Dr. Deepa. It was very informative because we happen to see children with disabilities, even our ROP children with refractive errors and developmental delays. So we can't even differentiate whether this is an autistic child or one with ADHD and all. So it was very informative to us. Thank you very much.
Inviting Dr. Sushila Binayan to present a token of appreciation to Dr. Deepa Bhaskaran. Thank you, ma'am.
We would have a slight readjustment of the session. So we'd have Dr. Meena's talks, and then we'll have a keynote by Dr. Jitendra, followed by a short break for lunch, and we'll assemble again for the rest of the session.
The next speaker is Dr. Meena CK from Little Flower Rangamali. So Meena is a person who has gotten long-term fellowship from LVP on pediatric ophthalmology as well as FACO fellowship from Sreenethra Eye, and she does very good pediatric cataract and she has got a pediatric cataract and she has got a specific interest in CVI, and she runs a very good clinic at LF on CVI. So she has got 2 talks, one on CVI and one on pediatric cataract. Since she has to leave, she will be taking her 2 topics together. So first is on CVI. Okay, Bina.
Good afternoon, everyone. After that excellent talk by Dr. Deepa, I don't know if I'll be able to do justice to this. This is a ophthalmologist's perspective on cortical or cerebral visual impairment. So much of importance is being given to cerebral visual impairment now. It is more aptly called cerebral visual impairment. So it is a visual loss or visual impairment due to the damage to the retrogeniculate pathway. And usually we say it is along with an absence of any ocular pathology, which is not so in all cases because you can have ocular pathology associated. It's an insult at the level of the cortex or at the subcortex, and this periventricular leukomalacia is a very common thing that you see in these patients. So you can have a normal examination, ocular examination, but the common things that you see are more treatable things like refractive errors. You can have cataracts, squints, but the visual impairment or the loss does not account to just this. So it's like something more than that. So that is what you have to think about, and associated neurological findings are significantly there. And usually the parents or the examining physicians, they send the child to us to comment on their visual status because they are not able to comment on it, and even we find it quite difficult. So a few points on the anatomy which is important for me to understand. So all of us know that this is the occipital lobe where most of the vision is getting processed. But you should also think about the 2 important streams here, which is a ventral stream and a dorsal stream. So it's just not seeing something that is, it's not just seeing, you have to respond to it. Like you should have some memory of what you are seeing, which is dealt with in this temporal lobe. That is mainly the memory is here, and also the dorsal stream, which is the posterior parietal lobe, that is the mapping of the visual scene. So this is called the tree of vision, which is given so much of importance in cerebral visual impairment. So here, what I mentioned earlier, like in temporal lobe is the visual library. So when the child sees something, the child has it in the library and knows what is or she is seeing. And also mapping of visual scenes is very important. Like you see something and you have to act for it, like which enables us to walk freely. So a few words on what are the causes of cerebral visual impairment. Number of causes are there. It can be congenital or it can be acquired. And commonly you can see hypoxic ischemic encephalopathy, a very common cause. And usually most of these children come with systemic features, commonly cerebral palsies, microcephaly, behavioral problems, etc. So coming to our role in CVI. So what are the common ocular CVI symptoms? So the common ones we see are abnormal light gazes. This child definitely has got a squint, but you can see the abnormal head pose the child is having. And blunted or avoidant social gazes, and brief fixations, intermittent following. They might fixate sometimes, they may not sometimes. It's not consistent. Then coming to the visual acuity, they will definitely, most of them, it will be very difficult to assess the visual acuity first of all, and most of them will have poor visual acuity. And one thing that we commonly see is the inferior altitudinal field defects. This usually the parents will talk about abnormal head posture. And also the common complaint will be the child hits against objects on the floor. So maybe they are not seeing the lower field. So we usually tell them that they are not seeing the fields, and that is a mechanism of the child to go around in the environment. So what do you do when a child like this come to us? First, you confirm your diagnosis. For that, you need the help of a neurologist, definitely. And most of them come to us with all the neuroimaging reports, and then you have to rule out other ocular causes like treat all refractive errors, accommodation problems as mentioned by Dr. Deepa. So many accommodation problems, you treat them. Any media opacities like cataract, any deviation problems, strabismus, treat them. So that is what you can do from your part first. But it does not end with that. So first, once you have treated everything, and suppose the child doesn't have any ocular problems, then first you list out the signs and symptoms, and you rewind and list out the signs and symptoms, and you have to work out a management strategy. And you yourself cannot do this. It's not possible for especially if you're a busy practitioner, you won't be able to sit and treat a CVI. So you have to give them the proper advice. That is very important. And what are the few things that you can advise them? So first thing, the advice should go to the caregivers. It's not to the patient, as all of us know. So caregivers have a very great role there, and mostly they are parents. So first you should have the patience for that and empathy for that, and treat, set limits. You can't ask a child with very poor performance to read all the letters in the alphabet. So it's not possible. So you have to set the limit, and you should have time. That is the most important factor. And according to Hoy et al., the assessment of functional visual acuity in these children has been assessed in 6 different levels. So this level 1 is perception of light. That is the lowest level. And as you improve, like level 6 is normal sensory visual examination. So your aim should be to improve the level of the child, and still you may have limits. So for that, you will have to get the advice of developmental pediatricians as to what level you can go and what all you can achieve in these children. So already mentioned by Dr. Deepa, but some of these words are new to us and it's a little difficult to pronounce too. So there are certain terms that you have to be familiar while dealing with CVI, like object agnosia, that is milder forms of CVI, where visual perception is affected and the visual acuity could be normal, but they won't be able to understand what they are seeing, or optic ataxia, that is visually guided movements are less accurate. So they may not be able to move freely, and as mentioned earlier, simultagnosia, that is the one thing that we have to unlearn in our practice. It was a common habit, especially maybe for me. I used to tell the parents, show them lots of lights, take them out and show them the scenery, but it's not so that we have to do. So here comes the term simultagnosia, and it's been seen that perform better on isolated optotypes. All this happens also in amblyopia children, so it will be easier for them to see a single word which is a little broader, and always give them familiar surroundings and background. So that is very important. And they prefer to look at bright, high contrast objects at close range. So you can give them high contrast objects like this, and also enlarge the features of the toys. A toy with a big, huge eyes, big nose, all this can be quite inspirational for them. And this is one thing you have to be very careful about, that is they have very low speed of processing. That is what is simultagnosia, that is you can't concentrate on too many things. That is a minimalist approach, which most of the architects also talk about, minimalist approach, that don't have too many things around you. So this is the concept of this tent. So they can be kept in a tent for training so that they are not exposed to too many things. You have 1 or 2 toys and give them that. The red signal is don't give them too much to see or too much to grasp. So that is one thing you should be careful about, which is something that we have to unlearn, because we had even at least I had a tendency to tell them, show them lots of toys and take them out, socialize, and that is not they want. And isolating, so this is a right for them. Like it's a minimalist thing, that a few things in the playroom, and if you provide them with so many things which usually the children like, they might be too confused, and don't insist on face contact each time, it may not be possible, and avoid crowded places. And they do react to moving objects than stationary one. But the thing is, you should know at what speed they are comfortable. It's not all speed. They may not be able to see a speeding car. So you should know the speed at which they are comfortable and also the distance at which they can see all this. So for that, you need to be with the child for a long time to know about it. And color also looks wash out. So you can help with color naming, which I have started now actually, like a black crow, so they can relate it to it. So all these things are important. That is some things that we can help out in these children. And also the visual field defect, which is a very common thing, that is a very common complaint the parents have, that when the child walks, they hit against things on the floor. So you can clear the floors for them. That's all you can do. You can't improve their fields. And teach them to hold hands when they walk. And reading stands like this are very useful. Like they can use their upper fields, that is your aim. You can't develop their lower fields. So try to use their upper fields with things, gadgets like this, and stairs, like you can color the stairs and you put markers on the doors which will be more prominent and they will be able to use it. And also there are vertically printed notes. You can see some parents complaining about significant head posture, and there are vertically printed notes which will be comfortable for them, at least when they have a little higher grade, then the vertically printed notes are available which can be given, and all these low vision aids like magnifiers, horizontal and vertical spacers. And photophobia is also a very significant feature that we see in them, and you can give them wraparound glasses in such cases. So the key thing is you have to empathize with them. That is one thing. And it's not to be done in a crowded and busy OPD. So ideally you should have a CVI clinic, and it has to be run by someone who has great patience and have reasonably good time. So your aim should be only to treat that, and it need not be a doctor. You can have somebody trained for that, and things should be accessible and meaningful, and there should be no anxiety or fear associated with it. And always one thing you have to be careful is you have to stay within their limits. Like you can't think of them going to great heights, which may be your wish, but try to be in the limits, and your aim should be to provide them with a situation that they can take care of themselves. That is, you can't have great aims, but at least you can improve their status to a higher level. That is what you have to aim at. So thank you for the patient hearing.
I'm continuing with the next talk. Because on CVI, if you start discussing now, CVI is something which you need at least one day to discuss. So I think you have brought out the salient points, and I think we can move on to your next talk, pediatric cataract.
So this is an entirely different topic, and I'll be speaking on the surgical managed tips in pediatric cataract surgery. So pediatric cataract surgery, like all the steps you have in adult cataract surgery, you have to go through them. Plus you have a few additional steps in pediatric cataract surgery. The more difficult part of pediatric cataract surgery is like you are dealing with tissues which are very supple and difficult to manage. So that is the most important challenge. And also it's not just the surgery, and post-surgical situation is also different in pediatric cataract. So it's the follow-ups that matters. So about the surgical tips, I'll be talking about the various steps in pediatric cataract surgery. So first, let's start with the various incisions in pediatric cataract surgery. So when you are dealing with a very young cataract, you are not going for an intraocular lens. So in such cases, you can get away with just side ports. You can do your surgery with side ports. So side port management is, it would be ideal for all the incisions in pediatrics eyes to be a little longer or broader, because the anterior chamber stability may not be that much, the sclera is not that stable. So such cases, it would be ideal for you to make a little longer or broader incisions. Like here you can see the main port being put with the keratome. And here, it would be ideal that it should not be a very short one, because you can get an iris prolapse, which is dangerous. So you have to be very careful that your incision matters really, and don't include the conjunctiva when you're doing it, because that also causes ballooning and your visualization, especially when you're a beginner. And suppose you're going for a rigid IOLs and you're making a scleral tunnel, make sure that your scleral tunnel is quite broad enough and the anterior chamber can be formed well with just the, don't try to avoid any iris prolapse, because then the surgery can be quite traumatic. Now coming to the next part of surgery, that is anterior capsulotomy. So anterior capsulotomy is an extremely important step in pediatric cataract surgery. You need a very well-centered and well-shaped anterior capsulotomy so that the rest of your surgery will be easier. So here you can see the capsule being pulled, and as you pull the capsule, it would be ideal to take multiple catches near the free segment of the capsule, because so that it won't run to the periphery. Whatever expert you are, when you are doing this, no, you have to concentrate fully on this, because just one run into the periphery makes your surgery a trauma. So it can be quite easy and it can be done easily, but you have to concentrate well on the capsular margin and make sure that you have an ideally sized capsular opening. It should not be too small nor too large. So a high concentration in this part of the surgery. Now coming to the next step, that is removal of the lens matter. That's not a very difficult task in pediatric cataract, because usually in cases like this, what I prefer is, whenever you are suspecting a posterior polar like here, I do a dry aspiration of the cortex and it comes off very easily. You don't have to go for an hydro in such cases. You can do definitely, either you can go for a hydro delamination or, but when you are suspicious about the posterior capsule, you can go ahead and do a dry aspiration of the cortex, which is quite easy. And when you're sure that the posterior capsule is intact, like here it was a posterior polar, but you can see that the plaque has come out and the PC is intact. So in such cases, you can easily then go out with a bimanual and do a proper aspiration. But here, like, this is a lamellar cataract where you are extremely sure of your posterior capsule. So in such cases, at the beginning itself, you can do an irrigation aspiration, and if you have any suspicion on the posterior capsule, maybe you can reduce the parameter or the bottle heights and don't increase the depth of the anterior chamber too much. In such cases, it is quite easy. Lamellar cataracts are the easiest pediatric cataracts that you can manage. And polishing of the anterior capsule is optional. Some surgeons don't advocate, but I regularly do polishing of the anterior capsular margin, because I feel that it significantly reduces that white opacities on the rest of the capsule that we usually see in long-term cases. So I always polish the anterior capsule, and I feel I'm quite comfortable doing that. Now coming to the posterior capsulotomy. This is one thing that we dread in an adult cataract, but this is one thing that you have to be perfect and you have to do it properly in a pediatric cataract. So posterior capsulotomy is a must. I do it till about 8 years of age, and a proper centration is very important, because even if you do a good rhexis and you have one edge of the rhexis in the pupillary axis, it can be quite troublesome. And when you put the IOL in the bag, then dealing with that part of the capsule is very difficult, because YAG lasers in children, they may not cooperate. So it has to be very well centered, and just like the anterior capsule, it would be ideal to take multiple catches, and microforceps are the preferred ones, or whatever instrument is comfortable in your hands you can use. And usually posterior capsulotomy is a little easier than the anterior because of maybe the convexity of the posterior capsule, and it has to be well centered. Now coming to the anterior vitrectomy part, opening up the anterior vitreous space is very important because anterior vitreous space acts just like a posterior capsule. So you might think that you have opened it up, but make sure that in very young children you have to do a core vitrectomy, do a proper anterior vitrectomy, and maybe in older children like 7 or 8 years, you just need to open the anterior vitreous space. You need not disturb the vitreous because you can definitely go for a YAG laser later if you want. And in the back, IOL is the preferred one. In cases like this, you are not, you can see that the capsule is not in a normal state, or there are plaques on the capsule. In such cases, a capsulotomy may not be possible. So in such cases, you may have to excise the capsule with the help of micro scissors, and when you are planning for an IOL in the sulcus, it would be ideal to do a 3-piece IOL in the sulcus. When it is a foldable, a 3-piece IOL in the sulcus. I am not going to the details of an IOL because I know it will be covered on keynote address extensively. So this is a 3-piece IOL that is being put in the sulcus, and it's a safe thing to do. And when you are not sure of your posterior capsule, you can definitely put it in the sulcus, and usually the results are really good. Now, coming on to certain scenarios where you have to be careful, like PHPVs are types of cataract which are, maybe we may be able to manage it, but the problem is post-operative inflammation, you can, especially in PHPVs like this. The other one is a very milder form of PHPV where you can see the fish tailing and only just a central plaque here, which has got an opening also, which has been already created by nature, and we just need to do a posterior capsulotomy, and usually the rest of the capsule will be quite rigid for the IOL. But in cases like this, you can see it is a highly vascular PHPV. Such cases, you can see the vessels falling into the vitreous, and you have to be careful, like you can do an endocautery there and cauterize the vessels, and usually the rest of the capsule will be rigid and you will be able to put an IOL. Here there's an associated coloboma also. But the problem with such children are that they can, significant post-operative inflammations we have to anticipate. So in such cases, you have to follow them quite frequently, and at the same time, you have to give significant anti-inflammatory support in the post-operative period. And this is so in small pupils also. Like here you can have a very small pupil, it is little bit of micro cornea too, and definitely you have to do something about the pupil to do your cataract surgery, and hooks are being used, and it's not that difficult to put hooks and do the cataract surgery, but post-operative inflammation is quite high when you do all these pupil dilating devices. And here you have a microphakia also. So such cases you have to closely follow up the patients and make sure your post-operative inflammation is not destroying whatever surgery you have done, and it's not closing your visual axis. So keeping a clear visual axis is what that matters highly in a pediatric cataract surgery. So to summarize, the requisites for good functional visual outcome would be well-centered and adequate size rexus, opening of anterior vitreous space in very young, and ideally IOL in the back, and long-term follow-ups. Thank you, and I would also like to thank the organizers of the CME and Dr. Swapna Nair for this opportunity. Thank you.
So, thank you, Meena. And are we taking one more pre-lunch?
Shall we break for lunch and come back after the session?
So, should we put it to vote?
Shall we have the keynote now, I think, and then we'll break for lunch?
So, yes. So, thank you, Meena.
May I invite Dr. V. Sastranamam to present a token of appreciation to Dr. Meena Sacon.
We go on to the next talk by Dr. Jitendra Jatani, Senior Consultant, Pediatric Ophthalmology, Children Eye Care and Screen Center, Baroda.
Thank you, sir.
He is the director of the hospital, MBBS from BJ Medical College, Ahmedabad, DO and MS from Regional Institute of Ophthalmology, Ahmedabad, and former head pediatric ophthalmology and strabismus at Dr. Thakurbai V. Patel Institute. Over to Dr. Jitendra.
Thank you so much, ma'am. Thank you, Sreenethra Eye Care, and especially Dr. Swapna for inviting me, for giving me the opportunity. IOL power calculation in children. Now, I would be talking mainly about a little bit about what do we recommend, which eyes we can put IOL. We would first talk about what are the problems and why it is a different, what is so special about kids, why it is so different when it comes to kid. So, we all are, most of us are cataract surgeons. And most of us, this is more of a run-of-a-mill thing now. It is, we have got IOL Masters 500, we have got LensStar, we have got huge number of formulas, Warren Hill, Barrett, Universal 2, Toric, multiple formulas are there. But the point is that most of these formulas, theoretical formulas, have been made, invented, thought about, keeping in mind that, the anatomical features are of adult eyes. Now, with pediatric patients, the anterior segment is definitely significantly smaller when it comes to adult eye, but it does not change much as the time goes on. So these are two important things, and when you have a patient with congenital cataract, they may have still more variations because already there's a cataract, there may be more variations when it comes to the eyeball anatomic landmarks. So the anterior segment of an infant, we all know, is smaller compared to an adult eye, but it is proportionately larger to the posterior segment because it is mainly the posterior segment of the eye which grows. As the age advances, it is actually the vitreous length which increases, and there is not huge change in the anterior segment. These structural variations, we all understand that will change most of the things like effective lens position and therefore effective power and therefore the affected estimated power. So most of this things would be estimated power and not the real power, and the capsular bag will also contract because there are too many ears behind a pediatric patient. That may also result in greater displacement. Implantation of high power IOLs. Now whatever happens when we implant an IOL in a kid, we want to see what is the positive predictive value and what is the negative predictive value once we implant the IOL. Often there are magnification errors, there are calculation errors, and also when you are trying to do a retinoscopy post-op, the eyeball sizes are growing at such a rapid speed that after a month when you do UA, there may be a change in the axial length, and you may get a positive predictive value or a negative predictive value, which may not be really true. Now, there have been a lot of work, a lot of debate on this. This is an old article by Neely et al. Who reported that SRK2, SRKT, Hoffer-Q, Holliday, these were, all of them had significant variability and there was no consensus. This was followed by a wonderful article by Bharti Nehelani and Deborah Vanderveen. They published that Hoffer-Q had the least mean absolute prediction error. This was followed up by Ramesh and I think Virender was a co-author. They published in AJO. And they reported that SRK2 had the least prediction error. The reason I'm depicting all these is because even in these literature also there is no true consensus which particular formula is good. Because and this was followed up by another article. So then Bharti had a co-author in Deborah from Boston, and they published another series where they found that the least absolute prediction error was 1.2 in Holliday 1. Additionally, so since there was a huge variation, they could not do a mean, so they did a median, and they found that the median difference between Holliday 1 and SRK2 was 0.3 diopter. The point is that we really do not know which is a good formula. We use SRKT for most of our cases, but you have to keep in mind that it is not, nowadays we use Barrett Universal 2, and we compare between the two. So we come back to how to choose a formula. We have to understand the specific characteristics of the operative eye, your own experience, how many pediatric cataracts you have operated, which formula works for you. The formula should be able to customize the calculations. Most important is you should be knowing the limitations of those particular formulas, whether they are good for short axial length, they are good for long axial lengths, and so on. Now, as we have moved further into pediatric cataract, the age of implanting IOL has gone down to almost 1 year, and some of the surgeons operate at 6 months also, implanting an IOL. So for us, the cutoff is more based on anatomical landmarks of an axial length of 18 and a corneal diameter of more than 10.5 millimeters. We believe that, we still do not have a great undercorrection. There is no, even with the formulas, and then we come to the undercorrection, because we know that as the age advances, there will be axial growth, and this would change the whole dynamics. And so we still do not have a proper undercorrection formulas also. We will have a small look at what are the undercorrection formulas available. This was pre-2000 when, most of the work was based on pure axial length without any K reading. So this is just for the sake of completing the list of mentioning that there was a proposed IOL power calculation in children by Dahan et al. In 97. We will not give a lot of credit to this. This was what we used to do at Arvind Eye Hospital when I did my fellowship. Under 1 year, no IOL, 30% undercorrection, 20%, 10%, and above 5, no undercorrection. And then there is this famous Inyadi's rule of 7, which a lot of institutes do follow. And this is a simple rule of 7, which means that the maximum age for undercorrection is 7. And at 7, if the kid's age is 3 years, you deduct 3 from 7, that is 4, and you undercorrect by 4 diopters. For the sake of ease, I have just divided it here 22.5 minus 4, but this is now not how you deduct. And this is to keep in perspective. There's a wonderful article by Dr. Rupal Trivedi, who works in Storm Eye Institute. They have published their article in Kerala Journal of Ophthalmology, where they have published this particular table of undercorrection up to 10 to 14 years. So there's a huge variability in undercorrection formulas also. We did our own studies, and at this point of time, this is the present concept. It can be deducted on the basis of percentages. It can be deducted on the basis of flush rule of 7. So how do we undercorrect? I mean, this is just to show the present concept. How do we undercorrect? Let us take a few simple examples. If the axial length is 22 millimeters, age is 2 years, and by 20% undercorrection, if the IOL power is 19.5, we will be undercorrecting by 3.9 diopters. Similarly, if the same age, axial length is 19, we will be undercorrecting by 20%. IOL power supposedly is 28.5. What is the power to be inserted? It would be, we will be undercorrecting by 5.7 diopters. Now here what we are doing at present is, with percentages, we are undercorrecting more in hyperopes, where the axial length is small. Whereas we should be doing it other way around. We should be undercorrecting more in myopes, because a myopic kid who is myope at 2 years of age is bound to be more myopic. He is bound to progress more quickly. And so we should be undercorrecting more for myopes and less for hyperopes. Whereas when we do percentage undercorrection, we are doing 180-degree opposite of what we should be doing. So how do we undercorrect? Normally, we should never undercorrect directly by a number. We should put it as the expected error of refraction, and that is how we should undercorrect. I'm pretty sure most of us do it, but sometimes, when we are in a hurry, we just deduct directly from the IOL power. This is just to show that how much difference it makes when you undercorrect directly, like you can see in the chart. If you undercorrect directly, 22 minus 4 would be 18. Whereas if you feed it in the table, that would be 16 diopters. So there will be a difference of 2 diopters, which will be understood only if you do it like this. So this is taken from Barrett Universal 2. And this happens for emetrope, this happens for myopes, this happens for hypermetropes. So for all the formulas, there will be a difference. If you feed it in the expected error of refraction, it would be different from if you deduct it directly. So that is also one of the important points. What other factors we can consider? We can consider what is the status of fellow eye. Like you have operated the right eye of the patient, you have undercorrected, you see the positive predictive error in that particular other eye. Whether that other eye is emetropic, what is the status of that other eye? You have to see the visual acuity. whether if you if you undercorrect by +4, you may end up into having risk of amblyopia. So there is no point in undercorrecting so much that the child goes for the risk of amblyopia. You have to see the expected compliance by the child to glasses, whether he's going to wear, see, undercorrecting a kid at 4 years of age by +4, and if he doesn't wear glasses, it is better he will wear -4 when he grows up. So that is also to be seen whether there will be any expected compliance by the child. Like if the kid is a developmentally delayed kid, he's not going to wear glasses. It would be extremely difficult. So that also has to be considered. And another important is parents' refractive error. As Ramesh mentioned in his talk, that if the parents are myopic, there's a huge likelihood that the kids would be myopic. In fact, the odds ratio is around 4 to 5 that the kids would be myopic. So that also has to be understood. This is what we do in our practice. The corneal diameter has to be at least 10.25, 10.5. Axial length has to be at least 18.5 to make us put IL in the eye. This is what we follow for undercorrections. We go by age and we add a factor of axial length to that. We do believe that age and axial length both are independent factors to each other when it comes to undercorrection, and that should be done. If it is a unilateral case, whatever the age, you cannot do more than 4 diopters of undercorrection because you are inducing huge amount of anisometropia, and patching itself is more difficult than the surgery and making sure that the kid wears glasses. Between 2 to 5 years, we go by our normative data of axial length, which we feel in our patients it was 20.5. If the axial length is more than 23.5, we would definitely undercorrect more compared to what we will do for a child between 2 to 5 years with an axial length of 20.5. And normally at 5 to 8 years, we won't be doing much of undercorrection if axial length is on the lower side of 20.5, but we will be doing more undercorrection if the axial length is around 24.5, because we feel that these particular patients would go into myopia more compared to the children whose axial length is 20.5. So, and above 8 years, normally, we will not undercorrect. Even with Inyadi's rule of 7, we will not undercorrect. But if the axial length is more than 24, we would definitely think of doing some undercorrection, because these children do tend to go towards myopia. So thank you so much for the talk. I hope I'm the one who's keeping you away from lunch. So if there are any questions, we can take.
So thank you, Jitendra. So if there are questions to Jitendra, I think probably we will be taking it up in the post-lunch session. Jitendra is talking on the topic again in the post-lunch session. Yeah. So I think we shouldn't keep people waiting for long. So thank you, Jitendra.
Thank you,
and so
are
we giving his memento now or after lunch?
Yes, sir. May I invite Dr. Sushila Binayar to present a token of appreciation to Dr. Jitendra Jadani. Thank you, ma'am.
So we'll move for lunch. So when are we expected to be back? 3 o'clock? As early as possible, no? As early as possible. So because everybody, as soon as people start coming back, no, we'll start the post-lunch session. So something like 2:50.
Check.
Presentation. Shall I start, sir?
So very good afternoon to all. First of all, I thank Dr. Swapna Madam, my teacher, for giving me this opportunity to stand here and speak on this recent advances in ROP as emerging clinical patterns and management in ROP. I am actually planning to change the talk as I'm just focusing out on what is new in this retinopathy of prematurity. ROP is an emerging cause of childhood blindness in the developing countries, and now the low income and middle income countries are facing the third epidemic of ROP. Why this third epidemic? The improvement in the neonatal care facilities has increased the survival in the preterm babies, and a lack of awareness and non-uniform standards of care in the ever-increasing number of NICUs has resulted in this third epidemic. It's a very important factor because this unblended oxygen and increased use of oxygen supplementation in this extremely preterm babies resulting in lot of new clinical manifestations in the ROP, and lot of atypical forms of this aggressive posterior ROP is also happening. So coming to what is new, there are a lot of new imaging techniques, telemedicine and artificial intelligence to screen ROP, and there are newer clinical patterns in ROP, and the main important thing is shift of the treatment paradigm from the laser photocoagulation to intravitreal anti-VEGF injections and also combination therapy. Now we'll move on to a classification. First of all, what all changes are happening in the classification? When we sit in the OPD or when we screen the babies in the clinics, what all things are helpful in identifying the lesion or also during recording the lesion? In ICROP in 1984 and a modification in 1987 taken into account the major aspects as location, extent and severity. Location in the form of zone 1, zone 2 and zone 3, I'm not going in depth. Extent in the form of clock hours of involvement, and severity. In the initial classification, the staging was stage 1, 2, 3 and 4 as demarcation line, ridge, extraretinal fibrovascular proliferation and retinal detachment. And the initial classification, they also identified plus disease, threshold ROP and also pre-threshold ROP. Plus disease in the form of progressive vascular incompetence presenting as dilatation and tortuosity of the vessels in all 4 quadrants in the posterior pole. And threshold ROP as ROP of more than 5 contiguous or 8 cumulative clock hours of stage 3 plus in zone 1 or zone 2, and all the eyes with the threshold ROP needs treatment. And pre-threshold ROP, any zone 1 ROP less than threshold, that is zone 2 stage 2 with plus, zone 2 stage 3 without plus, or zone 2 stage 3 with plus but less than the threshold criteria are included in the pre-threshold ROP. So with this classification, what were the major problems we were facing? First of all, the anatomical delineation of the zone 1 was difficult because anatomic landmarks are ill-defined in a premature infant. And there was need for further classification of the stage 3 because of its prognostic importance. And the cicatricial forms of ROP were not included in the initial classification. So next, the revised ICROP classification came in 2005, and they tried to cover the gaps in the previous classification. And the main highlights of this revised classification were aggressive posterior ROP, pre-plus disease, and anatomical delineation of the zone. These 3 were the lacunae in the initial classification. In the revised ICROP classification 2005, they maintained the stage 1 and stage 2 as the same without adding too much. And in the stage 3, the definition of stage 3 was same, but the proliferations were divided into mild, moderate and severe. And the major change was stage 4 and 5. In the initial classification, stage 4 was included in the retinal detachment, and in the revised classification, stage 4 as partial detachment, in that extrafoveal 4A and the fovea involving 4B. And they introduced the stage 5 as total retinal detachment. And plus disease, actually it was there in the initial classification, but they modified little bit as at least 2 quadrants of involvement of the signs were required to define the disease as plus disease. Initially, it was all the 4 quadrants. And then came the pre-plus disease, introduced the new term. And in this, the features were insufficient for the diagnosis of plus disease, but the vascular changes were more marked than the normal. And it signifies the stage which is later on to be converted into plus disease. And then came this aggressive posterior ROP. That is a rapidly progressive, ill-defined form of ROP called rush disease or Firminage ROP. There is severe dilatation and tortuosity of the vessels out of proportion to the peripheral retinopathy. And this was limited to the posterior zone 1 and zone 2, and was usually does not progress through the classical stages of stage 1 to 3. And the main feature was it rapidly progresses to stage 5. That is called, that's why it's called aggressive posterior ROP. And then the new edition came as ICROP third edition. And the important modifications came in this classification is posterior zone 2, notch and subcategorization of stage 5 and recognition of a spectrum of vascular abnormality as defined as plus disease and the use of term aggressive ROP than aggressive posterior ROP and the description of regression, reactivation and long-term sequelae. So the key components of ICROP third edition was, the first one was definition of posterior zone 2 region that begins at the margin between the zone 1 and zone 2 and extending into zone 2 around 2 disc diameter distance. And also the term notch. We can see when we see these ROP babies, even if the lesion stage 1 or stage 2 or stage 3, even if the major part of the lesion involving in the zone 2, we can see in that figure as a notch-like extension into zone 1. So according to the initial classification, when we see such a lesion, if the posterior most zone is to be considered while writing the final diagnosis. But in this case, if we write zone 1 stage 3, that implies the major lesion in zone 1. But in this case, the major lesion is in zone 2, only a notch-like extension into zone 1. So that modification made a huge difference in this modified classification of this third edition. So in such a situation, we have to name the stage as zone 1 secondary to notch. That implies the major lesion in zone 2, only this notch-like extension of 1 or 2 clock hours extending into zone 1. And then in this third edition, they modified aggressive posterior ROP term into aggressive ROP because these changes, the definition remained the same, but these changes occurs beyond the posterior retina, especially in the larger preterm babies. So they modified the term into aggressive ROP. And severity wise, almost the same as the revision done in 2005. Only few things which I want to highlight is, when we see a baby with a vascular retina in the periphery, ideally we have to mention incomplete vascularization in which zone, either in zone 2 or in zone 3, other than mentioning as no ROP or immature retina. All those are vague terms without conveying the proper message. And in this third edition classification, stages remain the same, stage 1, stage 2 and stage 3. And one more focus they made out is popcorn lesions. These are small new vessel proliferations seen just posterior to the ridge, which has not to be considered as stage 3. It comes under stage 2 only. And then the retinal detachment, stage 4 remained the same even in the third edition classification, but stage 5 they subclassified as 5A, where optic disc is visible, that is open funnel detachment, and 5B, where optic disc is not visible due to fibrovascular proliferation, and it comes under closed funnel detachment. And 5C means 5B accompanied with the anterior segment changes, that is marked anterior chamber shallowing, iridocorneal lenticular adhesions, and corneal opacifications. And then the new term introduced were regression, reactivation and a long-term sequelae. Regression can be spontaneous or after treatment, laser or anti-VEGF injections, and it can be complete or incomplete. So all these things has to be properly mentioned when we write the final diagnosis of the ROP. And similarly, the reactivation, ROP reactivation can happen after treatment, which can include the new ROP lesions or sometimes the vascular changes. So it has to be specifically mentioned as reactivated stage 2 or depending on the vascular change. And the other one is long-term sequelae, which are late retinal detachment, peripheral avascular retina, macular abnormalities, retinal vascular changes and glaucoma. Up to this area, that was the third edition ICROP classification. Now I am just coming into some atypical APROP conditions which we see in the clinics. That is a hybrid ROP in which components of both staged ROP and APROP is seen. There is both ridge tissue that simulate the staged ROP, that is because of disrupted angiogenesis, and flat neovascularization which simulate the APROP, that is disrupted vasculogenesis happening in the same eye, which is seen mainly in babies with birth weight or gestational age which is higher than the APROP babies. And usually complete regression is seen after laser treatment. Sometimes the combined management with anti-VEGF and laser is also tried. And next, coming to the posterior zone 1 or half zone disease. In this, the lesions are focused mainly in between the disc margin and the fovea, or we can see as within 4 disc diameter from the nasal disc margin, temporal disc margin. The common lesions seen in this half zone ROP is AP-ROP, hybrid ROP, threshold ROP, and also retinal detachment. And lot of atypical features are seen in this half zone as retinal vascular tortuosity without dilatation, bleb-like retinal detachment, excessive candle wax-like preretinal deposit, and long arteriovenous shunt bridging ends of the multiple arteries and veins, and prominent fibrovascular bridge. There is a risk of recurrence or inadequate response, especially when we treat with primary anti-VEGF alone. So the most effective method is in a combination therapy with anti-VEGF and followed by laser treatment. Bleb-like ROP, which is seen mainly in the half zone situation, as isolated subretinal exudation without any tractional features. The main pathologic mechanism implemented is accumulation of excessive fluid in the subretinal space due to disruption of the blood-retinal barrier. Similarly, severely disorganized retinal vessels resulting in exudation, and extensive choroidal ischemia, and there is a fibrinoid necrosis of the choroidal arterioles resulting in exudation. So the characteristic findings in bleb-like ROP is extensive areas of avascular retina with retinal edema, subretinal exudation, and there is vascular sclerosis. These are the consistent features in bleb-like ROP. The main thing is these conditions respond very well to the anti-VEGF injections, and additional laser is almost always required for the complete cure. Then comes to the cicatricial ROP. Untreated or partially treated eyes can present with the cicatricial ROP or sequelae or the disc and macular dragging, and also macular folds, peripheral vitreoretinal lenticular adhesions, and the subretinal pigmentation from the reattached exudative detachments. So now coming to the newer aspects of the treatment, laser photocoagulation, I am not going in depth to that. Pre-threshold conditions also type 1 and type 2 need close follow-up, and type 1 also needs laser treatment according to the ETROP guidelines. And nowadays the anti-VEGF injections are helping out a lot in managing the retinopathy of prematurity, especially in posterior zone half or zone 1 conditions, and aggressive posterior ROP. And the main advantages of anti-VEGF treatment is ease of performing the procedure and faster regression of the ROP, lower risk of myopia, and less stress to the patient, and faster administration time, and compared to laser, anti-VEGF is also used in treating AP-ROP, and also it's indicated as a perioperative use. Then surgery is mainly needed for this stage 4 and 5 ROP. So I'm not going in depth to this surgical aspect. Thank you.
So, thank you, Shira, for... Is this on? Thank you, Shira, for highlighting the newer terminologies in ROP and just outlining the treatment aspects. And Shira is a person who has done a lot of screening in ROP across the southern states of Kerala. So she can talk rather authentically on ROP findings. Very good.
May I invite Dr. V. Sahasranamam to present a token of appreciation to Dr. Sheera K.R.
Okay. Next we move on to Dr. Jitendra Jatani, Senior Consultant, Baroda. The topic is surgeries on vertical muscles, inferior oblique. Okay. Over to Dr. Jitendra.
Thank you, sir.
Thank you once again. I will be talking on intraoblique surgeries, and so first of all, so the whole talk would be a small bit on what are the indications, and then we will see what we do, like which indications we operate. There will be very short videos, mainly to show the particular technique as to where the intraoblique has to be attached. Most of the surgeries of intraoblique I have done are almost weakening of intraoblique. There are no strengthening surgeries for intraoblique. There have been some reports, but intraoblique normally cannot be really tightened. So indications obviously would be wherever there is an infraoblique overaction. It could be primary infraoblique overaction, could be bilateral essential overactions with V pattern with horizontal strabismus. There was a wonderful paper from Sumit and Ramesh in AIUS, which won the best paper award, horizontal strabismus surgery with supraoblique palsy. Unilateral essential overactions combined with horizontal deviation and a significant hyperdeviation in primary position. So the hyperdeviation is associated with infraoblique overaction, and a DVD, dissociated vertical deviation, associated with infraoblique overaction. There could be secondary infraoblique overactions in supraoblique muscle palsies as a contralateral synergist in suprarectus palsy and in DEP. So the last two ones are not very commonly done because it is secondary to the primary underaction of suprarectus in both the cases. So DEP or monoocular elevation deficit is primarily tackled with a NAPS procedure and not with infraoblique, but sometimes when there is a residual correction and there is an infraoblique overaction, there is torsion, you may have to manage. So basically whenever there is an overaction of infraoblique, we have to tackle because infraobliques are normally weakened. The contraindication would be any V pattern without presence of infraoblique overaction. Now, this is really tricky because there are some patients where you do not have infraoblique overaction and still there is a V pattern. You have to tackle with horizontal, like medial rectus has to go down and lateral rectus up. X pattern strabismus, apparent overaction in craniostenosis and in DRS when there is an apparent infraoblique overaction which is actually an upshoot and not really infraoblique. Now infraoblique is the actual only muscle which starts from anteriorly and goes posteriorly. Even the superior oblique starts posteriorly, but because it is reflected through trochlea, it is also like similar to, it has a functional origin at trochlea. It has got the shortest course, it has got the shortest tendon, and that is why you cannot resect it because there is hardly 2 millimeter of tendon. So you can't really resect it. You never cut the muscle in resections. It is close to vortex vein. Vortex veins are true realities, so they are visible, and it is close to vortex vein, and it does not contribute to blood supply of anterior segment. All these points are important when you are handling infraoblique. We can discuss it later because it is a big topic. And this is the surgical anatomy. It is very important. You cannot recess infraoblique beyond 12 millimeters. And why? Because this is a wonderful picture taken from David Plager's article. You can see how you cannot recess it beyond a certain point because you cannot go back under the inferior rectus. So you can recess it only till 12 millimeters, and from origin, it has got a wide insertion, so when you are inserting it, you have to take care that you have to bunch the muscle, otherwise you can have anti-elevation syndrome, and you have to be very careful because you are very close to the macula. When you are operating or when you are cauterizing the muscle, you are very close to the macula. It's a very forgiving muscle. Most of the cases, whatever happens, the only thing that happens is that there would be a persistent infraoblique overaction despite whatever has been done. Normally, there are no palpebral pressure changes or normally not a problem. The only thing is there is huge diversity of opinion on what is the proper technique to recess or to weaken the infraoblique. And whenever there are multiple options, these are all the options which have been published over a period of time. Point A and point B are the origin and insertion. And then there is Fink's point, which gives an 8 millimeter recession effect. Apt and Call gives a 12 millimeter effect. But they published their article in AJO where they did a graded recession of infraoblique, which was published in 78. So it is quite old. Park's point, which gives a 10 millimeter effect and a small anterior positioning. Elliott and Nankin anterior positioning, and Mims anterior positioning, which is anterior to Elliott and Nankin's anterior positioning. I know this is very overwhelming. When it becomes very quick, it becomes very overwhelming because there are too many names: Fink, Apt, Park, Elliott, Nankin, and Mims. So there are a lot of things available. How to choose from this? We have to see for how much is the hypertrophy and primary position, how much is the overaction, and how much is the amount of torsion. And how do we select? There are some surgeries which are purely recession surgeries. They will have absolutely no effect on primary position hyper, whereas there are some surgeries which have a recession effect as well as an effect on the elevation in primary position, and then there are surgeries which will have pure effect on the hyper element in primary position, and then there are surgeries which can even cause intorsion. So we will see one by one. This is what we do when there's a very small infraoblique overaction. What we do is we do a Fink's recession. A lot of surgeons believe that Fink's recession is like you're not doing much. Basically, the recession is through the lateral rectus. You have to measure 6 millimeters posterior, 6 millimeters inferior. Here I am assuming that we know how to separate the infraoblique, because that in itself is a separate thing. How do you separate? So here we have separated the infraoblique and we have started 6 millimeter posterior. This is the lateral rectus which is being hooked. 6 millimeter posterior and 6 millimeter inferior is the anterior point of the new insertion of infraoblique, and then you can put the posterior point 3 or 4 millimeters behind. So this we do when there is very minimal infraoblique overaction, and if it is very minimal, you can leave it untouched if it is unilateral. If it is bilateral, then we can do symmetric Fink's surgery. Or if there is moderate overaction, we want to do some recession, we can move on to graded recession, which is also pure recession. That is basically given by apt and call. So there is no hyper in primary position. So that is very important to understand. This is through inferior rectus. Now, if you want 8 millimeter, 9 millimeter, 10 millimeter, the whole classification is there. Here we are doing 10 millimeter recession. We are going 4 millimeters inferior to inferior rectus on the lateral side and 2.4 millimeters temporal to this particular point. Now, this is the anterior point of infraoblique, and muscle has to be bunched to prevent any anti-elevation syndrome. When there are large hypers, we can go for either modified iliac Nankin, we can go for Park, or we can go for graded recession if there is if there is a very small hyper in primary position. So basically, when there is a large hyper in primary position, you are trying to bring the eye down and you want to do more and more anterior transposition. You want to do anteriorization of the muscle because it is coming from anterior to posterior. You want to put it as anterior as possible with respect to inferior rectus. So we will not go into the surgeries. Already the bell has rung. So if we want to go even further, we can do iliac and Nankin. This is a new procedure which was described in 2003, 2004. This is basically nasal anteriorization. What we do is we go under the inferior rectus to the nasal point of inferior rectus, 2 millimeter temporal, 2 millimeter inferior. This particular procedure normally we would do bilaterally in DVD patients where we want to intort the globe. I would just go to this is the second last slide. This was one patient, we were doing resurgery. Okay, this is not working. Video is not running. Okay, it is running, I'm sorry. So this was a resurgery. We got the patient, this was resurgery. So before we move on to infraoblique dissection, the infraoblique was visible. So somebody had done a Fink's recession. We can see the lateral rectus is hooked. And this is right 6 millimeters inferior and 6 millimeters posterior to lateral rectus. And this is the whole muscle. We are trying to dissect out the muscle. The surgery was done by a strabismus surgeon. So this was this was I think 3 years post surgery. We are trying to hook the complete muscle. This is normally it is not so clean. A resurgery is normally not so clean, but this was very good surgery done before us by some pediatric ophthalmologist. And so you can see that the infraoblique, we have grabbed the infraoblique. We are trying to separate the adhesions. Once we separate the adhesions, the patient still had residual hyper, so we did anteriorization. We did a total anteriorization of the infraoblique. The important thing is that, once we did that, then we tried to find out whether any posterior fibers of this particular muscle were missing or were left over. And to our surprise, when we tried to dissect it further, we found that there was a full 2 millimeter belly of infraoblique which was remaining or which was probably missed out in the primary surgery. So my point is that it is very, very important that whenever you are doing infraoblique surgeries, you should try to take the whole muscle. It is very, very important. It has been well reported that there could be multiple bellies. The only way to do that is to see that you have to dissect it in the triangle. You have to see that you are actually able to see the sclera once you hook the complete muscle. Now this is the belly I was talking about. There was a small, see this is 2 millimeters which was left over, and we could find it and we could then place it back and do the surgery. So this is very, very important, especially in inferior oblique. And this is the last slide. What is anti-elevation syndrome? It can occur if we overdo our surgery. If we do too much of surgery, it is a co-contraction of inferior oblique because it is an elevator. We have made it a depressor. So when we tell the patient to look up, inferior oblique contracts along with superior rectus, and there's a co-contraction, and the eye is not able to go up. Even in primary position, it will go slightly up, but in adduction, it does not go up. In abduction, it does not go up. In adduction, there is a pseudo-inferior oblique overaction and a reduced palpebral fissure width and a Y pattern. The treatment of anti-elevation syndrome is nasal enterization of inferior oblique. So I think that was very quick, but still I overshooted the time. So thank you so much.
Sure. Thank you, Jitendra. So unlike skin surgery and horizontal muscles, no, inferior oblique surgery, it needs a bit more of expertise and your planning. And being an oblique muscle, you should know, but with their procedure, what are the things that are going to happen to the ocular movements. So your planning should be perfect. And as this last video he showed, no, even in expert hands, no, sometimes problems can occur. So each case, no, you say that you have hooked up the whole muscle, and whatever the surgical work you have done, it's complete. So otherwise, so that even in, as he showed in that video, even in an secondary surgery, since the surgeon was so good, the dissection was rather easy, but you had this thought in mind that you went back and saw that some residual problem was persisting.
Yes.
So thank you, Jitendra.
Thank you so much.
Our next speaker again is Ramesh. Ramesh is now talking on another important thing, nystagmus assessment and management. I think the PGs are here.
Can I have my slides, please? Slides on the... Okay. It's a very huge topic. I'm going to make it in 8 minutes. Just 3 slides. Probably you all can concentrate. It's not simple as you can see here. There is a slow phase and recorrecting. This is what typically happens post-lunch session, and sometimes it can go out of control, you know. There is no there is a very fast recovery phase. Slow phase, but it comes back very fast. This is the similar thing what happened. That's why nystagmus came from the word nodding, right? He just realizes, suddenly he comes back. That's a fast phase. And sometimes in opsoclonus and myoclonus, there is no control. It absolutely goes out of control. So this is similar to what exactly happens in these kind of situations. This is slide number 1. All of you should remember when you assess a case of nystagmus. Visual acuity. There are 2 types of visual acuity. Person's visual acuity, be it in CVI, be it in nystagmus, be it in stroke, be it in anybody having a visual field. What they can do with their both eyes open, with whatever visual field they have, that is person's visual acuity. Eyes is when you close one eye and then check. What is more important in a nystagmus is person's central visual acuity, even if you can have a gaze angle visual acuity, and also near acuity, because we are trying to improve the functional vision of that particular patient. So it's very important to consider. That's why binocular vision estimation in nystagmus is very important, because latent nystagmus can reduce it. Second thing, you can see I think there are 12 things in 4x3 table here. All are very important. Nystagmus evaluation might take around 20 minutes or so in the clinic if you want to really make a difference in the life of that particular patient. I showed you fast phase direction, which direction it goes. And then what is the movement intensity? Is it conjugate like this, or it's like the person who fell, it's completely disconjugate? Whether there is any associated strabismus. What happens to the pursued saccades and vestibulo-ocular reflex? Whether the patient has abnormal head posture, periodic alternating nystagmus, or aperiodic alternating nystagmus. Everything, it takes time. And then what is the effect on gaze? When he looks to the right or to the left or to the up or down, what's the change? What happens when you show a near target? Whether there is a dampening of nystagmus. When you cover one eye, whether there is a latent nystagmus kicking in. This is one more thing which is important. And your typical textbook says frequency and amplitude. Any waveforms, be it your cardiac rhythm or EEG or ERG, amplitude and frequency is very important, and the direction of nystagmus. These many things has to be documented before you proceed what it is. So that's the important slide number 1. This is associated thing. What exactly happens to an infantile nystagmus syndrome? Usually early in infancy, horizontal conjugate nystagmus. Usually they will have a presence of null point. If it is in abnormal head position, they will have that. They can have refractive errors and strabismus. It can be pendular or jerk, decreased amplitude at null point, intensity decreases with sleep and inattention. This is very important. When they are not anxious, maybe when they are facing their professors or when they are answering a viva or an interview, it becomes more intense. So, dampening of convergence. Just want to show you this case. This is a treatment where a vertical transposition of horizontal muscles made this head tilt better in all these 3 patients. What we did, just a horizontal vertical displacement of all horizontal rectus muscle. How to do it? I'll come back to this case description. And like cardiac arrhythmia, it's better to have a ECG for any ectopic beats and things like that. You can't hold a pulse and like a movie, you can't say that this person has heart attack. You can't say that, right? Same way, it's best to have the eye motility recording. But having said that, this is not a must to have if you want to treat nystagmus. This is the slide number 2, which is very important. CIMAS is classification of, it's a working group which worked on classification of eye movement abnormality and strabismus. In 2002, when I was doing my fellowship, it's called congenital sensory, congenital motor. We don't use these words anymore. Either it's infantile nystagmus or peripheral vestibular imbalance, or it can be FMNS, fusional maldevelopment nystagmus. These words, latent nystagmus, is not used anymore. So with the classification system, you have to have that. You can see on yellow, on point number 9, infantile nystagmus syndrome. All of them, congenital motor, sensory, idiopathic nystagmus blockage is called as infantile nystagmus syndrome. And then all of the other things like spasmus nutans, these are all different names what you have. 9 and 10 are the most common nystagmus what we see. And this is the slide number 3. You need to remember. Probably I can share with all of you because the font is very, very less. What are the 9 surgeries you do to reduce the amplitude of nystagmus or frequency, or to correct different types of abnormal head posture or nystagmus with strabismus? This itself will take 20 minutes to explain, so I am skipping this. But if anybody would like to really know, I can send you this 9 operations. This is the essence of nystagmus surgical management. It's pretty nicely done by one of my friend, Dr. Richard Hurtle. He is in Ohio. He's done a fantastic work. I just want to share this case. This patient has ocular motility wise, he has abduction limitation. In the primary position, not so much of esotropia. Esotropia out of proportion to the abduction limitation, it is Duane syndrome unless proved otherwise. He also had nystagmus. He also had retinal dystrophy. Duane syndrome, nystagmus, retinal dystrophy is a rare thing to have, but this patient had it. He is coming with head tilt. Parents wants his head tilt to be corrected. You have options of operating on the horizontal rectus muscles. You have option of operating on the vertical rectus muscle, and you have the option of operating on the oblique muscles. What we did here, you can see this is the tilt, which is a binocular phenomenon. You can see as soon as I patch one eye, this is gone because he is not using it. So this is a binocular phenomenon. So what we did, you have a, superior rectus medial transposition, or this is one of the surgery. What we did in this case, he has this head tilt, right? So this way, right eye is intorted, left eye is extorted. What we have to do is, right eye to be extorted and left eye to be intorted. That's what we want to do. So this is what you want to achieve. That's why I said there are three options to correct. We chose the simplest one. I will not again go into the details. We elevated the right lateral rectus. Again, I'll show you. And infraplaced the right medial rectus. If somebody has a right head tilt, raise the right sided muscle. That is right lateral rectus and left medial rectus. That's a simple way to remember. If somebody has a right head tilt, raise the right sided muscles. That is right lateral rectus and left medial rectus. Same opposite happens to the other eye. So in this case, left medial rectus is elevated and the left lateral rectus is depressed. That way, it can create extortion in the left eye and intorsion in the right eye. This is his post-op appearance. He had a little bit of tilt, and when he came after 2 weeks, this was the result. 6 weeks when he came, this was the result. So just wanted to give one example because of the time factor here. There are surgeries for face turn, which is a little bit simpler according to me. There is surgeries, custom mom, all these for vertical head posture also, chin up and chin down. But do something simple to make their life better. Even in 2022 or 2023, people say nothing can be done to nystagmus. I'm not saying we can do so many things, but we can help to make their life better in at least, I would say, around 60 to 65% of the patients. Maybe a pair of glasses, maybe low vision aids, maybe sometimes surgery like this. There are so many things we can make to improve their quality of life. Thank you so much.
Thank you, Ramesh. There is a very good talk on and very, because no head nodding happened here. So though it's a post-lunch session, no, because it was so interesting. And probably after that initial slides, whoever was planning to node, they decided against. So it was a very nice, because then that's a good message you gave, that many a time, nystagmus, when we say nothing much can be done. That's the first thought that comes to the mind of many. So the fact that something can be done for many with nystagmus, it's really a good message. And thank you for that.
Just wanted to share one thing. When I was a postgraduate, I used to really hesitate to take strabismus cases because I was not so sure to tell the professor what I know. But when a nystagmus used to come, I used to run away. So,
thank you, Ramesh. And the next speaker is Dr. Neelam Pawar from Aravind. So, she is currently senior consultant in pediatric ophthalmology strabismus at Aravind, Tirunelveli. She has a long-term fellowship in IUL and anterior segment, as well as she has a short-term fellowship from overseas. And she's a live webinar faculty. And because nowadays that is the current thing, being a webinar faculty, with Cyber Site New York. Over to you, Neelam.
Thank you, sir, for those kind words, and thank you, the whole team of Sreenethra for inviting me for this session. So I'll be speaking and sharing few cases of advances in transposition surgeries. So transposition surgeries, they are done to improve the limitation to have a diplopia-free field and to expand the binocular visual field. And transposition surgeries are mainly done for the paralytic cases, commonly met cases of 6th cranial nerve palsy, 3rd cranial nerve palsies, and in restrictive cases of Duane's retraction syndrome, monocular elevation defect in large angle exotropia due to INO, or any paralysis because of lost or slipped muscle. So what is the mechanism of actions? According to Rosenbaum's famous Kostenbender lecture, according to him, there is no innervation, plasticity, or no relearning of the transposed muscle, and there is just a transfer of function of the transposed muscle and change in direction of the vector forces. And any vertical rectus transposition creates approximately 7% of shift in the primary position force, and all the VRT done laterally, they are more effective than the VRT done medially, and horizontal rectus transposition, they are more powerful than the vertical rectus transposition. And any augmented procedures with posterior fixation sutures creates the divertification of rectus muscle pulley posteriorly in the direction of the transposition, and it can be evident in preoperative and postoperative MRI pictures that both the pulleys, they are shifted towards the lateral rectus. So most commonly we see 6th nerve palsy in which transposition surgeries are needed. Whenever there is adduction the eye is crossing the midline, we always prefer to do resection, and whenever the eye doesn't crosses the midline and there is no force generation test or very weak force generation test with low saccadic velocities, transposition procedures are preferred. And VRT can be done as double muscle or single muscle, or as a full tendon or partial tendon procedure combined with medial rectus recession or augmentation of Botox or chemodenervation with the Botox to MR, or with various posterior augmentation sutures technique. So in Hammershim in 1907 was first to give the concept of transposition, in which he transposed the lateral half of the superior rectus and inferior rectus to the lateral rectus, and later on Jensen in 1957 he gave the concept that both of the muscle bellies can be reunited around 14 millimeter from the limbus, and then came the concept of augmented Hammershim. In this along with the transposition, 4 mm additional resection can be done, and then double augmentation can be done along with the resection of the transposed muscle with the intermuscular augmentation. And superior rectus transposition, unilateral superior rectus transposition or bilateral, it can be done with medial rectus recession as a full tendon or as a partial VRT. And to enhance the effect, the adjustable cross-section partial VRT can be done, and even Nishida procedure has shown to be effective in treatment of 6th nerve palsy. So a recent paper just again emphasizes the point that modified vertical rectus belly transposition to the lateral rectus, it is more effective than the augmented SRT along with the medial rectus recession for the treatment of chronic 6th nerve palsy. And in a paper by Egberi et al., in which almost 86 articles were discussed, and they came with this table that most of the studies done with partial tendon VRT and along with augmentation like Foster or intermuscular augmentation or resection augmentation, all of them, they created more esotropia correction and enhanced the binocular field. But the problem with all these transposition surgeries are that whenever multiple muscles are involved, there is risk of anterior segment ischemia, and whenever we are planning for medial rectus recession or Botox, it should be done at a later procedure. Success rate varies from 50 to 80%, and it depends upon the residual LR function, duration of deviation, and degree of MR contracture. This is a short video showing the journey of the 6th nerve palsy. So in initial period, we can give the Botox, and later transposition surgeries can be done. So here in this case, the superior rectus is isolated and it is split up to 8 mm, and then the 6 cervical sutures are passed in this lateral half, and then this is disinserted and this half is transposed at the lateral rectus. Similarly, inferior rectus can be divided and is transposed towards the lateral rectus. In augmented Hammersheim procedure, obviously for every case we have to do a pre-op and post-op FDT. And these are the old videos in which previously I used to do the phonic space incision. So here again superior rectus is isolated. It is split up to 9 mm. And here at 4 mm we are passing the 6-vicryl suture. And this lateral half is then transposed towards the lateral rectus muscle, and resection can be done earlier or it can be done after transposing the muscle. So this is the lateral half of the superior rectus, and here I am doing after transposition, resection is done. Similarly, inferior rectus is up to 8 mm, and at 4 mm the 6-vicryl suture are passed. This half is disinserted and it is attached near the lateral rectus, and then that resection is done. So this is augmented Hammersheim, and in double augmentation Hammersheim, so in double augmentation, along with this resection, intermuscular augmentation can be done with non-absorbable sutures at 8 mm. So all these procedures gives usually a diplopia-free period and decrease in the angle of deviation. So this was the case of bilateral traumatic 6th nerve palsy, in which one eye did, you can see obviously very large angle esotropia, and in right eye I did augmented Hammersheim and later on MR recession, and in left eye double augmentation and as a second stage MR recession. So you can see there was nice improvement, cosmetically also good improvement, and diplopia. Patient initially had a large face turn, and post-operatively he is cosmetically good also and with no face turn. So Dr. Velas et al. Has also reported few cases of inferior rectus transposition for the treatment of esotropia and hypertropia. And now coming to third nerve, in third nerve we have to use the lateral rectus power. So there are various transposition procedures initially given by Gogates, in which medial transposition of the split lateral rectus can be done. And all these transposition, they can be enhanced with augmentation or with adjustable sutures. And there's simplified Gogates technique also, and few authors have even reported the splitting of lateral rectus and medial rectus and then reuniting it. So in Gogates technique, the lateral rectus is split into superior and inferior half, and then superior half is passed through the superior rectus and superior oblique complex, and then it is placed near the medial rectus, and inferior half is passed through the inferior rectus and inferior oblique complex, and it is placed near the inferior border of the medial rectus. So this video shows there already I have split the lateral rectus into two halves, and we have to split them around 14 millimeter, and here is the superior rectus, and superior oblique is also we have isolated, and the superior half of the lateral rectus is then passed through this hook, and through this hook we can easily transpose the muscle to the medial side, and before this I am also doing the posterior tenectomy of the superior oblique. So any hypotropia or hypertropia also you can correct, and usually doing PTSO always gives you a better result, and then this transposed this end split end is transposed near the medial rectus. Similarly, inferior rectus is isolated, inferior oblique is also isolated, and inferior half of the split lateral rectus is then brought with the help of the hook towards the medial rectus, and it is attached near the lower border of the medial rectus. So this patient had left eye traumatic third nerve palsy, and I did NTSLR along with PTSO. So you can see there is improvement in the exotropia and improvement in the adduction also. So there are various papers on about the enhancing the effect of this split LR, either by the adjustable technique or along with the augmented fixation sutures. And a recent worldwide paper of NTSLR group has suggested that if you are doing this procedure and if you are placing the ends of the split LR around 3.5 to 4.5 millimeter away from the medial rectus, then you can achieve the good correction also, and complications like choroidal effusion can be lessened. Now we can even do vertical rectus transposition for DRS syndrome, but it is limited only for the patient where we want to improve the abduction ocular alignment, and in case of ESO-DRS, in cases with very severe co-contraction, it is contraindicated. So this paper is by Dr. Kekonia et al. And multiple procedures of superior rectus transposition are described. So augmentation, superior rectus transposition can be done, and augmentation can be done with posterior fixation suture, with suture myopexy, or with multiple augmentation, and Brooks modification, that is resection of the superior rectus before transposition, and then weakening of the medial rectus and resection of lateral rectus can be done. So even in patient in which already we have done unilateral or bilateral medial rectus recession, we can reoperate them for the superior rectus transposition, so to achieve the long-term good motor outcomes. So this was the patient who had, in this photo, the left face turn is not obvious. So patient had left esophagus with 15-degree face turn. And in first stage, FDT was tight, so I did MR recession of 6 millimeter. And 3 months later, I did Brooks modification with superior rectus transposition along with the superior rectus and lateral rectus intermuscular augmentation. So that was muscle sclera and muscle augmentation. And post-op, you can see that there is no esotropia. In initial picture, there is esotropia and abduction limitation. Post-op, there is very minimal esotropia, and abduction limitation has also improved. So Nishida's is also a very good procedure in which there is no split note anatomy technique of transposition. So in risky cases, we can do. So in this case, this was modified Nishida, in which I took 3/4 of the superior rectus and inferior rectus muscle belly and transposed them near to the medial rectus. This was case of exotropia. So both the superior rectus and inferior rectus I transposed at 14 millimeter away from the limbus near to the medial rectus. So this was the case in which I did bilateral modified Nishidas for large angle exotropia and bilateral INO because of dengue fever. And here we can see that this large exotropia, it was cosmetically good, and even the adduction in both sides also, it improved. Now coming to another restrictive pathology of monocular innervation deficiency, whenever there is large amount of hypertropia and when we have to do the NAPS procedure. In original NAPS procedure, we are just shifting the medial rectus and lateral rectus to the superior rectus. But we can again do with various augmented procedures. So in this patient, he had large left eye hypertropia with limitation of elevation both in adduction and abduction. And here we can see the limitation in elevation and in adduction and abduction. And in this patient, I did NAPS with double augmentation. Already inferior rectus recession was done for this patient. So again, we had the risk of anterior segment ischemia. So both the medial rectus and lateral rectus were transposed to superior rectus. And along with it, I did medial rectus resection of 3 millimeter and then did another intermuscular augmentation, augmenting both the superior lateral rectus and medial rectus and superior rectus. So even doing, here the lateral rectus is isolated, superior rectus is also isolated, and medial rectus 3 mm, at 3 mm sutures were placed. And usually I do the resection after transposing the muscle. So medial rectus was transposed to the superior rectus and 3 mm resection was done. And lateral rectus was also shifted, and at 8 mm with oro bond, I did augmentation on both sides. So in large angle hypertropia, we can again combine Nishidas along with inferior rectus recession. And this case, I think it was referred from Sreenethra only. So this patient had a large hypertropia because of blunt trauma, and patient had diplopia and hypertropia since 2 years. And in CT and MRI, we didn't get anything, but on table, I found that only 40% of inferior rectus fibers were there, and patient had 35 prism of R/L. We can see the limitation in dextrodepression and even in levodepression. And diplopia, it was more in dextrodepression. This is 1 week post-op, and at 1 month, patient had almost no hypertropia and improvement in movements in both levo depression and dextro depression. So in this particular patient, I did inverse snap along with double augmentation. And here the inferior rectus fibers, we can see these were the only minimal fibers and rest were the pseudotendon. Medial rectus was isolated and 5.5 mm resection was done, and lateral rectus was also isolated, and they were transposed to the inferior rectus. So that is inverse snap, and along with the intermuscular augmentation with 5-0 oro bond, though it was very difficult, one side only few fibers were there, other side the pseudotendon was there. So these were the cases, and thus with meticulous transposition planning with case by case, we can give good cosmetic correction and good motor function, motor result in this paralytic cases and restrictive cases. Thank you for being with us up to last presentation of the CMI. Thank you.
Thank you, Dr. Neelam. In recent cases of trauma, how long will you wait before taking the patient up for surgery?
Yeah, it depends. If trauma is like recent, even we can take patient recently, because it is always better to explore the muscle, and if any disinsertion is there, it is better. This particular patient, they never presented to us. She came 2 years later, but then also the results were good. So that's why if muscle is lost, then we can do all this transposition surgeries.
Okay. Thank you.
May I request Dr. Sushila B. Nair to present a token of appreciation to Dr. Neelam Pawar.
Sure.
Thank you, ma'am. Inviting Dr. Asha Shivaraman to hand over a token of appreciation to Dr. Sushila B. Nair. May I request Dr. Swapna Nair to present a memento to Dr. V. Sahasranama. Now it's the time for the quiz. This is a very interesting session where a lot of preliminary work was done. I request Dr. Harshali Yadav, Senior Consultant in Vitreoretinal Services, Sreenethra Eye Care, to introduce as well as conduct the quiz session.
So very good afternoon to all of you, and a big thank you for whoever is staying back. Your presence here is so important for the participants. It's an encouragement to all of them. So this postgraduate quiz, like I mentioned, was Dr. Swapna's brainchild, and Dr. Ashad has financed it. We had 21 teams all over from the Kerala, and very thankful to the participants who came from so far and their mentors who encouraged them to come here. The preliminaries were held in the morning as we announced the result, and the top 4 teams here will participate in the finals. I request them to come forward. The finalist teams, Dr. Reshmita, Dr. Sahala, please come forward. Dr. Devi Karthia, Dr. Alan, Dr. Vishnupriya, Dr. Rehana, Dr. Devika, Radhika, come forward and introduce yourself, your institute. let them go ahead with the arrangements. You all come forward. The rest of the postgraduates, please come forward and encourage them, please. So, with my very limited knowledge in ophthalmology, I've tried to be very fair with the questions for all the rounds. I've been blinded as to which team is which, so there is not going to be any bias. In case of ambiguity, trust me, I'm the final word still. So most of the questions are going to be clinical, hopefully help you with your exams. And before we start, I'd like to acknowledge my team members, Ms. Priji and Arvind, who will help me out with the scores and the timing. So let's start with the introduction. Have your seat. Team A, who picked up team A, B, C, D. Okay, A can go there. Okay, A can go there. A, the buzzer for A is that side. B, B is which one? A, B, C, D. That's how the buzzers are placed. Team A, introduce yourself at your introduction and your institute.
I am Dr. Vishnupriya from Little Flower Hospital, Angamali.
Loudly, your answers have to be very clear for me to hear. So, loud, clear, crisp.
I am Dr. Vishnupriya from Little Flower Hospital, Angamali.
I am Dr. Ehna, Little Flower Hospital, Angamali.
They need two separate buzzers. Either connected. I didn't hear the team B. Please go.
I am Dr. Devi Karthia from RIO Trivandrum.
I am Dr. Alan Matthew from RIO Trivandrum.
Alan was one of the participants who won the Teachers of Tomorrow award at the midterm AIOC. Give him a big round of applause. Team.
I am Dr. Rashmita from RIO Trivandrum.
Dr. Sahala from RIO Trivandrum.
I am Dr. Devika from RIO Trivandrum.
I am Dr. Radhika from RIO Trivandrum.
Presenter viewer. Presenter show around there. Okay. Off to your screen. Next slide. Yeah.
It's Dr. Devendra's birthday today. So can we just give him a big hand and some wishes? Happy birthday to you.
Can we start?
കോപ്പി എവിടെ മേഡം? പെൻഡ്രൈവ് വാങ്ങിക്കാം. എവിടെ ഫയലല്ലേ?
അതാണ് ചോദിച്ചത്.
നേരത്തെ നമ്മൾ നോക്കിയപ്പോൾ ഒന്നാണ്.
ഇത് അവിടെ വരണില്ലേ?
അവിടെ വരുന്നുണ്ട്, പക്ഷേ മാഡത്തിൻ്റെ ആൻസർ അടക്കം വരുന്നുണ്ട്.
ഇപ്പൊ നോക്കൂ അവിടെ എന്തെങ്കിലും വരണുണ്ടോ? എനിക്ക് പ്രസന്റേറ്റീവ് വേണ്ട. അവിടെ എന്താണ് വരണത്?
ഇവിടെ വന്ന് ഷോ സ്ക്രീൻ മിററിങ് വന്നു. എന്താണ് അങ്ങോട്ട് വരുന്നത്?
ഇതിൻ്റെ ഡ്യൂപ്ലിക്കേറ്റ് സ്ക്രീനാണ് സെയിം.
അല്ല ഇത് അങ്ങോട്ട് വരണില്ലേ?
വരുന്നുണ്ട് മാം. ഈ സെയിം ഡ്യൂപ്ലിക്കേറ്റ് നമ്മൾ വിൻഡോസിൽ ഡ്യൂപ്ലിക്കേറ്റ് സ്ക്രീൻ പോകില്ലേ, സെയിം.
സോ അത് ഓപ്പൺ ചെയ്താലോ? എന്താണ് വരുന്നത് അവിടെ? ഇത് വരുന്നില്ല.
ആൻസർ ആണ്.
There's a bit of confusion because they can see all the answers in the first slide itself. So, extremely sorry. Dr. Ashad will have to pay all the 4 teams the first place. So, we are taking the time. Sir, you're ready to give all 4 teams first place? you are doing that, we can declare the results.
സേവ് ചെയ്തപ്പോഴത്തേക്ക്
ഏതാ അൺടൈറ്റിൽഡ് അതല്ലേ So let's start. The round one is a pretty simple round. You get a STEM question. There is no passing of questions in any of these rounds. There's no negative marking. That's me being very nice to you all. This is just a warm-up round. 10 marks for each right answer. If you answer both correct, you get 20 marks. And please pardon me if the finger gets pressed and the answer comes around. So let's start. So hypopion is defined as an inflammatory leukocyte exudate that sediments in the dependent part of the AC. Name 2 autoimmune systemic diseases. That's for team A that can cause hypopion. Team A, that's for you. The next question, name a drug that can cause non-infective true hypopion. It has to have a high significance and your time starts now. Timer.
Behçet disease.
Yeah, sorry. Go ahead, you get these marks. Next. We'll have to keep the timing because it's not working. Yeah, and name the drug that can cause a non-infective true hypopion.
Behçet disease. Juvenile idiopathic rheumatomyositis.
Pardon?
JIA.
GIA, okay, more commonly that can cause GIA will present with more of a chronic non-granulomatous. More commonly, if you can. I'll still give you the 5 points for that. Name a drug. Go ahead to the next question. Name the drug that can cause a non-infective true hypopion.
Rifabutin.
Rifabutin. Okay. So, okay, we'll give you your 10 plus 5, 15 points. So, Behçet's disease, HLA-B27 associated anterior uveitis and spondyloarthropathies can cause the autoimmune systemic diseases, and the drug is rifabutin. So, team B, fundus albipunctatus and Oguchis are the types of CSNB with abnormal findings. Name the ERG-based CSNB which have a normal appearing fundus and 2 genetic conditions with negative ERG. Timer. Oh, sound varanilla. Endane? Adu undalla avade. Off aanunda nokku. Sound off.
Hello.
Yeah.
Second question, retinitis pigmentosa.
No. The CSNB types with normal appearing funduses based on the ERG. Okay, your time's over, I think. Yeah. So the answers were Rick's type and the Schubert-Bornstein. The types, the genetic conditions are X-linked retinoschisis, fundus albipunctatus, Oguchis, Battens, and Schubert's. Optic disc coloboma, team C, this is for you. Optic disc coloboma is characterized by sharply delimited, glistening, bowl-shaped excavation. Name 2 systemic associations with optic disc coloboma and abnormality over what stage of embryogenesis leads to this condition. That's your time up.
Embryonic fusion of embryonic fissure. Second question.
Yeah. Tell me clearly, no? Tell the answer. I just heard embryonic closure. Any associations? Can we have some third umpires in the round, in the audience who can tell whether we can give?
Golden hair.
Okay, so PAX gene mutations, papillorenal, golden hair, she said, so we'll give her those 5 points because we'd asked for 2. And she did answer this incompletely, so maybe we'll give them 5 plus 5, 10. Okay? That's me being generous. Okay? Team D. Pellucid marginal degeneration is a term where pellucid means the corneal clarity was maintained despite the ectasia. You need to tell me what is the type of astigmatism that we commonly see and 2 patterns seen on corneal topography.
Corneal topography, we get crab claw pattern.
Pardon?
Crab claw pattern topography. Against the rule astigmatism.
Pardon?
Against the rule astigmatism. Against the rule astigmatism.
Correct. So against the rule astigmatism, crab claw. I think you answered only crab claw. So 5. 10 plus 5. Is that all okay? So next is a Hall of Fame. So we'll show you a personality and you need to identify the personality as well as give his contribution to ophthalmology. So if you identify the personality just by the photograph, you get 10 points. If you name the contributions along with it, you get 20 points. But if you cannot identify, then we'll give you the contribution, but then you get only 5 points. You get 10 seconds for the same and there's no negative marking. Okay, Team A, this one's for you. Team A.
Muller. Muller.
Pioneered the development of shunt implant.
Ahmad.
Okay, so you don't get any points for the same. It's Dr. Anthony Multino. Team B, we come to you. This is for you. Yep. No. So I'll give you his contributions. His most notable achievement was the Boston keratoprosthesis. So these are the giants whose shoulders ophthalmology stands on. Yeah? No? This is Dr. Clay Stolman and father of modern corneal science. Team C, we're coming to you. No? So we'll give you a clue. He's the one who performed the first pars plana vitrectomy.
Macmer.
Yeah.
Macmer.
So you get 5 points. Dr. Robert Mackimer, father of modern retinal surgery. Team D. No? So I give you the clue, he performed the first intra-arterial chemotherapy. But then at that time it was just puncturing the ICA. No? Okay. Dr. Algernon Rees, so the Rees-Ellsworth classification. So in this round, I think only Team C has scored 5 points. Yeah? Are we okay with that? So we're moving to the next round, that is implants in ophthalmology. Okay? So you identify the implant with its name. If you can't identify the implant, we'll give you its anatomical position, how it is placed. But then if you identify, you get only 5 points. Okay? Again, no negative points. Should we go? Team A. This is for you.
Mini monocle.
Mini monocle stand. So they've answered correctly, they get their full points. Okay, so mini monocle used for the canalicular lacerations. So now we're going to team B. It okay. No? Okay, these are the orbital implants for fracture floor, fracture for the orbital walls. And this is a composite one with the titanium as well as the porous polyethylene. Okay. So now we go to team C.
Hydrous.
You want to see the clue?
Malfusion.
You're close to it. It does the same function. I think time's up. We'll go ahead. Okay, so the Canabrava ring, more for the coloboma eyes because that thing fits into even in the absence of iris. So team D, we come to you.
Keratoprosthesis.
No. We'll give you a clue. That's how it looks after it's implanted. Okay, we'll go.
Molteno.
Eh?
Molteno implant.
What
Tube.
implant?
Molteno tube.
No. So this is the ranibizumab port delivery system, the SUSWIMO, which just works for around 6 months. They don't need to take the injections. You just refill the reservoir. Withdrawn for some time. So now we come to instruments in ophthalmology. This is more based for the postgraduates for the OSCE, but be careful when you just tell me the first one or the second one. Look at it very carefully. It won't be as simple as it looks like. Okay. So you get 10 points for the correct answer and 10 seconds for the same. No negative marking. Team A, this comes to you. If you can tell me the name along with the instrument, it will be perfect.
Calcium clamp. Calcium clamp.
That's what I told you. Look at it carefully before you tell me it's Calcium. Okay. It's the corneal graft holding forceps, the dasturs. Now we're coming to the scores. Scores are being handed. So now we are coming to team B.
Globe suction forceps.
Not for suctioning, to pushing, to push something,
The
not to
orbital
pull.
implant.
What is it? I don't think we can give you with that. Okay. So it's the sphere holder and the introducer, especially when you're implanting the orbital implant for pre-illustration. Team C.
Punctum dilator.
It's a lacrimal probe. So, Team D, no points for that. Team D, we come to you.
Iris holding forceps.
No, see it's a muscle clamp for all the forceps. Okay. So let's quickly go down to the next round. That is, we'll show you a 2-minute small clip of a video, the important steps of that particular surgery. It's not a routinely done surgery. You need to identify the procedure. 10 marks for identifying the procedure. Your timer starts 10 seconds after the clip ends. Team A, this for you.
Sclerotomy making for scleral
Don't
buckling.
be in a hurry. You look at the whole thing.
Okay.
Don't be in a hurry to answer. See the whole thing. You have 30 seconds even after the clip ends. So he did that. He's going to do that in all 4 quadrants. Why do you think he's doing that? I'm not asking the audience because they're I would make a fool of myself. Yeah, Team A. Yeah, that's the end of the clip. Can you tell me timer for 30 seconds? Yeah, 30 seconds. No. So, do you know what he did? He made partial thickness scleral flaps in all 4 quadrants. Why? Okay, so this was partial thickness sclerectomy for uveal effusion syndrome and nanophthalmos. Okay. So now we are going to Team B. The surgeons have been acknowledged in the slides. Maybe that can be a clue.
madam, slit.
Correct. So they've answered correctly. Okay, team C. Sorry. Okay, I think we won't give this. You all saw the answers, right? Still, would you like to tell us about the... Can you explain? Then maybe we know you knew. You know what happened? What procedure? You must have at least seen what came up, right? Say.
External cyclodialysis.
So what happened? What was the procedure? If you answer, then maybe we'll consider giving, yeah? Okay. Third umpires, what should I do? Let's come back to it a little later. Okay, to decide whether you get these points or no. Okay? So this is for the cleft closure, the external ab externa through these transscleral. Now coming to the team D. What was the procedure?
Mullerectomy.
No?
Mullerectomy.
It was the optic nerve sheath fenestration. So now we'll come to the sixth round. Here you will be shown the ocular manifestations of a systemic disease. So you have to identify, like if you identify it with one presentation itself, you get 30 marks. If you want to see the second presentation of that disease, 20, and third, 10. Okay, so your time starts from the first image itself. So if you're not sure what the systemic, I'm looking at the systemic disease. So if you're not sure, you ask for the second clue in the beginning itself. Don't waste your time, okay? Team A. Tell me if you want the second clue.
Second clue.
I am looking at the systemic disease.
That clue. HIV. HIV.
HIV, correct. Can you tell me they get points after 3 clues? HIV, they answered correctly. So tell me all the manifestations.
CMV retinitis.
Loudly, yeah.
CMV retinitis.
Next. Correct.
Kaposi sarcoma.
Correct.
Molluscum contagious.
So they have identified the systemic disease, which is what we were looking for, though they took the 3 clues. Now we are coming to the team B.
Neurofibromatosis type 1.
So they've answered with 2 clues. Very nice. Leash nodules. Now we are coming to team C. Time's up.
Candida.
No. Your time's up.
Cytomegalovirus.
No. So this is lupus, retinopathy and vasculitis. The keratoconjunctivitis sicca and scleritis. Can you now, do you still want to tell me the systemic disease? SLE. I think, okay. Now we'll go on to team D.
Sarcoidosis.
Do you want another clue?
Next clue.
Tuberculosis. Tuberculosis.
Yeah, so they've identified with the 3 clues. So now the round 7 is you'll be given a clinical photograph. If you cannot identify, we'll give you one diagnostic investigation. If you still cannot identify, another diagnostic investigations. Okay? So let's start team A. This is the right eye and that is the left eye.
And the next clue.
Tell me quickly if you want another clue.
Another clue.
Yeah? I'll give you another clue, but no more points. The pinpoint leakage on FFA, contralateral eye having trauma, subfoveal detachment with a basilarity detachment.
Sympathetic ophthalmologist.
Sympathetic ophthalmologist. But you don't get any points. Okay. Now team B. 14-year-old post-blunt trauma.
Next clue, madam. Next clue, madam.
Blowout fracture. So they've identified after the third clue. So wide-eyed orbital blowout in children. Okay. Now team C. Look at the B scan. What is happening on the B scan? It is shadowing. Osteoma. But your time's up, so you won't get the points, but the answer is correct. Okay, so it's a osteoma. Okay? Team D.
Next clue. Next clue. Keratoglobus.
Keratoglobus after third clue. Very good. So, so next, we are going to rapid fire, but rapid fire will be based on the subspecialty. So my team members will come forward and give you, will ask you to pick up. So you'll blindly pick up the specialty and let me know which one. So as of now, the scores are Team A 35, Team B 40, Team C 15 and Team D 20. So as of now, Team B is leading with 40. That is Dr. Devi and Dr. Allen. Okay? Something is wrong? Yeah, 1 minute, even I'm. Okay, in the meantime, we'll pick up the lots. I'll sort it out. Anila, can you just... So the Team A and Team D are at 35, Team B is at 40, Team C at 15. Glaucoma. Can we start? Can we start the screen? Okay. So 10 questions, you get a minute. If you don't know, pass. If you know, you answer. You get a -5 if you give me a wrong answer. Okay, so let's start. Name the anti-glaucoma drug that causes apnea in infants.
Alpha 2 agonists.
What are glaucoma flaken?
Anterior subcapsular opacities in angle.
Sickle-shaped extension of the blind spot is called.
Serous coating.
Eagle trial compared safety and efficacy of laser PI with which modality?
Clear lens extraction.
Pardon?
Clear lens extraction.
Glycomethocyclitic crisis is also known as?
Posner-Schwarzman syndrome.
Name the gene most commonly affected in juvenile open-angle glaucoma.
Pass.
Mode of inheritance of most Axenfeld-Rieger syndromes.
Autosomal recessive.
What is Zenmeyer's ring?
Pigment seen in the posterior lens capsule.
Sonolar fibers in pigment dispersion syndrome.
Which modality allows to best visualize ciliary body and ciliary process?
UVM.
Me or the students? Okay. So, for this round? For this round, you are yet to go. Okay. You said alpha brimonidine, then glaucom flecken you answered correctly, sickle shaped you answered CTILS you answered. Lens extraction, she answered. Glaucometrocyclitic crisis, she answered. 6, you didn't answer, you passed. Mode of inheritance, you said wrong, so you are going to get -5 for that. Zenmeyer's ring, yes, she answered. And 9 also she answered. 10, we didn't reach. So how much is the score? 55. Is that okay? Very nice. Now we are going to cornea. Cornea? Okay. Can we start? Normal endothelial cell count at birth is?
60,000.
Okay. Composition deposits in the spheroidal degeneration?
Lipid. Lipid.
Contact lens of choice in keratoconus is?
Rigid.
Loudly.
Rigid gas permeable contact lens.
Okay. Protozoa that causes infectious keratitis in healthy contact lens?
Acanthamoeba.
Very good. Lifitegrast approved for dry eye disease belongs to?
Pass.
Past. What does Cadorous line represent?
Endothelial rejection line.
Correct. Scleromalacia perfringens occurs more commonly with?
Rheumatoid arthritis.
Correct. Preferred drugs in medical management of pythium keratitis?
Pass, ma'am.
Passed. What is the most common causative agent for?
Bartonella Hensley.
Correct. Common method for quantification of corneal sensation?
Ischiometer.
Name?
Cockett-Bonnet.
Ischiometer.
Correct. So they answered the normal endothelial cell count. They answered correctly. Second was wrong. They said lipids. Third was correct. Fourth, they answered correctly. Fifth, they passed. Sixth was answered correctly. Seventh was answered correctly. Eighth was passed. Ninth was answered correctly. And 10th was answered correctly. So they get 70. Okay? Is that all right? Next, the retina. Cotton wool spots represent dash pathology.
Nerve fiber layer infarct.
Correct. As the Scintillation albicans is composed of chemical composition.
Calcium.
And
Calcium pyrophosphate.
most common mutations in typical Stargardt disease involve?
ABCA4G.
Very good. Luxturna is FDA approved for?
Pass.
Retinal hemangioblastomas may be presenting feature of?
Von Hippel lymphocyte.
Correct. Vaginous granulomatosis is now?
Granulomatosis with polyangiitis.
Very good. Dash should be ruled out in any non-responding intermediate uveitis in an elderly patient.
Malignancy.
Which one? I'll still give you. Rods have maximum densities 12 degrees away from fovea. True or false?
False.
Wrong. In type 3 macular neovascularization, the pathologic vessels originate from?
Deep.
Deep. Okay, we'll give you that. Trilateral retinoblastoma refers to? But you won't get the marks for that. So they answered cotton wool spots correctly. That is asteroid hyalosis, calcium, they answered. Mutations associated with Stargardt's, they answered. Luxturna, they passed. Von Hippel-Lindau was correctly answered. Sixth was correctly answered. Seventh, they said malignancy, I'll still give it to them. It was retinal lymphoma. Eighth, they said false and they get -5 for that. Ninth, they answered correctly. So the scores are? Is that okay? 65. Okay? Now we move on to the Fourth, neuro-ophthalm. Visual defects associated with Leber's hereditary optic atrophy, common one.
Central and central.
Correct. Damage to the Meyer's loop causes what type of homonymous defect? God. Bellin syndrome is caused by lesion in which anatomical pathway?
Next question.
Dash drug used in the treatment of multiple sclerosis associated with macular edema.
Pass.
Heavy eye syndrome is characterized by what squint?
Pass.
Past. Isolated dilated pupil that reacts to near better than light is from? What's the pupillary abnormality?
Robertson pupil.
Temporal crescent or the half moon syndrome is caused by lesion at the which anatomical site? Herpes zoster affecting the 7th cranial nerve.
Ramsey.
Correct. Most common cause of Alice in the Wonderland syndrome in adults. Area post-tremor symptoms.
Vomiting. Autonomic symptoms.
Okay. Central, they correctly answered. Damage to Meyer's loop, you said inferior, right? So they lose -5 for that. Balance, they passed. Fourth, they passed. Fifth, they passed. Sixth, you said Argyle Robertson, so -5. Seventh, you passed, isn't it? Seventh, you passed. Eighth is correct. Ninth, you passed. So, points. So the combined score is 10. Okay. So now we come to the final buzzer round. So each slide has a question. The team which presses the buzzer first gets the chance to answer. 20 marks if you answer correctly, -10 if you give the wrong answer. You should answer within the 30 seconds or you lose your turn and you get negative marks.
Madam.
The last point, it doesn't go ahead to the next.
Madam, marks calculation.
There's some problem. About which?
Hello.
Pardon? Results.
This round.
You're asking for the updated marks, or you have a problem with the marks which were calculated?
We made 2 passes and 1 wrong. I think 8 team also made the same thing. But the hello.
But we did confirm, right, for each. Okay. Anila, can you correct the... Yours was glaucoma, right?
We did for glaucoma, madam. We missed 2, made 1 wrong. Team D, madam.
the meantime, can we just go ahead to the buzzer round? So your plus, the 10 marks are on hold. So that will sort out. They're doing the... So you'll have to press the buzzer. This is the buzzer round. The last thing doesn't hold because they can give only one buzzer. I mean, the first person who presses only. It doesn't pass. Okay? Is that sorted out? Should we go? Ready? Name the sign and the condition. Yeah. Nobody pressed the buzzer? The team 2 pressed. Team B pressed.
Kogan's lit with sign.
Correct. So, very nice. Seen in? Myasthenia gravis. So, the twitching which is seen when she looks in the upgaze and on returning to the primary is the Kogan's lid twitch. That mild flutter which you see. Okay. You all press the... Now we're coming to the next one. Name the sign and the condition. Team 2 pressed. Yeah? Team 2 pressed.
The oil droplet reflects in keratoconus.
Very good. Next, name the lid, a specific lid sign that you're seeing. Name the specific lid sign that you're seeing. Nobody? Okay, time's up. So the pseudographies of the fugue sign in the aberrant third nerve. Okay, the retraction, let's quickly finish. Name the implant. Nobody's pressing the buzzer. Nobody? So the bimatoprost implant, Urista. Name the genetic condition which shows this OCT picture. 3 pressed? Yeah.
Retinoschisis.
Retinoschisis.
X-linked juvenile.
Very good. So they get the marks. Next. So a hypertensive who comes with a sudden loss of vision, and this is what you're seeing. I want the sign which is marked with these green lines in the clinical picture and the red lines in the FFA.
Cigarette streaks. Cigarette streaks.
Who? You didn't press the buzzer. No, I think, okay, your buzzer was not pressed. 2.
Seagri streaks.
Nope. So you lose marks. These are the amalgamic signs, large patches. Again, choroidal ischemia with these large triangular patches. Next, and the last question. Identify and give its use. Nobody's pressing the button. Okay. The Begolini filter bar. So with that, we come to the first end. Let me see the scores. You get those 10 points for that. Dr. Asha, Dr. Swapna want to say anything by the time we calculate the scores? Please. I'll need some 5 minutes till we calculate the scores.
I hope you guys have your mic with you. Do you? You still have? Okay, I have your mic. I'll give it back to you. So we would just like to know what your hobbies are outside of ophthalmology. What about, yeah, you can start. Outside of ophthalmology, yeah. So do you do anything specific like swimming, cycling, cooking? Cooking? Yeah, good. This is not a quiz question, by the way. You don't get any marks for it, but we get to know you better. Yeah, and
Recently, my main hobby is to teach my daughter dancing and all. For
okay.
many competitions.
How small is she?
LKG only, ma'am.
Okay. And doctor?
I like to write, madam.
What do you write?
Poems.
Okay. Is there anything you'd like to recite for us?
No.
No, it could be anything. Something very short. Please.
No, madam.
Madam, I like to read, madam.
Uh-huh.
I read a lot of novels and fictions.
Okay. So do you like fiction more or do you like non-fiction?
Presently, I'm reading a book on history.
Uh-huh.
It keeps changing.
Okay. Do you write something yourself?
No, I don't.
Yeah.
Watching movies.
Okay. That's good. We can all resonate with that. What's the latest you watched? Anything? Any suggestions for us? Yeah. What about you?
I'll be playing with my kid on my free time.
Yeah, I know it's hard to get free time. How old is the child?
4-year-old. I like listening to music and going for short trips or travel.
Okay. Do you sing? Do you sing?
No.
We're not going to make you sing a song, but still.
No.
And do you trek? I mean, short trips means trekking or do you go for...
Not trekking, just like exploring.
Okay.
And my hobby is just sleeping.
I'd
like to sleep a lot.
Okay, that's also rare to find. But it's even rarer to get someone who admits to that. Anyway, that's good. Any one of you into martial arts? Or are you all very gentle and nice? Okay. Anyone into cycling, jogging, running, sports activities?
Jogging, maybe I would like to go to gym.
Okay. Please note, Ramesh. This is our future.
We have one person who is very much interested in martial arts. This is a quiz question. Can anybody answer?
I think
100 marks. She is into all street fight kind of gymnastics and all. And one day she came to OP with her legs cramped, and she said she was in a fight the other day. So that's why ma'am was asking. Meanwhile, I have a little hobby which I was telling Dr. Ramesh in between. I'm a filmmaker. Happened to become a filmmaker because of the kind of activity she was telling. She used to write. I also used to write, and I also used to read a lot when I was doing my schooling. But after that, after the medicine times, you never read anything other than medical books. So that happened. So, I think I got a state award for a best director in Kerala for a television award in 2019, and my movie is getting released. A commercial movie in Malayalam is getting released this March 31st. All over Kerala. Maybe in Middle East too, by March 31st. The name of the movie is Laika. Laika is the first dog which went to space. Yeah, it's a comedy thriller, and I can show you little bits. The advertising has not yet been started. I can show you. I can show you a little bit of trailer kind of thing in 3 minutes time. And it's an unofficial release. The producers may sue me if I show in public platform, but being a private meeting, I can show it. That will get released in another 2 weeks time. Thank you. Inviting you to all watch in theaters by March 31st.
Dr. Asha, we have a tie.
Tie? You have a tie?
Yes,
Great.
and you're going to pay 2 teams.
Okay. Tie.
Okay, so what we'll do is we have got 4 tiebreakers.
No, there was a differences of opinion regarding their mark.
No, that was sorted out.
It was sorted out.
Yeah,
Okay.
that was sorted out. So we have a tie between 3 teams. So A, C, and D. So what we'll do is we'll give them more 3 questions. If they still get a tie there, we'll score them based on their morning MCQs. We'll give you 4 more questions now. If still there happens to be a tie after that, we'll go with the morning highest score, second score. Okay? Is that acceptable? So we are now coming to the mic. Please give them the mic. Please press the buzzers. Don't sit tight because you're in the safe space. Okay? Okay? We are going to the buzzer round. So both are the field effects that are associated with lesions in the LGB. Match which A and 1 and B and 2, you need to match based on which vessel gets occluded. Please press the buzzer.
First, A, madam.
Who's pressing the buzzer? Nobody pressed the buzzer. One pressed, yeah. Yeah, tell me.
A, left lateral choroidal artery ischemia.
A goes with what?
2.
Very good. And B goes with 1.
With 1.
Excellent. So they get 20 marks. 20 marks for team A. Now we're going to the next question. You need to tell me the artifact which you're seeing with the white arrow. There are white arrows on the OCT there. You need to tell me the artifact. Yeah, team 4 or team D.
Shouldering.
Pardon?
Shouldering effect.
Shoulder.
Shouldering.
Now, what is the name of this artifact? You lose 10 marks. Mirror image artifact in the OCT, especially seen in the high myopes. So the team D has lost 10 marks, and from the first question, team A has got 20. Okay. The last question. What could be the causes of the pseudo doubling of the ONH shadow? What could be the causes of the pseudo doubling of the ONH shadow? 3.
Air.
Wrong. So you lose 10 marks. So either it can be foreign body in the ocular codes or a maculochoroidal osteoma. I think we should conclude while we have a best winner. Yeah? So can we have the results? So I'm going to give you all one question between the two. The position is that we have a clear first winner. That is Little Flower Angamali. That is a clear first winner. Now we have a tie for the second place. We can end it here if you're going to pay both of them. If not, I'll go for the second question. One single question they need to answer. If neither decides to answer, then we'll score them from the morning scores. Who scored highest amongst them will be the second runner-up. Okay, so I'm giving you all the next question. This is between team C and D. What is the current accepted method to treat the persistent vitreous seeds in retinoblastoma? Yes, team D.
Intravitreal melphalan.
Very good. So we have a clear second winner. Intravitreal chemotherapy, melphalan or tepotican, or the combination. Very good. So the winner is, the first winner is team A, second winner is team D, third in position is team C, and fourth is team D. Very good. Thank you all. So now I invite all the participants, please come forward. So Dr. Ramesh Kekunia, so we would like you to give the award to the first prize winner, and ma'am, so left, Dr. Angamali gets the first place. Dr. Vishnu Priya, Dr.
Your names? Rahana. And so Rahana and Vishnu Priya are getting the first prize. Ashali, please. Second prize winners, team D. Your names, please. They are very soft-spoken. Radhika and Devika. Both are Radhika and Devika. Okay. So congratulations to you, sir. No, please. Thank you, sir. So, we congratulate Dr. Harshali for making such a wonderful quiz program. We were really struggling hard to get an answer sitting over there in the crowd. I could see even the senior consultants were struggling to find answer. I don't know how you got such kind of difficult questions. Is it available in ophthalmology, such questions?
I was so scared of you because he told me, don't embarrass me in front of everybody by giving very easy questions. So I studied hard.
Thank you. We have a special gift to Dr. Harshali. I request Dr. Swapna to hand over the gift to Dr. Harshali. No, this is very important because you have done a wonderful job. So, with that, we come to the end of this program, right? Nothing. So, thank you all for being there. I request my team members to stay back for a small meeting. Thank you all. Bye.
ഒരു സിംഹത്തെ പോലെ റഷ്യയിൽ കഴിയേണ്ടിയിരുന്ന ഞാൻ ഒരു വർഷോപ്പുകാരന്റെ വീട്ടിൽ.
ഒന്ന് തുടങ്ങിയിട്ട് പറഞ്ഞിട്ടുണ്ട്. അപ്പം അത് ജസ്റ്റ് അത് കാണിക്കാവേ. ലോ റെസൊല്യൂഷനാണ്. ബിഗിനിങ് ഇങ്ങടാവോ? ഓക്കെ, റെഡി? തുടക്കത്തിൽ നിന്നാണോ?
ഒരു സിംഹത്തെ പോലെ റഷ്യയിൽ കഴിയേണ്ടിയിരുന്ന ഞാൻ ഒരു വർഷോപ്പുകാരന്റെ വീട്ടിൽ.
ഈ റോക്കറ്റ് അയക്കാൻ വേണ്ടി വെച്ചിരിക്കണതാ.
ഇത് ഡമ്മിയാണ് സാറേ. മാങ്ങാച്ചാറ വീട്ടിൽ നിന്ന് ഉണ്ടാക്കിക്കൊണ്ടുവന്നതാ. ജയിച്ചു പോടാ. പോയി മറ്റേ കേസിൽ ചാടിയാ വെച്ചാപ്പൊന്നും ഏറ്റില്ലല്ലോ.
അണ്ണാ വല്ല നടന്നു.
അവൻ എന്നെ പെർമിഷൻ ഇല്ലാതെ ഉമ്മ വെച്ചു.
അറിവുള്ളവനാണ്, സമ്മതിച്ചു. എന്നാലും കണ്ടവനെ കാൽ പിടിക്കാത്തിരിക്കും.
സ്വന്തം വാഗുകൊണ്ട് സ്വയം നശിക്കും.